Welcome to the 2020 Colloquium of the Drexel Creative Arts Therapy and Counseling Program. My name is Dawn Morningstar, and I'm a faculty member and a dance movement therapist, and with me today is Janika Griffin, who I'll say more about in a minute. Today, we celebrate the 2020 graduates and the projects that they've worked on for the past 6 months. It's been a challenging year for all of our students due to COVID-19 and the social unrest regarding racial injustices in this country, particularly against Black people. No student was able to finish their internship in person. Many were able to continue through virtual means, and some had to end suddenly and did not get to say goodbye in the ways they had hoped. There have been many losses and much grieving during this term. However, today is a time to celebrate all the presenters and their hard work and passions. We have the opportunity to share in their final projects, which are creative and varied, as you will soon see. As a result of COVID-19, we've had to shift to remote teaching and learning. And as a result, the students and faculty have had to be creative in how they deliver and receive material. Today, I'm going to offer a movement experiences prior to each module, and I'll invite you to use this time to help you focus your body and attention to what you'll be seeing on the screen. As creative arts therapists and counselors, we all offer some kind of a warm-up or way to welcome clients into the therapeutic space, assess their needs, and set intentions or goals. This term, during a dance movement therapy supervision class, the faculty asked students to lead warm-ups to the whole entire class. Although teletherapy has been around for a while, it's not something that we often offer as creative arts therapists, so it's a growing edge for us all. Janika Griffin, who's with me today, is a first-year dance movement therapy and counseling student. She led an intriguing and creative warm-up for class. She used the medium of Zoom, the screen, to orient and also help the class feel more embodied and connected. Since we'll be sharing a lot of screen time today, I asked her to share her warm-up with us. I invite you to join this and all other movement experiences at your own comfort level. You may sit, stand, or just listen and imagine. There's no right and wrong when engaging in movement. So without further ado, Janika, it's all you.
Hi, good morning, everybody. And like Dawn said, my name is Janika Griffin. I'm a first-year dance movement therapy student, and I hope you all are doing and moving well in spite of the climate that we're living in right now. And this is a time more than ever that we get to think about the people and the communities that frame and shape us, and that we too get to frame and shape. And so I want to lead you guys in a movement exercise around framing our space here virtually to get you oriented to this wonderful day today and the wonderful presentations that we're going to watch later on today. So, all right, so let's take our positions. You can either stand or sit like me. I'll use my Zoom window as my frame, and I see that Dawn is going to use her space to shape her movements. So what we're going to do is play with these our boundaries, this frame that we're in, to create shapes, to express, to present ourselves today, to listen, to be in tune with our bodies. And so just imagine what your frame looks like. Where is the boundary of your frame? Let's explore that by moving and exploring the height, even the depth of your frame, the left or the right. I'll try to remain in my frame. How far can you walk from one end to the other? I can't walk in mine, but I could like shift my body weight here. Shifts of the torso. How deep can you stretch? I can't stretch in mine, but I'm making some shapes. What kind of shapes are you guys making in your frame? What are you presenting today? What kind of mood? What word is coming to you as you're presenting and shaping your picture? Can you reach? How far can you reach in your frame? What kind of lines can you make? What story are you telling today? What's your story today as you listen to the presenter? And what's your approach to your edges? Is it a slow approach? Are you approaching using your whole body, or is it just the hands? Is it even hard to stay in your frame? Is your frame a little bit more narrow like mine, or is it expansive like Dawn's, where you get to stretch and move and wiggle your toes, your arms, your legs, and have everything be activated? Is your frame only big enough to capture your hands? And what other shapes can you make with your hands as you're framing them? And what mood is your frame giving? A happy one, surprised one, an excited one for all those graduates ready to move on and expand into their careers? And again, what does your picture say today? As we honor the graduates, and as the graduates receive our honor, sending honor their way, sending a congratulations their way. So I hope this movement exercise reminds you to move as we're watching the presentations today. Let's pay attention to what our bodies need, how our bodies want to respond to the information that we're receiving today. Alrighty, and so I'll pass it over to Dawn, who will lead us in the second part of this warm-up.
Thank you, Janika. I'm gonna take it back. Oh, that felt really good to move. So as Janika said, I'd like you to take time during the presentations, after the presentations, to really embody what you're hearing today and see how it resonates with you on a body level. You know, do you feel it in your stomach? Are you really thinking about some things? Do you feel it in your shoulders? Are you feeling tense or more relaxed? You know, where is it living in your body as we move through? And for health purposes, we're going to be sitting looking at the screen for a lot of the day. So what are some things we can do to sort of get our bodies ready? So some suggestions that I have for you would be leaning side to side. We don't want to get Zoom neck. Sometimes we get stuck in a Zoom frame. So as Janika's doing beautifully, like rolling your head is a good option. Eat both directions. Rolling your shoulders is also another option. Yeah, mobilizing that sort of upper body. I also think actual stretching could do really nicely, really stretching your sides out in different ways. I also want you to invite you to sort of, if you need to look away from the screen for a minute, or you need to get up and watch from a standing place, that's fine too. We're going to be spending a lot of time here today. And we really are here to honor and support the graduates. So we'll get a chance to do some movement all together at the end of our program. And like I said in the beginning, if you're just joining us, welcome. We will be doing little movement introductions before each section of the program, each module, and to get us hopefully focused and able to attend for the length of time. In addition, I know we're going to hear this again. We're going to want to hear questions from you, see how it lives in your body, see how you're responding in your soma to what's going on. So we'll be starting in about 5 minutes or so. So while we're waiting, go grab a cup of water, go grab a snack or two, get yourself all cozy if you're in a seat, if you're standing. Do a little more movement if you want to shake or wiggle it out. So we're going to put up a slide and we're going to get started very soon. Thank you for joining us and enjoy the day.
Go.
Good morning, and a warm welcome to everyone joining us here today. I am Sherry Goodill, Chair of the Department of Creative Arts Therapies. Before moving into our program, we wish to observe a moment of silence. And during this year's 2020 Creative Arts Therapy Colloquium activities, to further emphasize the commitment of our department to social justice issues, as well as to honor and to remember the Black lives lost to police brutality now and previously. I invite you now to join us in a full minute of silence. And I invite you now to bring your focus back to the screen and to formally begin our program with a hearty congratulations to our Creative Arts Therapies grads. And with a heart full of gratitude, I want to recognize the Creative Arts Therapy Department faculty and professional staff for their brilliance, their sweat, for their mentoring of fine new therapists and researchers, for their esprit de corps and camaraderie. They are, in alphabetical order by last name, Associate Clinical Professor Yasmin Awas, who was here at Drexel up through the past winter quarter. Professor Yoka Brat, Associate Clinical Professor Natalie Carlton, Associate Clinical Professor Christina Devereaux, Assistant Clinical Professor Abby Dougherty, Admissions Coordinator Cade Haskins, Assistant Clinical Professor Scott Horowitz, Associate Clinical Professor Flossie Irardi, Associate Professor Garija Kamal, Assistant Clinical Professor Dawn Morningstar, Program Coordinator Kristen Noreen, Associate Clinical Professor Michelle Rattigan, Assistant Research Professor Minjung Shin, and as a collective, our many dedicated adjunct faculty members and field supervisors. It is my honor to offer a few thoughts to our outgoing students. Beginning with, and on behalf of the Creative Arts Therapy faculty and staff, welcome to your counseling and creative arts therapies careers. It has been a journey indeed, parts of which you expected when you enrolled, parts that none of us imagined. Everyone has adapted, coped, connected, learned, and grown in their own ways. And this ability to shape-shift and creatively reconstruct is itself a professional skill that you all will need and use during your careers in a fast-changing healthcare system. You each found your flow. And especially in this last term, use your creativity to face many unknowns and stressors. And here you are, finishing strong. When you started the program, I brought up the idea of liminality, about places and times in life that are thresholds, borderlands, edges, when we are betwixt and between, in the misty, ambiguous places that accompany any process of true growth and change. To be a student is to be in a liminal phase. And now you are crossing a threshold into your career when even our society is perhaps, hopefully, in a liminal phase, perhaps even a sea change, and you are ready. We know that the powerful, supportive relationships you have made with each other will carry you into and through your careers, and that is something to be celebrated and cherished. We also know you will continue in your impassioned and vital work as social justice advocates, standing up and speaking up for clients' rights and against the stigma, inequities, and systemic barriers to optimal behavioral health care. On your journeys these last 2 years, you have come to know, serve, and have learned much from countless people in your clinical and community settings. I'm talking, of course, about your clients, patients, students, project participants, and collaborators. Let us honor and hold these folks in our awareness today, for they are truly what it's all about, and to whom you've made your professional commitments. To conclude, I wish to acknowledge and thank all of you here listening and witnessing today as guests, loved ones, partners, family members, and friends who have supported our students as they navigated the sometimes rough waters of grad school. You have buoyed them through. Can you feel their applause and gratitude resounding through cyberspace right now? I think I can. Without further ado, we move into the program for the day. This innovative 7+ hour digital event and celebration is led by Dr. Natalie Carlton and Dr. Arun Ramakrishnan of the CNHP. I am deeply indebted to them both for enabling us to cap off the year so brilliantly, and turn it over to Dr. Carlton for some logistics.
Good morning, everybody. Welcome to our 2020 CAT Colloquium. Welcome to this digital platform and full day of presentations, creativity, and dialogue. As you know, technology is fluid when it's working and can be frustrating when it is not. For example, our stream today had to switch to a new link and address at the last minute. Please share out that new link to anybody that you invited. And the website has been updated for those who will be joining us later. One can interact with the chat stream as we have been doing so far. Feel free to keep sending support and comments and love and thoughts. Also, while student presentations are happening, anybody can send a question or a comment to that chat box. And our fabulous moderators, Dawn Morningstar and Michelle Rattigan, will be monitoring questions and comments and feeding them essentially to the students during their Q&A sections. The modules, there'll be 5 of them. They will go in a sequence throughout the day. Please consult the program available on the website for download. And at the end of each module will be a Q&A session with the 6 students previous and Dawn and Michelle, and they will have a dialogue and sort of small group discussion. There also are creative works that are shared, a few short videos, artwork as well, and musical selections donated and contributed rather by students and will be shared at the top of the intermissions. Please enjoy the day. We are so excited to have you with us, and welcome to this dynamic, interactive, sometimes frustrating, but ultimately connecting us across many miles and distances media platform. And humbly, our show begins now.
Welcome to Module 1, Social Justice. If you are joining us at the start of this module, you will soon view and listen to 6 graduating CAT student presentations based on their graduate culminating projects. You are viewing this 2020 CAT Colloquium content being broadcast live on a private YouTube channel. You can listen and view these presentations in their pre-recorded sequence, and you may wish to add questions or comments in the chat box function. To share any questions or comments ahead of the small group discussion at the end of each module, you must log into YouTube via your Facebook or Google account. There are live question and answer sessions with all presenting students and 2 moderators at the end of each module throughout our program. Before we take a dive into our presentations, we also want to acknowledge that the land on which we gather with you are the ancestral lands of the Lenni Lenape people, whose presence and resilience in Pennsylvania continues to this day. We take this opportunity to honor the original caretakers of this land and recognize the histories of land theft, violence, erasure, and oppression that has brought our institution, Drexel University, and ourselves here. Taking a social justice approach to the creative art therapies and counseling involves advocating for clients within their many social systems, modeling empowering behaviors by teaching clients how to access services and encouraging clients to become advocates for themselves within their communities. This approach includes empowerment of individuals and groups, as well as active confrontation of injustice and inequality in society, both as they impact clientele and within their systematic context. Social justice advocates work to understand how their implicit biases influence their quality of care and client outcomes. White supremacy is interwoven into our larger cultural fabric and history of providing mental health care. Adding the fears and social stigmas about therapy and mental health only highlights a group of people who critically need mental health services but are instead left underserved or unserved because our profession and practices do not meet these clients where they are. Our CAT presenters today for this module are seeking to make a change. These creative art therapists and counselors utilize a social justice perspective in their work to acknowledge the fact that oppression exists. They recognize that oppression can negatively contribute to mental health for their clientele, and that we need advocacy in our works for our clients. Each presentation highlights the 4 critical principles of a social justice approach: equity, access, participation, and harmony. Equity is the fair distribution of resources, rights, and responsibilities to all members of society. Access is key to a socially just world. It includes notions of fairness for both the individual and the common good based on the ability of all people to access the resources, services, power, information, and understanding crucial to realizing a standard of living that allows for self-determination and human development. Participation is also crucial to a socially just world. This principle describes the right of every person in a society to partake in and be consulted on decisions that impact their lives as well as the lives of other people in their contexts and systems. The final element of this definition of social justice is harmony. This is a principle of social justice wherein the actions revolving around the self-interests of any individual or group ultimately produce results that afford the best possible outcome for the community as a whole. As we transition to our presentations, I leave you with a quote by the great James Baldwin. "Not everything that is faced can be changed, but nothing can be changed until it is faced."
body. I am a body in this space, with eyes that crinkle up from my mother's cheekbones like crescent moons in laughter. It observes the crisis, the need, the hurt, the differences, the privilege. With a gentle slope of my father's nose that enjoys the smells of nature and fresh paper, but smells the fear and tension wafting in forms of unspoken but visible self-preservation or complacency. In a space with other noses, some desensitized over the years, and some still sharp as a bloodhound, refusing to ignore the stench. With ears to listen to the symphony of your experience, to hear the hope and the truth carefully and fully. With a mouth armed to speak words of love and comfort, to speak out for what my other senses have to take in. With a pair of hands to reach out to the need, to take action with and for those who cannot, but desire to. With a heart to stir in compassion and empathy, a heart that acknowledges that I still need to grow, unlearn, and heal from the generations of collective trauma just as much as you. The body that has heard too often, "Where are you from? Now, where are you really from?" I'm from a family with the luxury of having 2 loving parents in stable housing all my life. I'm from a family that says I am beautiful and holds me close in the deepest way to say, "I see you." I'm from a family that was built upon the dreams of 2 body jars of families who have witnessed different degrees of hardship and comfort across continents and cultures. I'm from a family that says I am more than a body and I'm more than beauty because my mind is sharper than the soft flesh that encloses the tenderness of my soul. It is this mind and this soul that is going to make it in those spaces. But I am not the only body in a space. A grain of rice among a sea of sand and soft earth. They say, put your head down and just keep moving if you want to make it here. They say, lift your head up and say no. Say, I refuse to stand in this race of life that wasn't built for me. But who says I can make it here in this room if my body and a body of bodies says you don't embody our ideals or our stereotypes of you? Their faces say, confused or denial of the obvious. The faces say, we have standardized boxes here. We believe you fit in this one. Our assumption of you on the basis of your appearance is truth. Wait, what do you mean? Why won't you just fit in here with all the others? What do you mean this box doesn't quite work? Why can't you be more like them over there? Why can't you just know your place? Oh, you don't know where that is. Well, then I don't know how to deal with that. You can just figure it out yourself, and if I don't like it, you'll just go where I tell you can go. Maybe you see what you choose to see because that's easier than seeing past this body. A body silenced by being the not quite fitting in here, or there, or there. A body tokenized and exoticized, like a mannequin put on for display to say, yes, we care, because look, we have this here. A body that can't even clear a throat or sneeze or cough in a public space for fear those eyes will see a walking disease. A body whose back and chest heats up like a warm stove, slowly turned on high when witnessing the impact of injustice bearing its many heads, overt and covert, A body whose shout chokes in the throat in a room that says, "You are welcome here," but really says, "Oh, you're here too. I didn't even notice." But I noticed. Like a one-way mirror, I can recognize it. Misunderstood, not taken seriously, ignored, brushed off, miscommunication, not taken seriously. That wasn't a microaggression, was it? You're just mad at things. They didn't mean it like that, did they? Why are you being so sensitive? Because this body exists in this space, capable of breathing deep and knowing that there is good out there. There's opportunity, there's possibility for change. So you, body and soul, are you willing to dialogue with me? More importantly, are you willing to dialogue with yourself? To do the hard work of acknowledging the ways you have been complicit to the problem that puts people in boxes, made by the master narrative that puts walls up into us versus them. To forgive your past ego, denial, or ignorance, and peel back your history and the ways it has informed you and your ancestors in responding to brokenness. To have your heart break for the marginalized and oppressed. They say difference is a teacher. Will you celebrate those differences? To unlearn and learn? I cannot promise an easy conversation. I can promise discomfort. I implore you to push through and not to pass this discomfort, for in it, maybe you can meet me in the middle. I am in the work too. I am a body who is ready to stand with, listen, respect, and support. I embody my culture that always asks, "Have you eaten yet?" as a way of saying, "How can I care for you?" I embody my family's hopes and dreams of success in a broken society. I embody healing, a listening ear to voices that say, "I'm here too. I hear you." I embody somebody who is forming. I am more than a body in this space. Aren't you more than a body too?
Hello everyone, my name is Erin McDowell, and today I will be presenting my master's culminating project, which focuses on microaggressions, embodied privilege and oppression, and the potential for performance as a way to enact social change. I'd first like to say thank you to my culminating project advisor, Christina Devereaux, my performance project collaborators, Ashley Porter, Gabriella McDaniels, Jason Gonzalez, Jenny Milton, Miles Young, and Summer Smith. I'd also like to acknowledge all of my professors and supervisors who have guided me and pushed me throughout my graduate school education. I first became interested in this topic as I engaged in my personal process of development as a dance movement therapist. As I began looking deeply at the theoretical perspectives which would drive my outlook as a practitioner, and spending time reflecting on my own biases and potentially damaging blind spots, being a white woman working within marginalized communities, I searched for literature to help my growth and learning process. In my quest to understand the plethora of ways that these power dynamics may arise in practice, I began looking into body privilege. I asked questions like, who has access to what types of movements? Is there a culturally competent way to utilize movement assessment tools that we have been studying in our education? And how do power dynamics of existing privilege and oppression impact movement interactions in a therapeutic setting? By asking these questions, I became interested in microaggressions and wondered how they both manifest on a body level and how they impact those targeted within their bodies. My intention as a developing practitioner is to recognize when and how I can help to advocate on behalf of my clients, because I firmly believe that change does not occur in a vacuum. The systems that continue to oppress these populations must also be changed. This is why developing a performative project that could potentially create conversation within privileged communities about the changes that they need to implement felt like the path best suited for this project. The literature I found to support this project focused primarily on the immense impact of oppression and microaggressions on the body, how it builds up over time as a complex trauma that cannot be erased. Carla Sherrill writes specifically of her experience as a Black woman enduring and resisting the impact of these traumas in a society that is dominated by white supremacy. She explains that the racism that she is not able to catch fast enough to scrape from her skin moves past the skin and becomes a bodily experience that requires a different removal process. Research on embodied privilege is much harder to find, speaking to the ability for privilege to go unnoticed by those who hold its power. Allen spoke about the embedded sense of superiority that whiteness holds, speaking of movement as holding the qualities of floatiness, comfort, and relaxation in privileged communities. A stark contrast between the studies suggesting that embodied oppression holds the qualities of restrictedness, limited access to certain movements, lack of control over one's own body, and a demand to simulate white bodies. With research by Birdwhistle from the 1970s suggesting that 2/3 of a message's meaning is communicated through nonverbal language, and contributions by Argyle and Johnson suggesting that power and privilege are communicated predominantly by nonverbal language, there is reason to continue examining how these movements manifest in a therapeutic setting in order to hold counselors accountable, especially in a body-based therapy which utilizes movement assessment. After finding literature to support the necessity for embodied experience through art as a way to discover neglected patterns of thoughts and behaviors, and in an attempt to continue to learn and reach others through movement, I connected with collaborators to create a performative project which would ideally deliver an embodied experience of the impact of nonverbal communication of power and privilege. With the arrival of COVID-19 earlier this year, my original hope to develop an interactive performance in which audience members would have a direct embodied experience needed to be shifted into an online format. After reaching out to potential collaborators with a brief explanation of my project, I was able to find 6 artists willing to share their stories. Each created a response to their individual lived experience of embodied privilege and/or oppression. They followed the prompts: how have verbal and nonverbal microaggressions impacted your experience of living in your body? How have the privileges you hold impacted your experience of living in your body? Each collaborator was given their own space in this website format to share movement and words representative of their experience of embodied oppression and/or privilege. Due to the nature of this time, all communication between collaborators and myself happened through email and phone conversations. I worked back and forth with each individual to make sure that the extensive material they shared with me was fully represented in its reduced form for this project. The collaborators were the first to see the finalized project and were given full control over how their stories were presented. The website, a social change performative project.cargo.site, is complete with each individual response and story as you scroll down the page. In the About Us section, you can read more about the literature that I've found, and in the context section, there is contact information in order to engage in dialogue with anyone who views this work. I now present to you a small glimpse into the work of 2 of my collaborators, First Movement by Miles Young, followed by the words of Ashley Porter.
I do know that I wish that people would stop asking the Black community what we should do to help this problem, the racial injustice and all of these crazy situations that we aren't perpetuating or starting. But I think that the key to ending those things would be to question each other. White people question other white people and figure out why they have these prejudices, why they don't understand certain things, and why they get angry that they don't understand certain things, why they feel the need to belittle other people.
An ongoing source of gathering information. I ask that anyone who's willing visit the website you see in front of you and contribute to the dialogue in any way that you see fit. I would love to hear responses to the movement and the words presented by my collaborators, or any thoughts or reflections on the literature which I spoke about today, or that can also be found on the website. I'm really hoping one day to bring this project to a live audience as a more embodied experience, and any contributions can help. Thank you so much for your time.
Hi, my name is Brent Rounsville. I am a current graduate student at Drexel University studying music therapy and counseling. Today I'm going to present on my culminating project, which is titled Music Therapy and Counseling in Rural America, in homage to Hillbilly Elegy. Before starting my project, I had to first look at the availability of music therapy and counseling literature with rural populations. From there, I was able to look at the availability of mental health resources in rural areas, which required me to first define what rural is. According to the U.S. Census Bureau, rural is basically defined as everything that is not urban. There is a very long process for them to define urban areas, but again, rural is just defined as anything that is not urban. I was then able to look at barriers, challenges, and opportunities relating to these mental health resources in rural areas. I would like to first discuss my personal relationship to the topic before going too in-depth in discussion of my project. I will of course soon be a professional in the field of music therapy and counseling, and there is always a high chance of me working with this population. I also identify as rural myself, coming from a small Pennsylvanian town, and I've always felt a passion for this topic. Some challenges found in rural mental health research include socioeconomics, access, and culture. Poverty can strike rural towns pretty hard, as there is shown to be a decline in employment opportunities over the years. This has forced individuals to work multiple part-time jobs with little to no health benefits. On top of this, access to mental health services is limited in rural areas. Although in 2001, it was shown that 87% of mental health professional shortage areas are in non-metro areas. On top of this, in 2019, they found that 65% of non-metro counties lack a psychiatrist, compared to 27% of metro counties. Because of this, clinicians can get burnt out pretty quick, trying to service all of the needs of their clientele. Culture in these areas could also prove to be a challenge to some clinicians, especially those who are unfamiliar to it. Within rural culture, there has been found to be themes of stoicism, stigma, distrust, as well as the acceptance and normalizing of dual relationships in these areas. When a clinician is able to look at the challenges presented, they are then able to understand some opportunities that are present as well. Some of these opportunities shown in the research include collaboration between the therapists, schools, and churches, as schools and churches are often integral to the community. Community music therapy is also an option, as long as the clinician comes into it with cultural humility, of course keeping in mind the cultural aspects discussed in the previous slide. Another option for an opportunity is telehealth, which may be more difficult for music therapy than it would be for counseling, but it is still possible. And finally, the last opportunity found in research is that of home-based services. For my project, I looked at the text Hillbilly, Elegy, a Memoir of a Family and Culture in Crisis by J.D. Vance. In this text, the author describes his experiences growing up in a rural Appalachian family. My project specifically looks at one member of the family called Mama. She is the author's grandmother and was his caretaker for a long time. For the sake of this mock case conceptualization and project, we're going to say that Mama is 85 years old. She's a white female who grew up in Jackson, Kentucky. She got married to her husband at the age of 14 and moved over to Ohio in order to find better opportunities for work. However, when they moved into this middle-class society, they found a lot of issues trying to adapt to the new culture. Mama and her family have a long history of drug abuse and violence, which includes situations she was exposed to as a young girl. Mama also has a history of depression and social isolation, but despite this, as she got older, the author often described her as being the thing that kept the family connected. Mama is a strong and resilient woman who was able to find ways to cope with what she's been through and to focus her time on taking care of her grandkids and other family members. For this mock case in my project, we're going to pretend that Mama has developed depression after her husband had suddenly passed away, and she decided to try out music therapy after hearing about it from a family friend. Some themes in the literature that are also apparent in Mama include stoicism and distrust. In the research, these tend to affect what the research considers help-seeking attitudes in individuals in rural areas. For goals and objectives, we will want to take a trauma-informed approach with Mama, as she has a long history of it. One goal to really focus on is increasing her awareness of her internal and external strengths, as most of her life she has been a caretaker for others. Once again, she's a very resilient woman who has the resources she needs, she just may not be aware of them. And for the intervention, we're going to assume that Mama identified Blue Moon of Kentucky by Bill Monroe as being a favorite song of hers. Not only is it the official bluegrass song of Kentucky, her home state, it was also released during her teenage years. In this hypothetical situation, we may be able to use the lyrics of Blue Moon of Kentucky to help to validate Mama's emotions after losing her husband. We could then work together to rewrite the lyrics to really focus on Mama's strengths, to not only be able to recognize them more, but also to help improve her own self-efficacy. This change could even be shown in the structure of the song itself, with the beginning starting off described as a bluegrass waltz, and later moving on to a faster bluegrass style. For those of you who may be unfamiliar with the song, let me play you what's shown on the screen. I'm going to be using a mandolin, and I'm going to be playing it in the slower style in which the song begins with. Say, Blue Moon of Kentucky, keep on shining. Shine on the one that's gone and proved and true. Say, Blue Moon of Kentucky, keep on shining. Shine on the one that's gone and left you blue. In doing this project, I've begun to realize there is a great need for music therapy research with rural populations. This project has also increased my passion for this population as well as increasing my personal identity as a rural individual. I would like to give a special thanks to everyone who's helped me, not only throughout the program, but throughout this project as well. They say it takes a village to raise a child. And, I think you all did a great job raising me through this program. I've learned a lot, I've grown a lot, so thank you.
Hello, thank you for coming today. I'm Amanda Williams, and I will be presenting my culminating project, The Patient-Provider Relationship as a Kaleidoscope, Developing Trust with Native Americans Seeking Healthcare. To extend my gratitude to the supervisors I've had the honor of learning from throughout my time here at Drexel, Christina Deverell, Adina Rosenberg, Nalini Prakash, Ivy Welshans, Dawn Morningstar, Heather Clark, and Kendall Ireland. This project came about because as a Choctaw Native person, I've often felt invisible or experienced a lack of reflection within the systems surrounding me. As I became more saturated with information, I felt that before I could speak to the health disparities we may face as a people or intergenerational traumas that may be living in our DNA, I first had to exclaim, "We are still here." And because we are still here and not going anywhere, I wanted to focus on how we could approach the patient-provider relationship in a way that fosters trust. So for my culminating project, I wrote and plan to submit an article to be considered for publication in a peer-reviewed journal. The article will be written from a narrative perspective of a Choctaw dance movement therapy and counseling graduate student. This article will be submitted to the Patient Education and Counseling Journal. The audience of this journal targets healthcare researchers, healthcare educators, managers, counselors, and a wide array of healthcare providers. This was done intentionally because the information I'm providing can really be extracted and used across the board in healthcare settings that Native people are engaging with on a daily basis. I personally got to see how this approach to the relationship could be fruitful working cross-culturally as a Native dance movement therapist working with majority African American and Black clients in my internship. First, I would like to orient you with symbolism that will be used throughout my presentation, beginning with the starburst, a prominent motif seen in Choctaw beadwork, which influenced my incorporation of the kaleidoscope, which I will present later. The half diamond, also known as the life of the people. This also represents the imaginary road that we are placed on by our Creator. The symbol for sunshine represents happiness, growth, and power, as the sun is an infinite life-giving source. We will look at invisibility within academia, systems mistrust, patient-provider relationship as a kaleidoscope, and recommendations moving forward. Education systems are one of the leading information sharing networks within the United States. The particulars provided within these systems has wide reach and lasting consequences, so it must be intentionally curated to supply accurate, factual, and inclusive material. Literature shows that less than 50% of the states report Native curricula required in their state. 87% of state history standards do not mention Native history after the 1900s. 27 states do not mention a single Native American in their kindergarten through 12th grade curriculum. 72% of Americans rarely receive information regarding Native people. It is also important to point out that in addition to invisibility within education systems, there's a lack of representation within health promotions, research, and media, with the majority of research and literature pertaining to Natives on reservations, despite the fact that 70 to 80% of Native people live off reservations. Mistrust. System transference is a potential factor when past experience with the system impacts current feelings and/or reactions to a system. Literature reports that a relentless history of complex and compound traumas within every system Indigenous people have come in contact with has resulted in a negative view. The forced and coerced sterilization of Native women is one piece of systemic genocide directly related to the relationship between Native people and the medical system. Native culture and Indigenous ways of knowing juxtapose the dominant culture. This can result in cultural mismatches between patient and provider. Indigenous ways of knowing tend to originate from a place of intuition. They are holistic and cyclical. Native ways of being are deeply relational. All things are equal. The land is sacred. The relationship between people and the spiritual world is important. Human beings are the least important. All life is sacred, and all life forms are connected. The theme of reciprocal recognition continued to arise, as did connectedness and relationality. This led me to the imagery of a kaleidoscope, which is similar to the starburst pattern. A kaleidoscope has two or more reflecting surfaces with numerous particles of varying shapes, colors, and sizes. The movement of the kaleidoscope tube creates dynamic images. What exquisite collaborative moments could occur if the relationship between providers and patients refracted and reflected in a similar manner, zooming in and out, witnessing reciprocal reflections, while acknowledging and seeing every person for who they are, where they are. This also would allow us to acknowledge the spheres surrounding and impacting both the collective and the individual, and how fluctuations of one affect everyone. With the current systems in place, I see my Native culture reflected in almost every aspect of therapeutic teachings, person-centered theories, and dance movement therapy theories. Yet, in the education of healthcare professionals, there is a minimal acknowledgement of not only the reflection, but of our existence. The kaleidoscope is defective. If the kaleidoscope is damaged, this creates safety concerns. Whether the reflecting mirrors are shattered or the holding container is cracked, it can no longer be used safely. As we look to build a fully functional kaleidoscope, I suggest that the providers validate and support Indigenous practices, push for decolonization and systemic change, acknowledge the emphasis of individualistic values within Western assessment and treatment and how those may not be conducive for collectivist cultures. The provider should allow for space for productive silence and non-intrusive observation, since eye contact and silence are seen in a different light for many Native cultures. Lastly, a sense of safety should not be assumed. Instead, trust must be earned by the healthcare professional or the educator through consistent demonstration of intentional, virtuous practices and care. We must strive for reciprocal recognition between all diverse populations and the majority within every system. I implore that cultural competency is not adequate. We must all take an anti-racist position. The principle of cultural competency still upholds the notion that Eurocentric views and ways of being are the core standard, and that other cultures are viewed as merely supplemental knowledge. When a provider takes an anti-racist outlook prior to engaging in relationships with Native clients, reciprocal recognition can occur. Trust can be fostered, and an environment can be created where collaborative healthcare can take place. Here you will find the references which I used in today's presentation. If you have any questions, comments, or would like to engage in further conversation, feel free to email me at amanda4lee@gmail.com. Yakoki, thank you.
Hello, my name is Natalie Maeda, and for my culminating project, I examined considerations for music therapists working across a language barrier. Specifically, my project involved developing guidelines for music therapists working with clients with limited English proficiency, so some operational definitions. When I'm talking about clients with limited English proficiency, I'm talking about people who cannot communicate quickly or easily in English because it is not their native language. Additionally, I will note that within this project, I was specifically examining working with immigrants and refugees with limited English proficiency because these are the two largest populations in the US that have limited English proficiency. I will also note that in this project, I was primarily examining the use of professional interpreters rather than ad hoc interpreters. So I wanted to examine what it's like working with a professional interpreter, someone who has received formal training rather than someone who has not. My initial interest for this topic developed during my Social and Cultural Foundations course within this program. There was a paper that discussed that therapists working with interpreters have to make special considerations. And that stood out to me at the time because I was working with an individual who had limited English proficiency because due to complications associated with dementia, they had forgotten how to speak English. And I was one of the few people who could still verbally communicate with this individual because I knew conversational Spanish. And my interest in this topic continued to develop as I moved into my internship and I had an opportunity to work with another individual who may be considered limited English proficiency. Lastly, I will note that my own personal background and experiences have influenced me to be interested in engaging with this topic. So for my literature review, I ended up breaking it into 5 separate categories of what I examined. I examined mental health of immigrants and refugees, the relationship of culture and language with mental health care. I looked at verbal psychotherapy literature on language barriers. I also looked at music therapy with immigrants and refugees, as well as developing a culturally centered music therapy practice. So for the sake of time, I will be discussing just the key themes of my literature review, the first being culture and language interact with migrant mental health. Experiences related to migration such as trauma, lack of social support, acculturative stress, or the stress of adapting to a new culture, as well as language barriers, all can negatively affect migrant mental health. Additionally, culture influences how migrants perceive and understand mental health, as well as how they interact with mental health care systems. And this highlights the importance of offering culturally centered treatment to migrants. Language also plays an important role in regulating emotional and personal expression within therapy, and this highlights the importance of meeting the client's linguistic needs. The second theme is that music therapy techniques have been examined in a variety of immigrant and refugee settings and have been found to promote a variety of benefits related to mental health, such as the development of self-expression, developing insight, gaining a sense of control, and improving social functioning. Additionally, language barriers and the degree of a music therapist's cultural empathy are relevant therapeutic factors. Finally, music and its meaning are culturally contextual. So there's some discussion in the literature that music therapists should incorporate ethnomusicological strategies into their clinical work to engage with their client and their music with cultural humility. So in the creation of these guidelines, I first synthesized the sources I got from my literature review, and I found that there are still some gaps in my understanding about this topic, so I went back into the literature, and from there I created a draft, which I turned into my advisor, and then I incorporated my advisor's feedback to develop a final draft. The final product ended up being a written synthesis of the literature describing my rationale for the guidelines, as well as a detailed list of the guidelines that could be an example of a resource for music therapists to use. So a quick overview of my guidelines. I ended up dividing them into 4 separate categories, the first being general guidelines. These are for all music therapists working with clients with limited English proficiency, and they cover topics that all music therapists should consider regardless of their resources or backgrounds. I also wrote guidelines for music therapists facilitating in the client's preferred language, so these are designed for music therapists who are bilingual or multilingual. And then I also wrote guidelines for music therapists facilitating with an interpreter and those facilitating without an interpreter. So some key themes I'd like to point out for the general guidelines are considering how one's linguistic context affects one's scope of practice. So what I mean by that is that music therapists should be examining how fluent they are in the client's language. What are things that are affected with interpreter-facilitated communication? Really examining how all these linguistic factors affect one's scope of practice, what you can or can't do for the client, and being transparent with the client about that. I also examined how music therapists can develop their musical cultural empathy, and this is primarily done by offering the client agency over the music experience, as well as expanding one's musical vocabulary in a way that promotes cultural humility. So key themes for facilitating in the client's preferred language. The thing I will note here is that when bilingual or multilingual music therapists are developing a professional multilingual identity, it is important that they are learning relevant terms in their non-professional language or the client's language. And so these relevant terms would include psychological terms or musical terms, terms that the music therapist is already using in English, but they may not necessarily know in their non-professional language because they were not trained in music therapy in this language. So some themes for facilitating with an interpreter. The things I want to point out here is that it's important for the music therapist to prepare the interpreter for therapy, primarily by training them and going over ethics, as well as defining the interpreter's role, what your expectations are of the interpreter. It's also important to facilitate the triadic relationship, acknowledging that there's an extra person in what usually would just be a dyad. So it's an important thing to establish boundaries with the interpreter and the client, as well as offer post-session supervision to the interpreter because they are at risk for vicarious trauma. And finally, for facilitating without an interpreter, it is important for a music therapist to consider one's scope of practice, especially considering that in this scenario, the music therapist would most likely be engaging in music-centered music therapy, so examining what exactly you can achieve, instances in which it might not be appropriate to use music-centered music therapy. And it's also important to develop the therapeutic relationship, relying on nonverbal communication. So some limitations with my project. I did not consider these guidelines for group settings. I did not consider issues associated with working with undocumented immigrants, and I did not consider U.S. residents with limited English proficiency born in the U.S. Again, I only examined working with immigrants and refugees. Finally, I believe that my culminating project fits within the discussion of developing culturally centered training for music therapists, specifically training that promotes the development of musical cultural empathy as well as linguistic empathy. And the importance of this, I think, is well illustrated with this quote, which I will end with. Reducing health inequalities involves us as practitioners in reaching out to others across all kinds of differences. So with that, thank you for listening to my presentation.
Hello everyone, and thank you so much for joining me here today. My name is Emiley Allison, and I will be presenting my final, Moving with the Black Pregnant Body, a community-based project investigating the use of movement and social connectedness to increase positive pregnancy experiences. So before we get into the project, I just want to say a huge thank you to everyone who has supported me thus far. And I want to give a special shout out to the dance movement therapist who's acted as my internship and practicum supervisors, part of my culminating project committee, as well as my professors. So let's get started. I often get a lot of questions about the work that I've slowly been getting involved in the past few years. Birth work? Don't you just have the baby at the hospital? What's a doula? These are all questions that I've been asked and will explain shortly. But first, let's start where I began. I come from a family filled with educators, birth workers, therapists, social workers, and more. So growing up, I really felt as if I was going to enter the helping profession from a young age. I entered my sophomore year of undergraduate and decided to become a professional nanny and really fell in love with working with newborn children. From that point, I decided that, hey, since I like this so much, I might as well become a doula, or someone who assists a pregnant person before, during pregnancy, in labor, and after or postpartum. So when it came time to deciding what I wanted to do for my culminating project, I thought it makes total sense for me to work with the people that I've been working with for the past few years of my life. I have broken down my literature findings into 3 sections. For the first section, I'm going to talk about my process into narrowing down my scope. I really had to branch out to branch in. So this seemed like a pretty big topic to tackle. So I decided to start from the very beginning and look at how pregnancy is defined and what are the cultural ramifications of that, depending on gender, race, ethnicity, etc. For example, in the United States, the medical model is how many people approach their health and well-being. That being said, many people go to the hospital to deliver babies, but there are also pockets of people that really believe in community births, birthing centers, and birthing at home. Now here is where I found some gaps. Most of the literature refer to pregnancy as it related to cisgender women, where there are many people who are not women who give birth. So I wondered how many more people were left out of the equation because their gender identity was not represented. I also discovered some research dedicated to surveying pregnant people and their experiences. Some of the negative feedback was related to little support, access to healthcare, provider bias, gender, and racism. After that preliminary search, I decided to see if there was information on the connection between racism, healthcare, and Black maternal health outcomes. I did find that Black, Indigenous, and Latinx people all interrelate into prenatal care, which put them at risk from receiving education and obtaining early health screenings. I also did a ton of reading on medical racism. An example of medical racism is J. Marion Sims, who is considered to be the father of gynecology. He did all of his operations on enslaved Black women without anesthesia. When looking at the Black American experience, one could only think about these instances or instances like that and understand and identify also how cultural mistrust between healthcare providers is another layer to be discussed. I'd also like to make a point about chronic stress. Carter et al. 2017 and 2019 discusses racial, structural, and interpersonal stress. Their research has found that it not only causes physical issues, but also creates post-traumatic stress disorder-like symptoms. Again, I'm thinking, what is the big picture related to poor maternal health outcomes? Pulling in all that information, I also wanted to know what was already being done to decrease Black maternal mortality, as well as negative thoughts and feelings related to pregnancy. In my research, I found that there is the use of early warning systems. So this is catching a problem before it becomes bigger, with the utilization of protocols, lists, risk management. In dance movement therapy, there is no research about Black people specifically, but there are people currently working in the field with parents of color. There is research about attuning or building a relationship with the child in the womb, which is related to the work of Judith Kestenberg. There is also literature about working with parents and groups and fostering connections and shared knowledge to increase positive familial outcomes. And most of all, there are a ton of people engaged in organizing, particularly related to Black maternal health, creating sustainable communities within communities to support birthing people at all levels. So as I was preparing to enter the birth community of Philadelphia, I really wanted to immerse myself. If I saw somebody at the grocery store and they were wearing a shirt that said community birth on it, I talked to them. I went to meetings, webinars, seminars. I read books that people recommended to me. I even created an Instagram page to speak with people in an online forum, and I spoke with many people at my internship site. And so even though my community engagement was a multi-tiered process, I also planned to have an event for Black caregivers. Unfortunately, that did not happen because of COVID-19. However, I still was able to hold an online forum with the participants individually. And so in these individual meetings, there was a focus on collaboration and community. There was also a mix between intentional full body movement and posturing and gesturing. I also utilized some of Alma Hawkins' creative process, specifically sensing, feeling, imaging, and transforming. Overall, participants stressed the importance of support and how that related to their bodily autonomy during labor. Some demonstrated that they physically felt strength. Each person said that their community is what holds them together, whether big or small. There were very specific conversations about the tension felt in the mind and body when discussing raising a Black child in America. And above all, joy is not lost. There is something so special about the creation of a child. Birth is an otherworldly experience. I just want to say thank you so much for tuning in today. I hope illuminating my process and findings was fruitful to you. Also, if you have any questions or comments, I'd love to discuss them. Thank you.
Hi, everybody. Welcome. This is our first question and answer period for Module 1. We are so excited that you're here to join us and that our panelists are here. If we could just very quickly, if each of you can just say your name and the title of your project, and then we're going to move into question and answers. We'll start with Brent.
Hi, I'm Brent. The presentation I did was Music Therapy and Counseling in Rural America.
Excellent. Arisa?
Hi, this is Arisa. I did a presentation on A Grain of Rice Among Sand and Earth, Understanding Ethno-Racial Labels and Unconscious Bias.
Great. Amanda? Oh, you're on mute, Amanda.
Hello, I'm Amanda Williams, and my presentation looked at the patient-provider relationship as a kaleidoscope, developing trust with Native Americans seeking healthcare.
Excellent. Emiley?
Hello, I'm Emiley Allison, and my presentation was Moving with the Black Pregnant Body, a community-based project investigating the use of social connectedness and many other things to increase positive pregnancy experiences.
Great. Natalie?
Hi, I'm Natalie, and my presentation was on music therapy considerations for music therapists working with clients with limited English proficiency.
Excellent. And finally, Erin.
Hi, I'm Erin. My presentation was on microaggressions, embodied privilege and oppression, dance movement therapy, and audience impact, a social change performative project.
Excellent. So we're going to start off with a question that anyone can answer, a general question for everyone in the module. And Dawn, you have...
Yes. Hi, everybody. I'm Dawn Morningstar. I don't think Michelle introduced us. I'm Dawn Morningstar. I'm a dance movement therapy and counseling faculty. And this is Michelle Rattigan. She's in the art therapy and counseling faculty as well. It only has my name on here. Obviously, we're sharing a Zoom social distance, so we're trying our best. So this is a question for all of the panelists. Having gone through this process, how might this influence your advocacy process as a clinician going forward? So anyone can answer it. You might just want to. So how might going through this process influence you to become an advocate as a clinician?
I can start. So I feel as if, and I talked a little bit about this in my actual paper, that I've constantly been an advocate because I am a Black person. And so I feel like doing this and going through all the research and working with people on my internship side, as well as other folks in the community, it only made me want to work and strive even harder, which is only relating to the state of the country that we're in right now.
Thanks, Emiley.
I feel similarly to Em. I think that with my project focusing on the actual relational piece between the patient and provider, it'll give an opportunity for me to advocate within each interaction that I have with patients and with my colleagues.
I think it's also helpful that with doing this project, we now have the literature to back it up as well. You know, we can pull out saying, you know, here are 5 papers on this topic, all saying the same thing, and this is what needs done.
Great point, Brett. Thank you. All right, for the essence of time, we're going to move into some specific questions that came in for people. Arisa, this one is for you. People were really wowed by your presentation. Thank you for starting us off today. People are wondering about your project growing and any future plans with the film to share with other viewers and with other spaces.
Sure. Yeah, I would like to somehow disseminate this video to other platforms. I got a message actually during the presentation that someone has suggested that I translate the video to other languages so it could be more broadly shared. And for this video in particular, or just the project in particular, I actually wanted to do something a little bit different that was in person, but due to global circumstances, that was not possible. So I'm thinking that this video could be used in place, whether it's through a workshop or other presentations, maybe in the future, as a way to introduce the topic. Yeah.
Good idea. Great. All right, Erin, this one's for you. Ready? Yeah. So,
it's kind of a two-part question. So are you planning to add more collaborators or contributions from the public to your website? And are you interested in other types of artistic expression, artwork, music, or are you just interested in dance?
So yeah, similar to Arisa, I had planned to do an in-person performance. So developing this website kind of opened up the doors for maybe the potential for more collaborators to join in the future. I had limited time, so I was able to contact 6 people, 4 of whom are movers, but 2 of whom are not, and work in film and writing. So they have like a different perspective on everything, and I'm completely open to adding more and continuing to have this project just like grow and become something more than what it is just now.
Yeah, and just really quick, everybody get their pencils out. Erin, can you say your website again? I know it was in the chat. I just want to make sure.
Yeah, it is a social change performative project.cargo.site.
Thank you. Brent, this question is for you. Were you playing the mandolin in the experience?
Yeah.
People liked you jamming on the mandolin. But also, people were really interested about what you did and what you had to say, and they're wondering what are some more ideas you have about bringing music therapy into rural communities?
Yeah, so it was interesting because there's not a lot of music therapy research with rural communities. Most of it is from other countries. I know one main one is from Bangladesh, but so a lot of it is kind of taking the ideas in the literature for counseling and adding music therapy into it and supporting it that way. Of course, with everything going on right now, telehealth is becoming more and more common. It's probably going to be a part of our field a lot more after this. And that is an option, although there are limitations with music therapy and telehealth. I think something that really speaks to the collectivism of rural communities is community music therapy. As long as the clinician is going in with culture, humility, and understanding that, it may not be their culture and they do have to, really listen to the community when they're working with them.
Mm-hmm. Mm-hmm. Yeah, thank you. Great. Amanda, I have one for you.
Yes, ma'am.
Yeah, okay, so how does historical erasure or invisibilia show up in therapy, do you think?
I think that it starts from even just that relational piece. I think that if you've never seen or heard or gained any real information about Native people, you come from a really unsteady foundation to be able to engage in the relationship. I also think that a lot of times in therapy, like I mentioned in my presentation, how eye contact and silence is a lot different for Native people or a lot of tribes. I think it can often be misread. I think it can also even be misdiagnosed, which is really potentially harmful. So that's one of the reasons that I really wanted to get the information to all healthcare professionals, because the eye contact and silence can be misread in any situation. So I think the more you know, the better we can do.
Excellent. And we look forward to the things that you're all bringing forward to the field. We have just a few minutes left, and I want to make sure we get to both Emily and Natalie. Emily, what are your thoughts about embodied racial trauma? What would be some of the advice you would give to people who want to do some movement and self-care for resiliency at home and not in the therapy session?
So I have a lot of thoughts about embodied racial trauma. I think it's so deeply embedded into not only, my focus is on the Black community, but in many communities who are considered oppressed or marginalized. And I know for me, what I do when I'm feeling overwhelmed or I get really anxious is I do a lot of different types of dimensional breathing. So I'll find a quiet space and I'll see the many different ways that I can breathe through my stomach, if I can breathe out through my arm, if I need to lay on the ground with like my back on the floor and see if I can breathe through my back. Another thing that I really love to do is find joy or curate joy. So I have different things like on YouTube and on Instagram, where if I see something funny, I'll save it. And if I'm feeling really low and down, I can go to those spaces and like laugh until I'm crying. And so we're getting a lot of emotions out at the same time, but at the root of it is really still signifying and finding that joy and happiness.
Emily, that's beautiful. And I love how accessible it is for all peoples.
This is a question for you, Natalie. How do you navigate language in a session when there's no direct translation or when the translation holds a different cultural meaning?
So I'm assuming if you don't have an interpreter or there's no English equivalent of the word, I think it's very tricky. It depends on the client and what their needs are, how old they are, where they're coming from. I did mention in my paper that something that I didn't really consider is our new developments in technology with online translators and how they are being improved. But I guess a lot of it is if you're having trouble navigating like verbal communication, you're going to have to stay within the music and figuring out what can be done in the music and what you can't do in the music. So that's the big takeaway there.
Wow. Well, thank you, everybody. Thank you for your presentations. Thank you for your perspectives. And thank you for answering questions. We had many more questions we did not get to. We're going to try to get to as many as we can. So congratulations also.
Yes.
Little round of applause for you all. And we will be back after a short break.
Thank you, everybody.
Thank you.
Thank you.
Thank you.
Some genie out of some battle somewhere is saying, this is what I thought you asked for. And some genie somewhere else is saying, it doesn't work like that. It's not commensurate with anything you ever said or done. Anyone says it is, you tell them I said that they're in a fairy tale. May as well say that somebody made beautiful, picturesque, glorious full moon just to make it right down crying. And when you look up at the sky, you see constellations. And somebody's tearing out her hair, saying, why is it the one I cannot name? Why is it always your way to show me what I used to have by taking it away? Maybe it doesn't mean anything. Maybe it's empty of meaning. I'm meaningless. Empty of quality, empty of good or bad, empty of anything meaningful. It's not allegory. Time moves in one direction. for as long as we're alive, as long as we're alive. Some genie out of some battle somewhere is saying, this is what I thought you asked for. And some genie somewhere else is saying, it doesn't work like that. It's not commensurate with anything you ever said or done. Anyone says it is, you tell them I said that they're in a fairy tale. May as well say that somebody made beautiful, picturesque, glorious full moon just to make it right down crying. And when you look up at the sky, you see constellations. And somebody's tearing out her hair, saying, why is it the one I cannot name? Why is it always your way to show me what I used to have by taking it away? Maybe it doesn't mean anything, maybe it's empty of meaning and meaningless. Empty of quality, empty of good or bad, empty of anything meaningful. It's not allegory. Time moves in one direction for one reason.
Welcome back, everybody, or welcome if you're just joining us. We're coming back in about 2 minutes to restart our program. This is going into Module 2, Children and Youth. My name is Dawn Morningstar. I'm a dance movement therapy and counseling professor here at Drexel, and I'm going to welcome you back. And we're going to do a quick little movement to get us ready for Children and Youth. Feel free to participate in this activity however you see fit. If you're sitting, if you're standing, if you want to move around a little bit. So I'm going to do a really modified brain dance. Brain dance was developed by Anne Green Gilbert to work on brain-body connectivity. So we're going to try to get that going. It's great to work with children. It's developmentally based. So we're going to start with breath. We're going to inhale and exhale. One more time. Inhale and exhale. Let's take that really big. Inhale and exhale. And we're going to move on to tapping. So we're going to wake up our body parts. We're going to say, hello, body, hello, legs, hello, torso, hello, arms. You can do this as a rub or as a tap. Kind of get ourselves ready and energized, ready to watch what we're going to do in a minute. I'm going to move to my favorite, cross crawl, which is where you crisscross. You can do the sitting, like I said, or standing. This gets the corpus callosum going, right to left. We're going to do, you can do it both ways. You can do it in a circle, however you want to do this. Keep breathing and work your way, if you're standing, over to your chairs and your seat. And let's get our heads ready and our bodies ready. We're going to move our heads so we don't get zoom neck. Roll your head and your shoulders. And we're going to take one more deep breath and prepare for Module 2, Children and Youth.
Good afternoon. Welcome to Module 2, Children and Youth. If you are joining us at the start of this module, you will soon view and listen to 6 graduating creative arts therapy student presentations based on their graduate culminating projects. You are viewing this 2020 Creative Arts Therapy Colloquium content being broadcast live on a private YouTube channel. You can listen and view these presentations in their pre-recorded sequences, and you may wish to add questions or comments in the chat box function. To share any questions or comments ahead of the small group discussion ending each module, you must log into YouTube via a Google or Facebook account. There are live Q&A sessions with all presenting students and 2 moderators at the end of each module throughout our program. My name is Flossie. I am the Director of the Music Therapy and Counseling Program in the Department of Creative Arts Therapies. Today is a very proud day for me and for all of the faculty in our department. The theme of this module is Children and Youth. The children are our future. Jason Millard's presentation concerns a theme that is very present for us now: how to talk to kids about intersectionality. Do white children know about the talk that their Black friends have with their parents? Will the children with financial means know what it's like for their friends with less, or who are food insecure and perhaps even unhoused? What about those with different religious beliefs, with disabilities? Our children will shape the future. The greatest love is needed for children in chronic pain and their families. Selena DeMeo will tell us of her work supporting pediatric chronic pain patients and their families through dance movement therapy. What better way to offer relational support for children in pain than through a body-based method that encourages attunement and a sense of truly being together? Let's teach them well. Caroline Kinsley is exploring mindfulness-based dance movement therapy with adolescents in a high school setting. Mindfulness and related practices help people of all ages to self-regulate, control impulses, and accept oneself fully. Dance movement therapists can help teens with awareness of mind-body connections to maximize behavioral health and increase awareness of personal resources. Give them a sense of pride. Sarah Shulbank-Smith has created a much-needed workshop training for professional music therapists to first facilitate the acknowledgement of their own biases about people who identify as lesbian, gay, bisexual, transgender, queer, plus. Second, to increase communication skills through inclusive vocabulary and awareness of discrimination. And third, to use music-based therapy processes with families to embrace their teenage child's sexual orientation. Let's make it easier. Rosa Mohan speaks of the development of emotional regulation in children with autism disorder through movement. Dance movement therapy has long been acknowledged and respected for the nurturance of developmental growth and healthy emotional experience and expression, and very much so for children with autism. Show them the beauty they possess. Gina Quinlan will present an approach to relational synchrony in dance movement therapy for children with developmental trauma. Healing happens in relationship. This is the underpinning of our program's emphasis on relational cultural theory. Safety and trust are key factors in the healing of trauma. Dance movement therapy addresses trauma non-verbally, eventually leading to verbal expression and awareness of personal strengths. Many thanks to Philadelphian, the late Linda Creed, for her beautiful lyrics that I borrowed. We're very proud of these students for their culminating projects focused on creative arts therapies with children and youth.
Hello, my name is Jason Millard. I'm an art therapist, graduate candidate. This is my culminating project entitled How to Hold a Pearl, talking to kids about intersectionality through story. I appreciate you being here and thanks for staying. Intersectionality, what is it and why it matters? Intersectionality identifies and differentiates shifting aspects of our individual selves and our experiences of bias and discrimination. These aspects of ourselves include gender, race, religion, sexual orientation, preference, our socioeconomic background, and ethnicity as well. The term intersectionality originates from Black queer feminist psychology and theory from the 1960s and 70s. Dr. Kimberly Crenshaw sort of brought up the term intersectionality to date when she started to talk about the differences between intersections of ourselves with relation to layers of the discrimination and discrepancy felt in society from an individual or from groups. In this way, at least from a white male middle class perspective, intersectional theory offers a theoretical and therapeutic stance, a sort of means for locating myself or various selves in various areas of my life. And it sort of represents a practical personal inventory as those situations differ and change throughout the course of a day, a week, a year, or a lifetime. I'm interested in a better way of relating to people where bias, discrepancy, and disparity are at least attempted to be neutralized. And this is particularly important in a therapeutic setting. Here's some of the supporting literature I used in my culminating project. Connectedness is interested in teaching psychologists and mental health professionals about women, gender from a feminist perspective and a transnational intersectional lens. Kimberly Crenshaw really brought the term intersectionality into a modern definition, whereby layers of ourselves and places of marginalizations actually compound and complicate this discrimination felt by certain groups. Dr. Collins is interested in how intersectional theory, intersectionality can become a critical pedagogy or critical theory. And the Combahee River Collective was the beginning of the intersectional definition. Those were the writers and poets, the thinkers of the 1960s, particularly the 70s for this group. The Character Lab at the bottom is an organization interested in teaching elements of intersectionality, though they're not specifically indicating that term. I think that it's sort of implicit in what they're teaching and who they're teaching, specifically with children in an educational way, how to develop values, relationships, and grit to determine what they want out of life and then to go to get it. It represents the more exciting intervention type of work that I believe intersectional theory could really lead to. My project's rationale really was crystallized and solidified by an exhibit at the Philadelphia Photo Arts Center called the Women's Mobile Museum. It was an artist activist program designed really, from my perspective, to impel thought, advocacy, and personal intervention related to systemic issues of power, privilege, and disparity, specifically within an artist's perspective and in the art world or art making community. This show really inspired a conscious intention in me to utilize art and this therapeutic discipline I was learning in a relational and social justice oriented manner as an access point to discussing privilege, and hopefully to narrow some of those disparities, at least in discussion. So why the pearl metaphor? Well, here's my rationale there. Pearls are a sacred object across cultures, histories, religions, and genders. You consider a natural uncultured pearl, an oyster laying in the middle of the ocean that's not being farmed. Those pearls are rarely round, often never symmetrical, blemish-free or white. They're rarely radiant, and they are not produced exclusively by oysters. All these other bivalves and gastropods also produce the pearl. Pearls are a result of a parasite invading that animal in the shell. Essentially, that's a trauma. Pearls are actually platelets the animal produces in self-preservation as a sort of coping mechanism. A full formation of a pearl can take 2 to 7 years. And a gastropod or bivalve is sexually diverse, adaptable, and fluid throughout its lifespan. Often they change gender at some point in their lifespan. So these layers of platelets are actually stacked crystalline material that's in itself very fragile and microns thin. Consider the human hair is about 50 times the width of one platelet layer. So How to Hold a Pearl is really the title of a series of books, maybe 3 or 4 illustrated volumes in free verse. It begins with a father telling a daughter a story of a magical island where you could go and dig up these unique pearls. I've heard of a beach on an island where billions of pearls lay inches below the sand. If you go, dig down through cold, damp sand to find one. Hold it tightly while asking the ocean if you may take it. The ocean will ask one thing in return. Lay under my waves to know this pearl story. In its telling, many answers are given. It's said the ocean's crashing waves show visions of a pearl's life as if in a dream or film. From inside a whirling tornado cyclone, winds and water whip through your hair, The cyclone pushes inside a shell where it hovers from this center. You see a city being built, working from the ground, building upward, laboring years, brick by brick, thousands of feet high.
Everyone, thank you so much for being here. Today, I am delighted to share with you my final master's culminating project, for which I have chosen to write a journal article manuscript entitled Supporting Pediatric Pain Patients and Their Families Through Dance Movement Therapy. Before we begin, I would like to take a moment and thank everyone who has supported me throughout this process. Thank you to my project advisor, Dr. Sharon Goodall. Dr. Goodall, thank you for your guidance and construction. And thank you to my project consultant, Erin Gallagher. Thank you for your support, graciousness, and time. My article centers around the impact families can have on a child's pain and the impact a child's pain can have on families, specifically within the context of a pediatric medical setting, and how dance movement therapy can support the patient and family. My reasoning for choosing this topic is that I wanted to take advantage of the opportunity to study avenues of my academic and clinical interests, as well as incorporate aspects of my clinical internship at the Children's Hospital this past year, which is how I landed on these intersections: chronic pediatric pain, family systems, and dance movement therapy. My article begins with a literature review that provides an overview of pain in childhood and adolescence and family work with pain. We know that pain is a complex experience, and it is a product of the interactions between the biological, psychological, and sociocultural factors, which results in unpleasant sensory and emotional experiences. Childhood pain can disrupt aspects of the family system, but the way caregivers respond to a child's pain has a profound influence on child distress. Additionally, there has been a growing interest into integrated mind-body practices in pain treatment approaches. However, there is little to no literature on dance movement therapy with the pediatric pain population, and none involving DMT, pain, and families. Following my literature review, my article examines 3 different case vignettes from my work with the pediatric pain population. After the vignettes is an informal, non-systematic qualitative analysis of themes derived from the work of 2 dance movement therapists with pain patients. And finally, I end the article with future recommendations. My first case centers around a session I observed of another dance movement therapist working with a patient with amplified musculoskeletal pain syndrome. In the dance movement therapy session, the therapist guided the patient to create a movement narrative of the patient's illness trajectory, which provided a creative outlet for expression and the space to take back control of this patient's personal narrative. The second case involves another adolescent female presenting with functional neurological symptom disorder. Earlier this particular day, she had refused her physical and occupational therapy sessions due to complaints of GI pain. During our session, we focused on pain management, using a breathing technique for coping, and then using props for distraction. From the work with props, she creatively derived and integrated meaning of her current painful and emotional state. The final case focuses on a male in middle childhood whose primary caregiver was his mother. Many of our sessions revolved around his emotional and physical catharsis of his frustrations and discomfort through movement and prop use. With this patient, I focused on his interactions with his mother by using the nonverbal assessment of family systems to highlight the relational resources via movement. The NVAFS was originally developed by Diane Dulikai, but there has not been reported use of it in this context. There was a particular interaction I wanted to highlight where the patient was initially refusing to attend his DMT session, but through relationship with his mother, the patient was the patient was able to get the resources he needed to attend his therapy, which I will show you in the next slide. As the patient's frustration grew, he displayed blocking behavior by crossing his arms over his chest with vehemence, sinking back in with a retreating postural shift away into his wheelchair with passive weight, directly shifting his eye gaze downward. His mother, in return, who was initially on the other side of the room, approached her son with sustainment and directness, accommodating to his crouch with a postural shift forward, crouching down on the vertical plane, and making eye contact with him. The dyad held each other's gaze, and following a verbal prompt, the patient agreed to attend therapy. In the movement interaction, what initially appeared to be a clash actually proved to be attunement, as seen with the NVAFS, as the mother matched her son's energy level and accommodated his blocking behavior. In addition, I would like to juxtapose this interaction with another between this pair. At another point in time, this patient was scheduled for DMT, but he was experiencing pain and discomfort and responded in a more aggressive coping style, which is common in severe illness. I witnessed this patient curl up in a ball shape on his mother's lap. He molded his body against hers as he unipolarly melted into her torso, with his head resting on her shoulder, under her chin. She reciprocated the molding by wrapping her arms around him and gently rocking him back and forth in a sucking rhythm. While the patient declined therapy this day, he was able to receive just what he needed through his relationship with his mom. These nonverbal interactions highlight the findings from the literature that the way a parent reacts to a child's pain influences how a child copes. We can see from the lens of the NVAFS that in this case, the mother's nonverbal behaviors provided her son either the resources and encouragement he needed to attend therapy or provided him the comfort and safety he needed in distress. Following my case vignettes is the informal, non-systematic qualitative analysis of themes that were derived from the work of 2 dance movement therapists with pain patients. These themes included using visualization to help the patient have an internal experience alternative to their pain, using imagery as a coping mechanism and as a path to enter into movement. Another theme is that movement worked as a bridge between imagery and the patient's reality. And additional themes of identity exploration and self-integration, as well as sense-making and meaning-making of the pain manifested within the movement sessions. Another theme was the use of props for creative representation, metaphor development, and coping. Movement also served as a coping mechanism and relaxation tool. And in regard to caregiver-patient interactions, themes of attunement and co-regulation were salient. So, from my work in the pediatric hospital and observations of some caregiver-patient interactions, I have made a few recommendations for the future. It is my belief that dance movement therapy can have a place in this setting to fill the gap of supporting pain patients and their families as an integrated mind-body therapy. Additionally, more literature and research on family DMT sessions with the pain population is needed, and it is further recommended that family system-focused tools such as the NVAFS be utilized for integrated family work and DMT assessment and treatment planning. And that concludes my presentation for my culminating project. Thank you all so much for listening, and if you have any questions, comments, or would like additional conversation, please email me at my email listed below. The following slides will list my references. Thank you.
Hello, and welcome to this presentation of Welcoming Pause, exploring mindfulness-based dance movement therapy with adolescents in a high school setting. My name is Caroline Kinsley, and I'm delighted to share with you my master's culminating project. First, I'd like to acknowledge key supports throughout my graduate career. With you, this was possible. The work with my students at the high school inspired me to pursue this project. I adapted and created this document to explore, learn, and share how a dance movement therapist can integrate components of mindfulness-based dance movement therapy, MBDMT, with an individual adolescent in a high school who is experiencing anxiety. I wanted to write about the experience to increase representation of this population in current literature. At the American Dance Therapy Association conference, I was drawn to Yael Schweitzer's MBDMT work because it was an integrated approach that helped me organize creative, psychological, and mindfulness-derived concepts and bring them into the therapeutic context. I am someone who uses mindfulness practices in everyday life and finds it natural for mindfulness to inspire and influence the dance movement therapy work. When working with the students, I'd often notice how applicable the ideas of non-judgment, presence, and awareness were to promote a sense of safety, trust, compassion, and hope in the therapeutic space. For me, bringing a mindfulness perspective into the dance movement therapeutic relationship is another way to build on the relationship and support the determined goal. This project explores intersections and gaps in the literature of dance movement therapy, adolescent development, mindfulness-based therapeutic approaches, treatment of anxiety and trauma, significant social and cultural considerations, and implications for future research. This was the first time MBDMT was applied at this high school with students managing anxiety, providing a unique opportunity for adolescents to explore and develop coping skills. Based on the 6 MBDMT guidelines and contextual themes experienced in the setting, I provided the adapted set of guidelines, a clinical example of pause, essential considerations, and future recommendations. Based on the contextual themes observed in the high school setting, I adapted the 6 guidelines from MBDMT. In this presentation, I will focus on the guideline pause. As defined by Yael Schweitzer, pause means to slow down, direct awareness inward, create a space between what we hear, see, think, and say, and notice any tension in the body or turmoil in the mind. I discovered how pause was an avenue for developing awareness of exertion and recuperation. Pause provides a way to explore phrasing and exertion and recuperation on a movement level. It is a practice of paying attention to the stillness in between movements. From the clinical example included, I discovered how pause was a practice of discovering one's rhythm of exertion and recuperation, to gain more self-awareness and to connect to their own rhythms of action and rest. Based on the academic, social, and emotional stressors the student was experiencing, developing a rhythm of movement and incorporating pause could support in sustaining energy and help avoid burnout. Knowing when to spend one's movement energy and knowing when to restore one's movement energy, providing insight for coping skills and managing anxiety. Regarding application of MBDMT in the setting, I wrote the key considerations. While the student accepted working with mindfulness, one must not assume that every student will. An essential consideration for future therapists is to invite MBDMT by offering mindfulness as an option, exploring whether a student might be interested or notice if it's initiated by the student. I emphasize the importance of making sure that the student maintains a sense of safety. Through guided prompts, both verbal and nonverbal, the student can self-assess to see if increasing attention to the body feels safe. Regarding essential recommendations, I wrote ways in which I needed to approach the process with non-judgment. I need to set down any ideas of what I thought the session should be, look like, or accomplish. It is helpful to balance letting the process unfold to serve the client's present needs with the intentions to incorporate guidelines from MBDMT. To balance these, one can be transparent of session's intentions and let that guide the exploration with the student's present state. The treatment process is long-term, but sessions are brief. Expect progress to be slow and use the time allotted for deep exploration. Taking time to explore a movement warm-up each session, gradual focus on the body allows for the student to communicate feelings of anxiety, perhaps avoiding feeling overwhelmed. I found the benefit of integrating embodied components of pause without naming it into the warm-up and multiple movement structures throughout the session. Importance to provide embodied experience of abstract ideas such as movement as expression and movement as a way of communicating. From my experience, once these concepts were embodied, the student was able to understand them. I suggest a combined approach with movement experientials and psychoeducation. A combination supports understanding of novel activities and concepts. Last, I would recommend remaining humble in the process. When working with adolescents, the individual is processing a lot on emotional, psychological, physical, social, and spiritual levels. is reliably inconsistent with what expression of the student you are going to get. So look, listen, feel, and attune to the student walking through the door that day, and use that as information to apply what is relevant from MBDMT to your work. To understand mindfulness is to practice it. I invite you to join me as I guide a brief meditation, only participating if you would like. My intention is to provide an experience of welcoming pause. Find a comfortable seat. You are welcome to keep your eyes open, soften, or close them as we begin. Hello. Pause. Pause means to slow down, to direct awareness inward, to create a space between what we hear, see, think, and say. And notice any tension in the body or turmoil in the mind. Meet it with compassion, love, kindness. Notice your thoughts. Can you imagine them passing you by, like clouds in the sky? Something you can see, but not hold, clench, or keep. Let them go. What else arrives? What sensations in the feet, behind the knees, front of the hips, ribs, palm of the hands, front of the elbows, space between your shoulders and ears, your middle brow, center of your skull. Let those sensations go. Let new ones come in. With your eyes closed or a soft gaze, imagine or begin to look at the tip of your nose, slowly lifting your eyes to meet the world outside of you. Welcome back. I thank you for listening to my presentation, and I wish you well.
Hello and welcome to Music Therapy and Counseling for LGBTQ+ adolescents and their families, a training for mental health professionals. My name is Sarah Shulbank-Smith and I am a soon-to-be music therapy and counseling graduate, and I will be going on to work in inpatient psych in Delaware. To situate myself prior to talking about my project, I like to share that I am myself an LGBTQ+ community member. I also graduated from Penn State with a degree in psychology and a minor in gender and sexuality studies. I have worked in the field and specifically as a case manager with young LGBTQ folks who were living with HIV and AIDS. So I have been involved with this population and a member of this population myself for a long time now. Part of what brought me to this topic was that as I've worked with this population, I've realized that LGBTQ adolescents face a unique set of challenges, and I wanted to be part of the solution with my own work. Specifically, LGBTQ+ adolescents are reported to have 1.5 to 3 times higher rates of depression, anxiety, and substance use disorders compared to their heterosexual counterparts. LGBTQ+ young people, their higher risk of suicide and mental health challenges are in part attributable to systemic devaluation and invalidation of the community and their needs. And there is a longitudinal study by McConnell, Burkett, and Mustansky that found that LGBT adolescents with lower levels of family support exhibit higher distress. For my project, I have created a 3-hour workshop proposal. This workshop would presumably become worth credits for continuing music therapy education, which would serve folks who are board certified music therapists at this time. So the topics for the workshop would include an overview of the problem and possible population needs and relevant vocabulary and issues. So this part would be an education portion. For the LGBTQ plus community, the vocabulary is ever changing, but as clinicians, that can be a huge way to build rapport and really validate the identities of these folks. It can also be really important for the therapist to be able to advocate on behalf of the client when working with their family to make sure that everyone is aligned as far as preferred language and appropriate language to use. There would also be an exploration of personal biases and strengths as an LGBTQ plus person or an ally for all participants in this workshop. So that would allow them to really become more aware of their own relationship with this community and ways that they might be able to improve as clinicians. And we would include some music therapy experientials, including playlist creation and blues songwriting. So for the playlist creation, what that might look like is I would encourage folks to create a playlist that represents their journey as an ally or LGBTQ plus person. So that could be, maybe when they first started learning about the community, there would be a song to represent that. And then as they became more comfortable, or maybe when they started to identify as an ally or identify with the community, and, a song to represent where they are now. This would allow people to start to see how you could apply music to your personal journey. And then folks would be able to share that within the workshop and get feedback and discuss how this might be adapted and used with LGBTQ plus adolescents and their families. There are multiple reasons why using music therapy could be especially helpful for this population. Gronska, Bain, and Crow found that music therapy can support expression both individually and within larger social contexts, including families. Music therapy can help queer folks feel empowered by their identities and can help build social skills to strengthen interpersonal relationships. Hardy and Moneypenny spoke about how music therapy can provide many opportunities for feelings of mastery and feelings of involvement and leadership within the therapeutic process that can be really empowering and can make young LGBTQ folks and their families feel as though their voices are valued and heard within the therapeutic process. Whitehead-Plow et al. Recommend that clinicians use LGBTQ plus musicians and artists and explore their intersectional identities through the use of music, whether that be active music making or music listening. Prior to designing my workshop, I wanted to make sure that I was aware of the ways that family therapy might approach working with LGBTQ plus folks and their families. I found that there were multiple possible approaches and that the field is currently leaning towards a more integrated form of family therapy based on specific cases. Some of the approaches include systemic, which views the family as a system in which everyone holds a stake in how the system operates, and postmodern family therapy, which really emphasizes the importance of language and clear communication for overall family functioning. There's also a pre-existing sort of family therapy called attachment-based family therapy that was adapted by researchers in 2013 into ABFT-LGB, which is attachment-based family therapy, specifically adapted to better fit the needs of suicidal LGBT teens and parents. For the workshop, learning objectives include the following. Participants will identify 3 risk factors for LGBTQ+ youth. Participants will identify 3 music therapy approaches for use with LGBTQ+ young people and their families. Participants will convey 3 ways they can make their practice more LGBTQ affirming. In creating these learning objectives, I had to consider what I thought would set this workshop apart, what people could walk away with, and these were some things that I came up with after creating my outline for the workshop. Key takeaways include that working with a historically oppressed population requires education and preparation. It is necessary to use LGBTQ+ clients' preferred language and may be necessary to educate family members to do the same. Music therapy provides unique opportunities to build skills and increase familial support. And when creating continuing education workshops, learning objectives must be specific and measurable. Below are a selection of the references I used to develop this training. Thank you so much for joining me.
Hello, my name is Rosa Mohan, and welcome to my Master's Culminating Project presentation on Empowering the Child, Supporting the Development of Emotional Regulation in Children with Autism Spectrum Disorder through Movement. I would like to give a special thanks to my Culminating Project Advisor, Dawn Morningstar, and all my supervisors I've had the pleasure of working with throughout this program, Lauren Kunkelman, Gail Gates, Nalini Prakash, Jian Yu, and Rachel Fetterman Morales. I have endless gratitude for you all. To provide background for where this project began, I completed my internship at the Center for Autism, where I worked with children ages 2 to 6 years old. My observation and experience working with this population led to my inquiry regarding the challenges children with autism spectrum disorder face in the development of emotional regulation. Identifying this challenge, I then developed movement-based tasks informed by DMT practice to foster the development of emotional regulation through movement. To guide my interest in investigating the influences on the development of emotional regulation, I held the following definition that emotional regulation consists of the extrinsic and intrinsic processes responsible for monitoring, evaluating, and modifying emotions. The extrinsic influences surrounding the child shapes the development of emotional regulation. Like a flower needs an environment rich with nutrients in the soil it is planted in, with plenty of sunlight, the infancy and toddlerhood period is dependent on adequate, responsive social interactions for the promotion of adaptive emotion regulation patterns. The infant-caregiver relationship is the first and arguably one of the most significant social interactions that can either support or inhibit the child's development of self-control of emotions and overall social competence. Then the peer environment provides emotional support and modeling of skills, as well as an opportunity for the child to practice emotional control skills. The cultural context shapes the child's quality and the level of intensity and expression of feeling, and the development of emotional regulation is affected by when, how, and how often the child is physically soothed by their caregiver, which is informed by cultural expectations regarding caregiving practices. Equally as important to consider are the intrinsic influences within the development of emotional regulation. These can be influenced by the growth of specific skills. The first factor is the child temperament. This is informed by their reactivity, meaning their latency, threshold, and intensity of their response to sensory stimulation. This relates to the ability to modulate emotional intensity. Next is attention, the child's ability to sustain and shift their attention, as this is a crucial skill for managing both negative and positive emotions. Effortful control, or response inhibition, allows the child to oppose their predisposition of reactivity by their ability to activate or inhibit behavior in order to behave in accordance with societal expectations. To understand how ASD inhibits the development of emotional regulation, we must first understand the core deficits of this diagnosis. ASD is a complex neurodevelopmental disability that is characterized by impairments in social communication and interaction. Children with ASD often have difficulty maintaining shared attention and have limited attentional control. Restricted, repetitive patterns of behavior, interests, or activities presents a challenge to engage effortful control and response inhibition when tasks are not aligned with preferred interests. Deficits in developing and maintaining appropriate relationships to developmental level impedes growth as relationships are essential for learning. I utilize the assessment method of Kestenberg Movement Profile, which is a multi-layered approach to understanding developmental and clinical aspects of behavior. There are 10 systems total within this assessment model, and for this project, I focused on the following: tension flow rhythms and tension flow attributes. Tension flow rhythms are based on muscular tension and release, which go between free flow, unrestrained flowing body tension, and bound flow, restrained and inhibited body tension, and they support the development of necessary biological functions, as well as other tasks that are significant to our growth, such as emotional regulation. For example, the first developmental rhythm of the sucking rhythm not only supports an infant to find nourishment from its mother, but also promotes a sense of comfort and supports a child to self-soothe from an early age. Tension flow attributes are particular traits that are mood regulating, which reflect manners of change and tension, and they help define qualities of emotions and movement. For example, anger can be held at an even level or fluctuate in levels of intensity, and sadness can appear right away or develop slowly over time. Like a plant requires nutrients for growth, I developed movement-based activities to foster the use of motor qualities, which supports the development of skills for emotional regulation and ultimately enables the child to bloom to their full potential. For example, the activity of blowing bubbles, you encourage the child to pop or catch the bubbles in the air. This movement fosters the use of tension flow attributes, as the child must either take in the space to see the various bubbles or direct their movement to pop or catch one specific bubble. This prompts the child to shift and focus their attention on the bubbles throughout the space, developing this needed skill for emotional regulation. Due to the fact that many children with ASD may be completely nonverbal or have severely limited verbal communication skills, it is understandable why DMT, a body-based form of therapy, is a sensible treatment option to consider when providing care for this population. As dance movement therapists, we support children with ASD establish a sense of safety by using our body to attune and move with the child to communicate to them that they are understood, respected, and accepted. We develop body and emotional awareness by bringing the child's attention to the different parts of their body. We support the child in identifying and connecting physical sensations to states of emotion, and as the child develops this awareness, their body then becomes a resource for emotional regulation. We help our clients identify internal emotional coping resources by modeling the use of internal resources available to the child, such as the use of tension flow rhythms. It is the intention to foster the child's autonomy and develop their ability to attain emotional regulation. We support our clients to discover adaptive external expression of emotion, as every individual experiences emotions, and in response they may exhibit a physical action. The key difference of importance is whether this response is adaptive or maladaptive. Meekham's 2008 stated, DMT emphasizes the externalization of bodily felt emotions in creative rather than destructive ways, aiming to assist the child to recognize and name emotions and develop self-soothing strategies together with appropriate emotional expression. Through this approach, the child is supported to find adaptive ways to express their emotions and feel a sense of empowerment. We foster the use of motor qualities associated with emotional regulation to promote the development of skills necessary for emotional regulation to occur. And ultimately, we support our clients reach their treatment goals. DMT has been found to support improvement in regulatory behavior as well as increase on-task behavior and attention. As clinicians, we hold the profound ability to understand, reflect, and expand the nonverbal expressions of a child to ultimately improve socialization, communication, body awareness, and relational engagement. Thank you for listening to my presentation.
Hello, everyone. My name is Gina. Thank you for joining us today for our culminating project presentations during this unprecedented time of collective discomfort and confusion. Moving on the same wavelength is an informed practice application and approach to attaining relational synchrony in the dance movement therapy relationship. This work was done with children who have experienced insecure or disorganized attachment relationships and therefore experience the somatic and psychosocial effects of trauma. My culminating project is inspired by and dedicated to my nephew, Daniel. Thank you for reminding me to ride the waves of the ever-changing tides, even when there are big feelings involved. I would like to start out by thanking my project advisor, academic advisor, supervisor, and program director, Christina Devereaux, my dance movement therapy clinical supervisors, Sarah Rott, Melissa Greer, Deborah Abrams, as well as my group supervisor, Nalini Prakash. I would also like to thank my undergraduate dance professors for giving space for me to cultivate my connection to movement as a human. Thank you for moving through this experience with me. Moving on the same wavelength was developed and implemented at my clinical internship site in consideration of the students' individual psychosocial needs in therapy. The trauma-informed attachment-based approach to treatment focuses on the role of relational synchrony in the dance movement therapy. This integrated dance movement therapy approach applies fundamental relational practices in DMT to cultivate the power of the therapeutic relationship as an agent of change. This will further be explored in a contextualized case vignette examining dance movement therapy with a child with insecure attachment behavior due to relational trauma who has been given several behavior-related mental health diagnoses. For context, attachment is the process by which infant and caregiver bond to one another through a positively attuned relationship, including proximity, touch, matching vocal tonality and pitch, and reflecting speed and intensity of movement. The development of early attachment relationships informs infant ego development and the capacity to co-regulate, which develops into the child's ability to self-regulate. Relational trauma may occur when there is physical or emotional abuse and/or neglect, or in the case of inconsistent, unreliable, or chaotic, disorganized attachment relationships with primary caregivers. When occurring in early infancy, the effects of developmental trauma may affect development of positively attuned attachment bonds, as well as a child's ability to safely relate with others. These effects can last throughout the lifespan. Bridging early life experiences with the practice of a trauma-informed, body-based approach to therapy, moving on the same wavelength emerged from lived experiences and knowledge gained through the presence of the dance movement therapy relationship. The following elements are essential pieces of this approach that are salient to the informed practice application. Moving on the same wavelength draws from a neurosequential model of treatment that focuses on the effects of trauma on lower brain regions, which govern functions of feeling safe and engaging in relationship. The role of attachment in the therapeutic relationship emerges through co-regulated movement experiences. By joining the child in their experience, matching their movement through spatial and rhythmic synchrony, as well as attuning to elements of flow and intensity, we are able to cultivate the development of safety and trust within the therapeutic relationship. Through shared intersubjective movement experiences, the child and therapist engage in a synchronous and mutually regulated relationship. To briefly describe the development of this relationship in my work, I will present a vignette of a client I will call Miles. Miles has a variety of behavior-related diagnoses, including ADHD, mixed anxiety, and avoidant behavior due to the early loss of primary attachment figures. Miles was viewed as impulsive and aggressive in his classroom and referred to me for dance movement therapy for, quote, moving all the time. After establishing physical and psychological safety within our therapeutic relationship, Miles presented a shift in his attachment behavior. He began ending each session by wearing my shoes back to his class to help him transition, and seeking closer proximity during and outside our therapeutic setting. This shift emerged from my meeting Miles where he was at and mutually regulating in movement through relational elements of space, time, and intensity, versus a structured therapeutic intervention that may have been met with resistance, fear, or reactive hostility. His initiation of wearing my shoes represented a newfound capacity to feel safe in a relationship, which was essential in addressing his experience of the effects of relational trauma. In the project, another element of the therapeutic relationship is explored through a second vignette, which is not included in today's presentation. Moving on the same wavelength employs the role of the therapeutic relationship in generating corrective emotional experiences within positively attuned interpersonal engagements. Through a positively attuned therapeutic relationship, the child can experience the reenactment of an attachment rupture and repair with the therapist in the role of the secure base. Of course, unfortunately, experiencing sudden termination of these therapeutic relationships due to the global pandemic affected the completion of this approach in its intended format. However, I can still say that changes in children's behavior over the course of therapy may imply that relational synchrony via rhythmic body action and attunement in dance movement therapy serves as the foundation of experiencing a positively attuned relationship. To close, I would like to briefly mention a creative exploration I engaged in after the sudden termination of my therapeutic relationships due to COVID-19. I found myself grieving the loss of my clients as an attachment figure. I resonated with the movement qualities and tone of Jose Limon's choreography in Dances for Isadora, Niobe, which was choreographed for American modern dance pioneer Isadora Duncan's grief over the loss of her child. I resonated with this mourning, and this creative movement exploration assisted me in my grieving process in this time of collective trauma. I hope to continue the development of this approach in my practice as an emerging clinician working with children with similar biopsychosocial histories. Eventually, I would like to engage in the research examining the role of rhythm in relationship within the therapeutic relationship with clients with relational trauma. My hope for my clients, present and past, is for the developmental trauma diagnosis to be officially applied to children's diagnoses to better serve them and their healing. Thank you again for joining me today in the presentation of my master's culminating project.
Hi, everybody. Welcome. My name is Dawn Morningstar. I'm in the Dance Movement Therapy and Counseling faculty.
And I'm Michelle Rattigan, and I am the Art Therapy and Counseling faculty.
And we're really excited to talk to our panelists today, our presenters today. We're going to take a quick minute. I'd like each one of them to introduce their name and what their presentation of their culminating project was. I'm going to start with Selena.
Hi, everyone. Thank you, Dawn and Michelle. I am Selena Demio, and my culminating project was a journal article on supporting pediatric pain patients and their families through dance movement therapy.
Thank you. Jason?
Yeah, hi, everybody. Jason Millard, culminating project How to Hold a Pearl, talking about intersectionality with children.
Thank you. Sarah?
Hi, everyone. My name is Sarah, and I presented on music therapy and counseling for LGBTQ+ adolescents and their families, a training for mental health professionals.
Rosa.
Hi, my name is Rosa. My presentation was on empowering the child, supporting the development of emotional regulation with autism spectrum disorder through movement.
Thank you. Caroline?
Hi, everyone. My name is Caroline Kinsley, and I presented Welcoming Pause, exploring mindfulness-based dance movement therapy with adolescents in a high school setting.
And last but definitely not least, Gina. You're on mute, Gina. Okay, Zoom, you know.
My name's Gina, and I did an informed practice application and approach to relational synchrony in dance movement therapy with children who have experienced developmental relational trauma.
Excellent, thank you. So while we're talking about Zoom, this is our general question for you all. So has anybody been using Zoom or telehealth, other telehealth models with children specifically, and how has that been working out? What are some of the discoveries that you had? Pros, cons, those types of things. Anyone can start.
So I'll go. I have had the opportunity this spring to transfer my internship online, and we did a telehealth type. It wasn't necessarily actually telehealth, but it was support for the students, and I was with adolescents. And I think the biggest challenge was just the executive functioning of often I think I take for granted of when I schedule something and I follow through with it. This is something that adolescents are definitely working on at this developmental level. And so the executive functioning was and planning and committing to the schedule was definitely a challenge that we worked through.
Is anyone else?
Yeah. Go ahead. Okay. Yeah. I was doing some telehealth for my internship with both adolescents and children. And I think one of the challenges was, co-creating music because we had to deal with the lag. But we were able to find some ways around that and do things like music listening, music guided relaxation, things like that. And I ultimately found that people were really responsive and engaged in the process.
Thanks, Sarah.
Yeah. And Rosa, you were going to say something?
Yeah, I was fortunate to have the opportunity to do telehealth therapy at the Center for Autism. And what I found to be really successful was giving choices and fostering the child's autonomy and giving them that sense of control. And it really helped them, I think, engage in the sessions and also cope with what's going on in the world right now.
Great. Well, we have some specific questions that we'd like to ask. And the first one I have is for Caroline. Since this is a mindfulness-based dance movement therapy experience, is there a focus on frustration tolerance, relationship success, etc., as well as grounding?
I think Caroline might be frozen.
I think Caroline is frozen. We are going to move on. Jason, I have a question for you. We'll come back to Caroline. People were really interested in how you created the illustrations, if that was digital, if that was collage, and also have you used this metaphor at your internship? So if you can speak briefly to that.
Yeah, sure. Thanks for the question. In lieu of my original wanted to do traditional artwork, drawings, illustration for the book, being home and doing the telehealth, I just felt motivated to create images that were done digitally and really started to work with the idea that this could be a way, this sort of narrative intervention with these images that I would find in the public domain could really be a complete style of creating these illustrations. And I guess so I really wanted to make it as simple as possible. So inside a raster application, which in Apple, it would be preview, maybe, I don't know what it is for PC, but I would just open that window up. I would play around with editing, cutting, copying, and pasting images on top of one another. You can manipulate, that technology's come pretty far, so you can do transparency masks and work with the intensity of the image. So I have not, though the second part of that question, I have not worked specifically with this metaphor. It's developed in a concentrated way only in the last 10 weeks, 11 weeks.
Well,
so I'm looking forward to using that, though.
Yes, absolutely.
Okay, do you want to flip back to Caroline? She's back now.
Yeah, so Caroline, the question was, in your work with the mindfulness-based dance movement therapy, does it also work on frustration tolerance, relationship success, as well as the grounding.
Yes, and as I was answering, thank you for your patience. I said it's all of the above. It depends on the intention of who you're working with, what are they presenting with, and what are your goals. And you can add that in with the mindfulness to do all of the above is the short answer. I'd like to get into specifics, but yeah.
Excellent. Thanks, Caroline. All right, this is for Selena. Selena, what is the unique role of families or caretakers in working with children through the creative arts?
Oh, that's a good question. Thank you.
Let's go DMT specific.
With DMT. That's such a broad question too. So I think parents and caregivers have a really special role to play in fostering that creativity, especially early on in development, and creating a space for freedom, kind of like a container for kids to be able to explore in the ways that the child wants to explore, but knowing that they always have that secure person to come back to. So kind of, I guess in terms of freedom, the freedom continuum of giving them the room to go off and explore and be creative, but knowing that they have the safety and a person to come back to.
Great, thank you. Sure, Sarah, I have one for you as well. I had to find it. So did you work with LGBTQ teens at your internship, and how that informed your project in any way?
I did. So my internship was a general behavioral health intensive treatment facility. And it wasn't that I had a specific group of LGBTQ plus adolescents. It was more that, adolescents were wanting to have conversations about that topic in group. And I found it really exciting to be able to have those conversations. And that was a big part of what led me to this subject. So, originally pre-COVID, I had intended to actually do some groups with families and LGBTQ adolescents. But ultimately, as I, looked more into the research, I got excited about the idea of training other professionals to be having these conversations that I felt like were a really important part of the therapy process.
Thank you. So, Rosa, I have one for you. I'm just noticing we have a couple minutes, so make sure we get to these. Rosa, how does stemming play a role in motorization and emotional regulation, and can it be utilized for the child in dance movement therapy?
Yeah, so I didn't see any of that discussion in the literature, but I will say I have seen how stemming can be used to regulate a child and how it can help them self-soothe. And so I definitely think there is room for discussion on how that can be utilized in a DMT session in the room with the child to help them regulate and find more adaptive ways to use it.
Excellent. Gina, we have a question for you. Are you able to give an example of an attunement intervention?
An attunement intervention. I don't think I have a specific intervention, but I the baseline and the foundation of this approach and the work is really energetically and then vocally. So physically, vocally, and kind of just at this other rhythmic level that's kind of understood between the relationship, that meeting the child just exactly where they're at, not asking them to do or be or change their movement, actions, or behavior, but just being with them in that and taking that and molding that into something that is safe if they're not being safe.
Great, thanks, Gina. And so our final question, and this is for all the panelists, is how will your learning through this process influence your clinical practice? That's a big question, I know.
I'll go and just say that I think the crux of this whole process for me, and at the end, this is kind of my oath to, as a therapist, as an artist, and as a human, that my intention is to hold people and their experience as completely unique and as sacred and fragile as and beautiful as a pearl.
Thank you.
I'd like to say that like doing this work during this time of global crisis has like just taught me a lot about myself and about clinical work, obviously with like telehealth communications, but also just with like my project being so focused on attachment and then those attachment relationships suddenly being terminated and cut off. That was really informative to my project and just about attachment relationships and in my own personal processing of that as well. And I spoke about it briefly about how like movement and creativity was one of the things that actually helped me cope through this time of uncertainty and fear and collective trauma.
Yeah, I will say that what I learned is really the importance of creating a safer space for LGBTQ plus adolescents. And something else that I read from the Family Acceptance Project was the importance of treating family members like allies rather than adversaries and really inviting them into the conversation and working towards a shared goal.
I would say going off of that with Sarah, similarly, when working with especially children and adolescents and their family members, looking at the strengths within the family system and those relational resources and working to support and encourage those rather than trying to find the things that may not be as beneficial because there are strengths there. So just working to pull those out and appreciate them.
And I'd like to add as we're wrapping up, I hope one of the things that you all discovered was your amazing resiliency throughout this process. You did it. We're able to complete this in the middle of a pandemic. And we are just so proud of you. So thank you for everything that you're doing, have done, and we are just so excited to see what you do in the future.
Round of applause.
Round of applause.
Well done. Thank you very much, everybody. We're going to take a little bit of a break, and we'll be back soon. Bye, everybody.
I wish I was a tea drinker, jasmine green in the afternoon air. Pour me a cup with a novel and some freshly sliced pear. But me, I just drink coffee, run around circles through my house till I am exhausted, having gone nowhere. Am I going nowhere? But we are not clay that's cooled. We are not unchangeable. I cannot live like this forever, and neither can you. I wish I was a morning person. Wish I rose with the sun. Greet the day, hear the birds in the beautiful gray morning light. Instead, I waste away into the night. But we will never be grief and lies. Just you wait. 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 I wish I was a tea drinker, jasmine green in the afternoon air. Pour me a cup with a novel and some freshly sliced pear. But me, I just drink coffee, run around circles through my house till I am exhausted, having gone nowhere. Am I going nowhere? But we are not clay that's cooled. We are not unchangeable. I cannot live like this forever, and neither can you. I wish I was a morning person. Wish I rose with the sun. Greet the day, hear the birds in the beautiful gray morning light. Instead, I waste away into the night. But we will never be Just you wait. Just you wait.
Hello, everyone, and welcome back. If you're just joining us for our program this afternoon, I'm Dr. Sherry Goodill, Chair of the Department of Creative Arts Therapies.
Hi, everyone. My name is Abby Dougherty. I'm Assistant Clinical Professor in the Creative Art Therapies program, and I was the chair of the awards committee. And we had many wonderful submissions from all of our advisors, faculty, supervisors. We had many submissions, and we look forward to celebrating with you.
Before we head into the awards ceremony, we're very pleased to bring you special messages. These are pre-recorded messages from Dr. Laura Gitlin, the Dean and Distinguished University Professor in the College of Nursing and Health Professions, and Dr. Stephanie Brooks, the Senior Associate Dean for Health Professions and Faculty Affairs in the College of Nursing and Health Professions.
Hello and welcome students, faculty, staff, families, friends, and significant others. I'm so pleased you're having this virtual celebration, and thank you, Dr. Goodall, faculty, and professional staff for inviting me to say a few words. Graduation is an important accomplishment, and we are honored to honor you and recognize and celebrate the success of all 35 of our graduates, even if we have to meet via Zoom. And what an extraordinary time to graduate. I think you would agree. You are graduating in one of the most unprecedented and important historical moments of our lives. Many are referring to this as a watershed moment, an inflection point in our country, and I would agree. We are living through COVID-19, which has made it impossible for us to continue to ignore long-standing health disparities as Black and African Americans are disproportionately affected and dying from the virus than whites. We are living through brutal deaths shown through video recordings and social media, which is documenting modern-day lynchings of George Floyd and many other Black men and women, some of whose names we know, and many we will never know. We are living through the growing strength and sophistication of community-based grassroots organizations such as Black Lives Matter, which began in 2012 with the death of Trayvon Martin, along with the birth of many other organizations that are now advancing concrete, actionable platforms for social justice and giving voice to those previously voiceless and articulating in ways that have not been articulated before changes to the structural, cultural, and systemic racism affecting people who are Black, African American, and Brown. the racism that forms the fabric of our country, woven tightly over 400 years, and which we are all a part of and party to. So this is a critical moment for each of us. It's an existential moment, and you have to figure out who you are at this moment. It's transformative in every sector, and particularly ours, health. How we deliver healthcare now and into the future, and how we heal our communities has to be a part of this critical moment. So by all of these accounts, you can see that our country and the world desperately needs you and awaits your leadership, your attention to health inequalities, your understanding of science, and your use of the best evidence and creative modalities to heal individuals and communities, each of whom reflect different life experiences, values, understandings, and exposures to racism and discrimination that make people literally sick. I have been informed of the topics of some of your final projects, and these have examined some of these issues, such as social justice, responses to trauma, and resilience. So bravo, your growing knowledge and skills are essential, perhaps more than ever. In 1966, at the second annual convention of the Medical Committee for Human Rights, which was held in Chicago, the Reverend Martin Luther King Jr. said, "Of all forms of inequality, injustice in healthcare is the most shocking and inhuman." But 54 years later, this statement still rings true in the United States, where healthcare is not considered a human right. As our new leaders in healthcare, I ask that you work hard to right this wrong and change our healthcare system, which is one part of the system that has perpetuated racism. And if you have any doubts about the possibility of making a difference, I leave you with an old African proverb that I learned from one of our students who graduated a few years ago with a PhD in nursing science. And the quote is, "If you think you are too small to make a difference, then you haven't spent a night with a mosquito." So graduates, go change our healthcare world. And once again, I extend my heartfelt congratulations, and I look forward to learning of your career journeys and your successes as they in turn enrich all of us. Thank you.
Congratulations, class of 2020 from the Creative Arts Therapy Program. This is Stephanie Brooks, the Senior Associate Dean of Health Professions and Faculty Affairs, and I just want to say a few words to acknowledge this very important transition in your lives, and also hopefully provide some words of encouragement to you. I just want to tell you a little story about how I arrived at this place. If any of you attended the orientation 2 years ago when I talked about the importance of having your own mission statement and purpose, which our dean refers to, one of the reasons that I transitioned out of clinical work and started teaching is because I realized that I could have a greater impact on direction of behavioral health or human service delivery. I was very unsatisfied with my observations of how services were delivered in my community, which was Newark, New Jersey at the time, and then subsequently in Philadelphia. My intentions at that time was to open up an agency where I could provide full services, including behavioral health, the social service agency, services to the community as well. After grad school, pivot, and when the opportunity presented itself, and although I never planned to be in academia, that seemed to be the place that I needed to be, and it very much connected with my overall mission. I say that because what I realized is that I could have a greater impact on how clinicians think, that I could begin to plant seeds earlier on in their career, that with the hope of that it would somehow help them to be more thoughtful, more client-centered, more culture-centered, more politically centered in how they delivered work. My students in couple and family therapy for many decades, I've always acknowledged that to be a therapist means that you have to be political. There's no separating the two things together. One cannot provide clinical service without really understanding the larger systems and structures that our clients are impacted. So what I want to say to you is what's going on right now in the world provides an opportunity for you to make big impact, significant impact on how things happen in the workplace or any other institution that you're involved in. That structural racism and inequality and environmental justice have been issues that have been haunting our union, if I think about it in a larger picture, because this is not just a people of color issue, this is a world issue. And I want to encourage you to seize the moment, to be intentional about what it is that you want to have an impact on, to focus in that area, really be intentional about it, and move whatever you believe is a barrier to equity, fairness, justice, access, quality services forward. So again, congratulations, and I wish you the best. And please feel free to reach back out to me at Drexel if I can do anything for you as you navigate your next steps. Thank you.
And welcome back. Now we will go through our formal process of talking and providing names for the awards.
Our first award, our first departmental award this afternoon is the Teaching Promise Award. And this is awarded to a graduate of our Creative Arts Therapy PhD program. The award is given to recognize consistent dedication to teaching and advising students, inspiring students to actively participate in their learning, proposing innovative and cutting-edge curriculum and pedagogy, and contributing to the advancement of overall student education in the field. On the behalf of Program Director, Dr. Yoka Bratt, it is my pleasure to confer this award to Dr. Erin Milrod. Congratulations, Erin.
Okay, our next award is the MA Leadership Award. And this award is given to a student who has demonstrated professional initiative and leadership in the program, department, college, in the profession or community, or in the development of a new clinical opportunity. And our winner is Brittany Henderson. Congratulations, Brittany.
The Master of Arts Artistry Award recognizes and honors significant arts involvement while in the MA programs. And there are more than one recipient of this award this year. They are Gina Brockway, Anna Cephas, Sarah Doan, and Laura Tant. Congratulations to all of you.
Okay, our next award is the MA Service Award. And this award is given to a student who demonstrates civic engagement, volunteerism, and community responsiveness in the context of the program, department, profession, college, university, or community. Emma Sadler, Sarah Shulbank-Smith, and Emily Wexler. Congratulations. And our next award is the MA Clinical Excellence Award. This award is given to recognize a student who has demonstrated exceptional performance during the clinical internship and excellence in the provision of patient-client care. Anna Cephas, Caroline Kinsley, and Emily Wexler. Congratulations.
The MA Culminating Project Award goes to a graduating student or students for exemplary work in the MA Culminating Project, considering innovation, scholarship, relevance, and potential contribution to the field, critical and creative thinking, ethical practices, integration of theory, research, and practice, and excellent writing. The recipients of the Culminating a Project Award this year are Kara Hurtnecki, Natalie Maeda, and Laura Tant. Congratulations.
Our next award is the MA Overall Achievement Award. And this award recognizes outstanding overall achievement, including and not limited to academic standing, demonstration of dedication and tenacity of learning, and an exemplary attitude and behavior within their peer cohort in scholarship, service, and clinical experiences. Emily Allison, Ashley Caldero, and Esther Hermes. Congratulations.
The next award is a new award. This is the inaugural award for the Diane Dulac Award in Dance Movement Therapy. This is given in honor of Dr. Diane Dulac, the first director of the Dance Movement Therapy program at Hahnemann Medical College and Hospital in Philadelphia, now Drexel University. This monetary award is presented to a Drexel University graduate student whose thesis, capstone, culminating project, or doctoral dissertation has built upon or advances the work of Dr. Diane Dulac. You can learn more about the work and career of Dr. Dulac on the back cover of the program for the day. It is my deep pleasure to announce that for the first time, the Diane Dulac Award goes to Selena Demio. In giving the award, it is also my honor to here provide some words from Dr. Dulac's husband, Selena. This is the message from Mr. Jim Dulac to you. Congratulations, Selena. I am delighted that you are the first recipient of the Diane Dulac Award for Dance Movement Therapy, an honor that has waited 3 years for a worthy recipient, and that's clearly you. I'm also moved to tears, quite literally, by the work that you explained so clearly in your presentation. Diane's focus on research reflected her intellect. Her focus on children reflected her heart. You, like Diane, have integrated the two, and in doing so have, again like her, helped to ease pain and support families. You were right in your presentation to thank your patients as the greatest teachers of all, because from them will you continue to learn, even after your academic work that is now culminating. I hope that your career, like Diane's, will inspire others toward further research and that will contribute to the welfare of those you serve and thereby advance the cause of dance movement therapy and honor your mentors at Drexel. Again, congratulations.
Wonderful. And now we're going to offer who was inducted into the Alpha Eta Honor Society, which is the National Honor Society for the Allied Health Professions.
Emily Allison.
Ashley Caldero,
Lauren Dobbins,
Esther Hermes,
Brittany Henderson,
Kara Hartnetke,
Caroline Kinsley,
Natalie Maeda,
Sarah Shulbank-Smith,
Emily Wexler.
This does bring to a close our conferring of awards.
Congratulations, everyone.
We now invite in Dr. Natalie Carlton with some special acknowledgements. Dr. Carlton.
Hello. I think you can see me and hear me. I'm not getting the feedback visually that you are, but welcome everybody. And a little bit of latency today, but otherwise I can't say how proud we are to see everything flowing as well as it can. Technology is affording us a chance to come together and share so many great works. I can't say thanks enough to all the students who really poured a lot of heart and content into your presentations today. Well, first of all, into the topics, into your work with your advisors, into the work researching materials in your topic area, and ultimately what you created as amazing presentations. I want to give a special thanks to several people besides the students and your hard work. I want to say a special thanks to all the advisors, persons who worked with alongside students in developing their topic areas, developing their culminating project papers, as well as the presentations today and the creative-based projects with which they explore the topics of their focus. Advisors, you've done an amazing job alongside students, and I know in my work as an advisor this quarter, I've really been excited and just so pleased to see how topics have developed, how my students have really pushed back the anxiety and the low focus of these times, these very concerning times, and were able to find their way in scholarship as well as in creativity, and really engaging the topic in an arts-based way. Many of the projects had to shift and change, so advisees and students, we did a lot of shifting and changing and showed a lot of fluidity, and I want to say thank you to us all. A special thanks to today definitely goes to Arun Ramakrishnan. Arun, our great wizard of CNHP, and also a dear collaborator to the CATs. We would not be able to broadcast in this quality way without you. So thank you very much. Thank you to Michelle and Dawn, Michelle Rattigan and Dawn Morningstar. Your facilitation of the Q&As have been so textured and detailed and on time, on point. A very special thanks to you both and to the students so far in Module 1 and Module 2. Those Q&As, they were robust and really well received. Thank you very much for answering questions and taking comments. And also a special thank you to Megan Dickinson and Claire Picard. Megan and Claire are continuing creative arts therapy students, and they assisted with the creative works, which you have been experiencing in the breaks. There's been musical selections so far from Cynthia Hopkins, James Levino, Esther Hermes, and Gina Brockway. I feel like I'm messing up your last name. I apologize for that. But the musical, the audio tracks have been amazing. Thank you for your contributions. Also, Sarah Burgess contributed visual images, still images, a series of artwork she did in response to our lives going on online this quarter, and a response to screens and our interactions with screens. Also, there were short videos. We had a little bit of technical trouble in the beginning of the program this morning earlier, but short videos made by faculty, Michelle, Flossie, and Dawn. A special thanks for that short video. Gopi Shah contributed a short video also about technology and nature, and a short video by Sarah Burgess as well. Thank you, Creative and Tech Committee, again, Megan and Claire and Scott, you also assisted us. And thank you to the artists and the creative persons who contributed those works. Janika Griffin, thank you for jumping in with Dawn in the pre-show warm-up. That was amazing, and such a nice, powerful way to start and to ground into our program. Persons who you're not seeing on screen or hearing from today are Cade Haskins, our admissions coordinator for Creative Arts Therapy, and also Kristen Noreen, who is our program coordinator for the Creative Arts Therapies. Cade, thank you very much for your support and advocacy, in this process. You're always very positive stance about our students and all the amazingness that they bring. Kristen, a very special thanks for getting our program together and working with the website and sort of the larger communication out to everybody. So a special thanks to you. Everybody, it makes my heart proud to have developed this alongside a team. A team is never made of one person. It's always made of multiple capacities, limits, talents, skills, and I'm very proud to be a part of this community we call Creative Arts Therapies in the College of Nursing and Health Professions. Special shout out to our college, and also within Drexel University. In these times, there is so much stress, there's so many unknowns, and a lot of sadness and grief and great concern. But it's a real pleasure to showcase creativity. It's a real base and strength and power that we have to speak, to show, to share, to put alongside, and to be active participants in this world. And I thank you very much. May the show continue. We've got about 3 minutes just to point your attention to time. We're going to restart with module 3 at 3 p.m. It's 2:27 now on the dial. So stay tuned. In 3 minutes, we will resume our program with module 3, Creative Arts Therapies, responding to trauma and resilience. Thank you very much.
Hello, and welcome to Module 3, Creative Arts Therapy's Responses to Trauma and Resilience. For those who do not know me, I am Scott Horowitz, Assistant Professor and Director of Field Education in the Department of Creative Arts Therapies. If you are joining us at the start of this module, you will soon view and listen to 6 graduating CAT student presentations based on their graduate culminating projects. You are viewing this 2020 Creative Arts Therapies Colloquia content being broadcast live on a private YouTube channel. You can listen and view these presentations in their pre-recorded sequences, and you may wish to add questions or comments in the chat box function. To share any questions or comments ahead of the small group discussion ending each module, you must log into YouTube via a Google or Facebook account. There are live Q&A sessions with all presenting students and 2 moderators at the end of each module throughout our program. As the title suggests, this module focuses on the power of the arts and creative arts therapies to support various experiences of trauma and foster resilience in coping and moving forward in our lives amidst and despite those traumatic experiences. Although not the focus of our presentation today, I would be remiss if I did not acknowledge the trauma that nearly everyone in the United States and beyond have experienced recently between the COVID-19 pandemic and the murder and violence experienced by Black communities and the subsequent responses of protests and riots. These are critical moments in our collective history, and while not minimizing the importance of the work ahead, part of that work will involve tapping into opportunities for resiliency and recovery. One simplistic definition of resiliency is the ability to bounce back from challenge and the importance of self-care and community care in that process. As the title of a prominent book related to trauma and psychology written by Dr. Bessel van der Kolk acknowledges, the body keeps the score. This helps to illustrate the fact that traumatic experiences affect individuals on all levels, cognitively, emotionally, physically, etc. For this reason, creative arts therapies are perfectly situated to address the mind-body connection that is so essential to supporting trauma, recovery, and development of resiliency. The range of projects that you will hear about during this module address these issues from a variety of perspectives and also will illustrate how movement, art making, and music making can be utilized to support the needs of our clients, our colleagues, and ourselves. I do want to acknowledge that some aspects of these presentations may have potential to trigger strong personal emotional responses and encourage you to take a break or step away from your screen for a moment to care for yourself as needed. We will begin with a discussion of embodied trauma and movement in art, representing one potential intersection of our arts modalities. Next will be a project which brings together the importance of family systems as applied within a music therapy context. Following that, we will hear about a project which focuses on a grant application to support the assessment of a body-based approach for PTSD. This will transition to another project focused on PTSD among women and the integration of music therapy and narrative therapy. Our 5th project will address how mindful art can be a tool to combat compassion fatigue in healthcare professionals. And finally, our last project explores the use of DMT, dance movement therapy, in supporting survivors of human trafficking. Each of these projects alone presents a meaningful area of work in our topic of CAT responses to trauma and resilience. However, I believe the combination of these projects within this module, as witnessed by audience, will represent a very powerful experience for all. One final reminder to please enjoy the presentations, but be mindful of what internal responses you experience, what you may need, and what aspects of resiliency you have at your disposal and can tap into as needed. Thank you.
Embodied Trauma and Movement in Art, a culminating project by Lauren Dobbins, advised by Michelle Rattigan. This journey started for me nearly 2 years ago when I first read from The Body Keeps the Score by Bessel van der Kolk,
which was assigned as trauma coursework. His work was a revelation to me, that the body has its own language and holds its own information. And in actuality, our lived experience comes from our mind-body, which is a continuous network of information being continuously looped from our body to our brain to our body. This compelled me to start exploring how trauma not only affects the body, but how the trauma is held in the body. I wanted to investigate what stories our bodies were sharing that our words could not. Embodied trauma and movement in art. Trauma affects the human organism in its entirety, including the mind, body, and brain. Psychological trauma has been defined as an individual's inability to cope after an event or series of events. As of now, the American Psychological Association only recognizes PTSD, post-traumatic stress disorder, and the DSM-5. However, many professionals promote that there be a spectrum of trauma-related disorders, including developmental trauma, complex post-traumatic stress, and post-traumatic stress syndrome. For the purposes of this presentation, trauma will be defined and accepted as any event or conditioning resulting in neurobiological and physiological disruptions affecting an individual's capacity to cope after the exposure has concluded. When threatened or injured, all animals, including humans, react in somatically based responses to protect and defend oneself, engaging the nervous system in a fight, flight, or freeze response. An individual with PTSD has a nervous system that remains in a state of acute and then chronic arousal and dysfunction and becomes stuck in a hyper-aroused or disassociated state. Many individuals who have trauma often have difficulty understanding their emotions and feel disconnected from their bodies. Somatic-based trauma protocols assist individuals to cultivate mindfulness and body awareness to refocus attention to their relationship with self. For individuals with trauma, a bottom-up approach is proposed as an optimal entry point for healing. Bottom-up processing involves resetting the autonomic nervous system originating in the brainstem through breathwork, movement, and touch. Trauma can come from a multitude of experiences, like sexual assault, domestic violence, tragic accidents, war, forced migration, natural disasters, or growing up in a neglectful and chaotic home. However, I would like to open up the dialogue of trauma and give recognition to individuals with lived experiences of being LGBTQIA+, persons of color, women, and individuals with disabilities or alter-abled who have had their freedom of mobility and safety in the world constantly threatened simply due to their identity. These experiences have undoubtedly affected the mind-body. I also want to note the shared experience of fear and immobility many of us are experiencing now due to COVID-19. Starting with a body-focused warm-up, like a body scan or sequence of stretches or a combination of both, helps to begin bottom-up processing by bringing awareness and attention to the body and sensory information. From there, the participant will transition into movement and art making. The session is concluded by a debriefing experience, which engages cognitive processing through a questionnaire. For this project, I used paint and paper along with non-traditional art making tools. I implemented the use of a balloon, squeegee, rubber gloves with sponge palm pads, a glass bottle, and a drawing tool I made from a piece of wood and multiple crayons attached. After a body-focused warm-up, the participant will transition into art making showcased by this video. By engaging the body and movement in a safe and controlled environment, giving the participant autonomy and choice allows for exploration of physical connection and safety. For those who are desensitized, it can be an experience of activation, awakening, and play. For those who are overstimulated and hypervigilant, it can be a release and an opportunity for mindfulness in the present moment. Having art making function as a mediator between the participant and body movement allows for expectations of outcome and self-consciousness to be suspended, promoting an immersive movement experience. Through non-conventional art-making tools, expectations of outcome and appropriate use can be suspended, allowing for more dynamic movement, experimentation, and creative expression. If we think of therapy as a microcosm, then the sessions transform to represent a safe space for mobility and expression. This is reparative action. Please note that movement can be modified to accommodate participant ability. After art making has concluded, the participant will be provided with a questionnaire to assist reflection on the art making. I appreciate the checklists provided by Virginia Barclay Goldstein in her book, The Magic of Mess Painting. She provides multiple checklists where individuals can use a rating scale to represent felt sensory and emotional experiences that came up for them while making art. This book is referenced at the end of the presentation if you would like more information. Using a checklist like Goldstein's after art making helps to connect the participants' physical sensations, movement, and emotions with one another. By working first with the sensory and kinetic movement and then crossing over to cognitive processing, allows for deeper understanding and integration of the mind-body relationship. Embodied trauma and movement in art. This is just the beginning of this work for me. I have future goals to work interdisciplinary, connecting with dance movement therapists, music therapists, physicians, occupational therapists, and neuroscientists to further explore trauma work through art making and movement. Materials and space can be continued to be explored. I want to continue investigating the effects different tools and space allowance have on movement and art making and the release of trauma from the body. This method was initially intended to involve multiple sessions capturing the evolution of art making and trauma narrative through movement. However, after conducting this project, I see future possibility for continuous art making to occur sequentially moving from movement-based to more cognitive work, such as collage or narrative exploration, to continue to transform and overcome trauma. Embodied trauma and movement in art, a culminating project by Lauren Dobbins, advised by Michelle Rattigan. Many thanks to my friends and family for your continued love and support, to my incomparable cohort and encouraging faculty, and special thanks to my advisor, Michelle Rattigan, for your guidance and grace.
My name is Anna Cephas, and I'm a student in the Music Therapy and Counseling program. For my culminating project, I focused on combining an internal family systems framework with music therapy approaches in supporting the needs of adults with histories of complex trauma. And I'll just start with some definitions, beginning with complex trauma, which is usually defined as exposure to multiple traumas or stressful events, usually at early developmental stages and within the context of early attachment relationships. And symptoms can show up in domains of emotion, such as difficulty identifying or regulating one's own emotions, behavioral, such as impulse control, and cognitive, such as issues with memory and focusing, as well as many others. And just focusing on the relationship element of that definition, our early relationships or attachments to primary caregivers are so essential to our physical and emotional development. We rely on our caregivers to help us identify and regulate our emotional states, learn to communicate in a mutually responsive relationship with others, and to understand who we are. When a caregiver is routinely neglectful, abusive, or impaired in some way, children become accustomed to having their needs go unmet, and they infer that they are unlovable and that relationships are not safe. These impacts are pervasive and continue on into adulthood. Because the current diagnostic criteria for trauma is limited to the occurrence of death, serious injury, or sexual violence, many individuals with trauma symptoms are misdiagnosed as having disorders that focus on specific symptoms, such as anxiety or attention deficit, but don't recognize the source and function of these symptoms. The Kaiser Permanente study measuring adverse childhood experiences, or ACEs, found that over half of participants were exposed to at least one traumatic event, defined not only as physical abuse, but other household dysfunctions, such as an impaired or incarcerated family member. This and other studies suggest that the prevalence of complex trauma is far more than what's currently being diagnosed and treated. One current approach in counseling is called internal family systems therapy, and it was developed by Dr. Richard Schwartz primarily out of his work with trauma survivors. This model recognizes the multiplicity of self and was actually based on language that his clients would use, such as, "There's a part of me that wants to do this, but another part of me is afraid that something will happen." And the idea is that all of us have parts, and that sometimes a part might be activated by a situation and take over an individual's thoughts and behavior. Another key concept in IFS is that of self, which is the active, compassionate inner leader that's present in all of us, and it's different from a part in that it is who we truly are at our most grounded and calm. The focus of IFS is to help unblend the true self from activated parts that try to take over, and learn to listen to the needs and motivations of each part, gradually helping them to let go of their roles and to trust in the self as the inner leader. Instead of pathologizing symptoms of trauma, this framework recognizes them as an individual's parts that were forced into extreme roles in order to survive, such as excessive self-criticism or avoidance of intimacy. It also allows the individual to have compassion for their past selves and to help them find new roles that are more adaptive within their inner family system. Music therapy can also support the needs and goals of survivors of trauma. Methods such as musical improvisation with others can help clients access and express difficult emotions and experience a reciprocal relationship with others through the structure and safety of the music. Additionally, songwriting methods can help to facilitate reconstruction of their own narratives. One particular approach in music therapy is Diane Austin's model of vocal psychotherapy, where the music therapist provides a holding musical structure to provide safety and engages the client in improvisational vocal techniques, and so the client is actually supported in giving voice to their younger, wounded selves. This approach also promotes self-compassion and reauthoring one's life experiences. For my project, I tried to design a structure that was informed by IFS and vocal psychotherapy. First, I tried to identify my own parts through daily journaling and musical improvisation based in my experience of parts. Then, out of these improvisations, I used songwriting to give voice to the experience and messages that I'd heard. Finally, I concluded with songwriting from the place of self as a compassionate response to those parts. And I'm going to share with you an excerpt from the final song that I wrote from the place of self, entitled "Who's There?"
I hear your heart. Does it keep you awake with its beating, keeping you safe? Trying so hard to make you think you've got something to prove. still feel like nobody sees it. Maybe it's time to put down the weight of their feelings and save some of that kindness for you. Who's there? Can I know you? Who is trying to tell me something? I might make mistakes, but I'll be who you needed back then. And I'll never leave you again. 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 I hear your heart. I'll never leave you again. Ooh.
I definitely found this project to be helpful with experiencing my own parts in a new way, including some that could not be expressed verbally, which is one of the unique aspects of creative modalities. And I also noticed that I thought about my past experiences in new ways and felt more compassionate towards certain parts. I think elements of this experience could be valuable in clinical work with clients with trauma histories, although additional structure might be needed to encourage the musical manifestation of certain parts. This is a list of references that inform this presentation. I cited just a few of them directly, and I thank you so much for your time, and I really hope that you enjoy this presentation.
My name is Rebecca Russ. I will be presenting my culminating project titled Assessing a Body-Based Approach for Treating PTSD+DS, a Fulbright grant application. I'd like to thank my culminating project advisor, Don Morningstar, and I'd also like to thank the DMT faculty and my DMT cohort for taking this journey with me from the beginning to the very end. Dissociation is the essence of trauma. The overwhelming experience is split off and fragmented so that the emotions, sounds, images, thoughts, and physical sensations related to the trauma take on a life of their own. In 2013, the DSM-5 included for the first time a dissociative subtype of PTSD termed PTSD+DS. The subtype is characterized by significant depersonalization and derealization, which are experiences of detachment or separation from the self or reality. The core PTSD diagnostic criteria includes two dissociative symptoms, which are dissociative flashbacks and dissociative amnesia. This graph more clearly outlines where and how dissociation appears in PTSD. In black are the core criteria of PTSD diagnostics, minus the exposure to trauma criteria. The trauma intrusions criteria includes the flashbacks or dissociative re-experiencing, which is when someone is taken out of the present and relive aspects of a traumatic event and feels as if it's happening in the moment. The criteria for negative alterations in mood and cognition includes the dissociative amnesia, which is when a person blocks out and can't recall certain information and is unable to remember important memories such as childhood memories. I would add that emotional numbing and detachment of others within this criteria are as important to understanding the experience of dissociation. The criteria for hyperarousal is an important element because it increases the sensitivity to being triggered, which can elicit dissociative responses. And as I mentioned earlier, the added dissociative subtype of depersonalization and derealization. The literature has shown that PTSD plus DS is associated with a high PTSD severity overall. Clinically, this population has higher levels of comorbid psychiatric disorders and a predominance of a wide range of dissociative symptoms. PTSD plus DS is a distinct clinical population. PTSD patients with a dissociative subtype have shown to exhibit different psychophysiological and neural responses to the recall of trauma memories, for example, the shutting down of the limbic region in the brain. This is notable because the VA and DoD came out with a PTSD treatment manual in 2017, which highly recommended the use of trauma-focused psychotherapies that have a primary component of exposure, including CPT, PE, and EMDR. Some of these treatments, like PE, have proven somewhat effective in decreasing dissociative symptoms. However, a frequent finding is that patients with PTSD plus DS both begin and end treatment with more severe symptoms overall. These exposure-based treatments also have the hazard of leading to overengagement of the traumatic event, eliciting dissociative responses, which may affect response to treatment, creating a cycle of re-experiencing and disengagement. My proposition is that the integration of a body-based approach can aid in treating this subgroup. For clients with PTSD navigating dissociative symptoms, direct engagement of the body allows for more diverse avenues of emotional and self-expression. Body-based therapies such as DMT and sensory motor psychotherapy have shown great promise as supplemental treatment options for those experiencing dissociative symptoms. These approaches promote body awareness and interoception, tools which have shown to help mitigate hyperarousal symptoms such as uncomfortable or painful memories and sensations in the body during exposure. However, a great evaluation and research is needed to understand how these therapies act upon a PTSD plus DS population specifically. This is why I decided to apply to a Fulbright research grant for my culminating project. I chose the Fulbright grant because it would give me access to conduct research as well as the funds to go to Israel for 9 months and gain international experience. I'm still currently in the process of writing and revising my application as it is not due until October. The first step of the process was to investigate the literature on the diagnosis of PTSD plus DS, which I've done in my literature review of this project. Step 2, which I'm still currently in the middle of doing, is creating a research study plan that examines the efficacy of a trauma-focused, body-based therapy approach in reducing dissociative symptoms of PTSD. Step 3 is going to be exploring this approach in the context of an Israeli society. In a country such as Israel, where war and terrorism are constant and military involvement is mandatory, the impact of trauma on the functioning, well-being, and mental health of the general population is a crucial public health issue. In Israel, trauma is experienced on a collective and national scale. This grant will give me the opportunity to explore how it manifests culturally and systemically as per its unique circumstances. I am highly looking forward to engaging in this next phase of my exploration. I want to thank you all for joining me here today. Enjoy the rest of these wonderful presentations.
Hi, my name is Esther Hermes, and I am a graduate student of music therapy and counseling at Drexel University. So today I want to talk to you a little bit about the integration of music therapy and narrative therapy in treating symptoms of post-traumatic stress disorder among women. So here's just a quick overview of what we're going to be discussing today regarding my culminating project. We'll go through the topic, what I found in the literature, and then a discussion of the reflexive project that I embarked upon. So the problem, as many of you know, post-traumatic stress disorder is a real diagnosis and a real issue here in the US. So the Mayo Clinic defines it as a mental health condition that is triggered by a terrifying event, either experiencing it or witnessing it. And in fact, 7 or 8 out of 100 people in the US will be diagnosed with PTSD at some point in their lives. And what led me to really focus on this population, on the population of women specifically, is that while approximately 4 out of 100 men will be diagnosed with PTSD at some point in their lives in the US, approximately 10 out of 100 women will be diagnosed. And there are many theories on this, but one hypothesis talks about the social roles that women are put in and or find themselves in, whether it's the caretaker role, etc. Typically very oppressive, problematic social roles, right? And within these roles, the points of trauma really emerge. And so that's why it's such an important thing to have this feminist therapy and feminist theory lens when working with this population in order to really support and provide that empowerment and giving back voices to women. So how is trauma processed in the brain? The brain automatically stores traumatic memories within the amygdala. So the goals of therapy should be thickening and integrating these strands of memory into the frontal lobe, which is the language accessible part of the brain. Also, repetition in therapeutic interventions is necessary in order to remap the brain's processing to specifically reorganize and regulate brainstem activity. So what are some of the approaches that clinicians can use to work with clients with PTSD? Narrative therapy seeks to be a respectful, non-accusatory therapeutic modality which views people as the authors of their own lives. So this is in an effort to deepen the narratives, to add thickness and richness to storylines, really acknowledging and encompassing the nuances, the contradictions and complexities of life. Interestingly enough, there is a subset of narrative therapy called narrative exposure therapy. Essentially, it's a theoretical frame that employs interventions that allow space for clients to share their stories, including traumatic events, in a safe and supportive environment. And then we have music therapy. According to the American Music Therapy Association, music therapy is defined as the clinical and evidence-based use of music interventions to accomplish individualized goals within a therapeutic relationship by a credentialed professional who has completed an improved music therapy program. So not so surprisingly, music is a form of sensory stimulation, which can trigger reactions due to associations of familiarity, predictability, and feelings of safety. Further rigorous research is needed to fully explore the efficacy of music therapy in treating PTSD, yet it has been found to improve functioning and foster resilience among PTSD survivors. So what are the intersections? Well, combing through the literature, I found that there are the core values of social justice and respect for autonomy. There's really a focus on this co-creation of the session content and a collaboration within the therapeutic relationship itself. And this can look like a number of things, but with these two modalities in particular, it can look like writing an autobiography, songwriting, creating a musical narrative. So what are the implications for an integrative approach, and what can it look like? Well, so I embarked upon this reflexive project over a 9-week period where I actually started with doing a trauma narrative writing process myself. So talking about traumatic memories, events, experiences that have happened in my life. And I wrote in chronological order, which is often a common technique used within narrative exposure therapy. And after I went through this writing process, I then went to the musical response. And oftentimes I would musically respond to a particular section, and other times I would musically respond just to the entirety of the writing itself. And I oftentimes wrote in fragments, and so I really attempted to find the common thread within all of these musical fragments. And so I want to show you a clip of an example of me responding musically to a particular section, which was actually on grief, and how oftentimes grief and trauma can be intertwined. And then this next clip I called Thickening the Strands, and essentially it is a direct response to the entirety of this writing process, right? So adding thickness, richness, depth to these experiences. So when I tracked this, this piece, I layered it with 8 different tracks, again to be a metaphor for the thickening of these memories. So here it is. So while I've been able to share some clips today with you all, I hope to share these songs in greater capacity one day. So how can this project inform an established integrated approach and/or intervention for this population? So going through this project, I really found that while the writing was really important and necessary for laying the groundwork, I truly felt more authentic expression and safety in responding musically. And to me, that really speaks to the power and importance of the aesthetic modalities in addressing traumatic experiences and giving expression to experiences that maybe direct language cannot. So thank you so much for listening and coming today. I look forward to answering your questions.
Hello everyone, my name is Emily Wexler and I'm a graduating art therapy and counseling student. My project was focused on mindful art making for healthcare professionals and how it could be used to combat compassion fatigue. I'm going to first explain some background information related to my project, including defining compassion fatigue, mindfulness, art therapy, and mindfulness-based art therapy. Those who work in healthcare focus on caring for others, sometimes putting their own needs behind those that they care for. This, combined with a high-stress environment of many medical facilities, can result in compassion fatigue or burnout. When a practitioner experiences compassion fatigue, Not only does it have an effect on their own emotional, physical, and psychological health, but it can also negatively affect patient care. Compassion satisfaction, which is experienced by individuals feeling that they can execute their work well and that their work is useful, is protective against compassion fatigue. The practice of mindfulness is one method of meditation that originated from Buddhist religious practices. It highlights the importance of paying attention in a particular way through moment-to-moment awareness, maintaining an open heart, abstaining from judgment, and not reacting. A component of mindfulness is self-compassion, which involves extending compassion to ourselves in times of adversity and acknowledging that these moments are not unique to us, but are innately human. Within the medical setting, mindfulness practice has been shown to lower anxiety, depression, and burnout. In addition, mindfulness alleviated stress related to conflict with coworkers or patients, a key component in emotional exhaustion. Art therapy can provide benefits that differ from traditional verbal-based therapeutic process. Art provides an opportunity for self-expression through metaphor and images. Art making allows individuals to view their emotions in a more complete, objective, and safe way. With medical professionals enrolled in art therapy supervision groups, there were significant decreases in exhaustion, which is a component of burnout, as well as increases in levels of self-expression, which can be protective. Mindfulness-based art therapy involves three components: self-awareness, the creative expression of thoughts and feelings, and acceptance. Components of mindfulness practices and aspects associated with art therapy can complement each other. The internal focus of mindfulness practice highlight the creative and introspective qualities that serve as a foundation of art therapy. While mindful practices stimulate internal observations and focus, art making allows the individual to express these externally. Although I did not provide therapy for my project, I used a basis of mindfulness-based art therapy to inform my method. The project, which took place on April 20th, 2020, focused on the use of mindful art making to help combat compassion fatigue within medical and behavioral health professionals. It was a one-time, 1-hour mindful art-making experience that was held via a HIPAA-encrypted Zoom. 39 people attended the event. The structure was broken into 5 sections. First, an introduction of myself and the space, followed by a mindfulness check-in to help acclimate the participants to their own spaces. Those participating were then instructed to think of a self-compassion mantra that could contain 4 parts: a statement of self-compassion, a statement of shared human suffering, a statement of kindness, followed by your intention. After completing their mantras, the participants were directed into the art-making process, which took 30 minutes. The art making took place using mandala making. The participants used a blank circle, such as the one on the slide, for their base and were instructed to consider their mantras in creating their mandala. They were told that although mandalas typically work from the center out, they could use it in whatever way felt best. This could involve patterns, images, or words. The final section was a 15-minute discussion about the process and outcomes. Images on this and following slides were created during the art-making process. Some topics that emerged during the discussion were a preference for sound or silence. Some participants chose to put on their own music in the background in order to curb the effects of silence during the art making. This was a benefit of having the event over Zoom because people were in their own spaces and therefore able to control the space around them. Some other participants found that it was difficult to sit still and make art for 30 minutes because they felt that the constant moving during their day can be protective. Many found, though, that this discomfort eased over time. Another theme that emerged was the idea of perfection. Many mantras that were shared included the ideas of perfection and imperfection, and how imperfection is one of those things that makes us innately human, and how it's important to extend kindness to ourselves in times of imperfection. Within the artwork, different categories also emerged. One was the use of words as a pattern. Some participants chose to include the words of their mantras as the pattern of their mandalas. Other images extended past the confines of the circle. And finally, some people chose to use concentric patterns around the circle, while others used a more organic pattern, such as the images shown on the screen. Something that emerged was the importance of giving those in healthcare the time to slow down and recharge, because they are so deserving of it, as well as it being a necessity if they're going to continue their work. It's important to support those who care for us, especially in times of high stress and fear, such as within the time of COVID-19. Without replenishing one's needs, there's a limit to how much they can extend to others, which can lead to total burnout. A vital takeaway from this process is that self-care is not a selfish act, but instead something that is a necessity. I want to thank you all for listening to my presentation and give a special thank you to my family, my boyfriend, my advisor, Michelle Rattigan, for their continued support throughout this process. Thank you.
The human trafficking population is underrepresented in literature and underserved in practice. Through launching an inaugural internship program this year, I discovered that dance movement therapy created a means to investigate and express deeply imprinted body trauma. The purpose of this performance-based culminating project used witness as a method to help one survivor reclaim her body when emerging from sexual slavery.
No one knows how bad it gets. No one knows the real me. I hide the truth from a lot of people. To be honest, I don't know if I'm protecting them or me. It would be so easy to end my life and all this pain and trauma. No one knows the pain and darkness. No one should ever have to deal with it. It's like a war in my head, and I end up dead each time. I'm drowning and no one cares. They say to be strong, but that's hard for me. I look around and I'm ready. A miracle happened and now I don't want to leave. But the war is hard to fight. No one knows. I don't want them to fully know. No one knows that I don't want to die, but my mind says the opposite. I'm scared I'm not going to win because no one knows. My heart aches knowing I can't change anything. My heart aches knowing what they're going through, because I've been there. My heart aches that no one takes me seriously. They just think I'm lying. If only they knew. Sometimes I wish I could erase my mind, so I could be happy and have a normal life. My heart aches for my loved ones because they see the struggle, and I know it affects them just as bad. I wish I could save everyone from an achy heart. Learning to let go is hard. I just want to be happy. No more achy heart. Just smile, keep going. Harder said than done. My heart aches because I don't understand why I can't let go. My chest hurts, but I continue. I have these chains still pinning me down. My own prison and fears that keep me from moving on. Forgiveness. No matter how much pain you put me through, I'm still here, letting go and being amazed the prisoner is letting go of his mate. If I forgive you, I move on. This is my beautiful life now, not yours, not anyone except mine. I will never forget the pain you caused me, or any other child for that matter. Forgiveness. I forgive you. I finally want to be set free. You are no one, just someone that caused me hell. I'm no longer the prisoner. I'm free. That's forgiveness. Forgiveness is not forgetting. Forgiveness is letting go. Forgiveness is love and freeing yourself. When a tornado ends, everything destroyed and rocky. That's how she felt. Everything went dark and she kept falling down. She could see the light coming out from the rubble. She landed feet first on a new surface. She looked around, not knowing what to think. She felt loving arms around her. She felt safe for the first time in her life. This is how a new foundation was formed, from a storm into a rainbow. Never give up. There's always light at the end of something wicked.
You are seen. You are honored. Your story will be danced. Your story will be shared. You will not fight alone. Together we are united in the fight for the unfree. You will not fight alone. With love, through love, because of love, the fight will be joined until all are free. You are seen. You are honored. Your story will be danced. Your story will be shared. You will not fight alone. Together we are united in the fight for the unfree. You will not fight alone. With love, through love, because of love, the fight will be joined until all are free.
Everybody, what an amazing module that was. And as a part of resilience, it's really important for us to just take pause and take a breath. Maybe if we can do that for ourselves right now, just put your hand over your heart if that feels comfortable, just to feel seated in your chair and take a deep breath in and then out. What wonderful work we all had an opportunity to just witness. My name is Michelle Rattigan. I teach in the Art Therapy and Counseling program.
And I'm Dawn Morningstar. I teach in the Dance Movement Therapy and Counseling program.
And we have some general questions and specific questions for our panel today. But before we do that, we invite our panel to introduce themselves and the title of their project. And since you don't know what order to go in, because we're in Zoom, we'll just call you out by first name, and then you can let us know who you are. Do you want to call?
Sure, Anna, why don't you start?
I'm Anna Cephas, and my presentation was The Voices of Parts, Applying Internal Family Systems to Music Therapy and the Healing of Complex Trauma.
Thank you. Emily?
Hi, my name is Emily Wexler, and my project was Mindful Art for Healthcare Professionals, a method to combat compassion fatigue.
Thank you. Lauren?
Hi, I'm Lauren Dobbins. I presented Embodied Trauma and Movement in Art.
Laura?
Hi, I'm Laura Tant. My presentation was called Absolution and Defiance, Utilizing Dance Movement Therapy in the Healing Journey of a Survivor of Human Trafficking.
Thank you. Esther?
I'm Esther Hermes, and I talked today about the integration of music therapy and narrative therapy and treating symptoms of PTSD among women.
And last but not least, Rebecca.
Hi, my name is Rebecca Russ. Mine was assessing a body-based approach for treating PTSD+DS, a Fulbright grant application.
Thank you. All right, so I have a general question for all of you, and anyone can answer this. The question is, when working with survivors of trauma, what creative means did you employ to mitigate compassion fatigue for yourself as a therapist or engage in self-care?
That's a great question. And I would like to just throw it back to Emily's presentation. I did a lot of response art, creating my own art after sessions, and just really checking in with myself, make sure I was practicing my own self-care.
Yeah, and I think mine was a little bit different just because it was like a very personal and reflexive project, right? So I was kind of facing kind of my own history and trauma. And so I think through that process, it was really important that I would give myself time throughout the project. But also, I think it was helpful that I was able to check in with friends and peers throughout, just to really utilize that support network through that process.
Yeah, and I mean, something I say to people I work with, or clients also, is just to remember that there's no perfect way to do self-care, and I think it's important to just check in and try things out and maybe think like that was definitely not for me, but maybe this maybe more is, and just kind of to check in and know yourself.
Wonderful. So Lauren, we have a specific question for you. Someone had asked, do you think that adding sensory components might impact the process that you were exploring, such as music, senses in the paint, or maybe additives like sand?
Absolutely. I think that would be an amazing addition, given the needs of the client and their comfortability with bringing in more sensory aspects. I never want to overload anybody, but if they're comfortable with it, working tactilely, using your hands, working like finger painting, sand, that could be really, really interesting as far as like what that would bring out for the client in those moments, because the whole point of the work is to really try to get in touch with what are you experiencing internally and how does that get evoked from our environment. So the more different sensations and environmental stimuli we can bring in, the more work we can do to see what that brings up in ourselves.
Great. Wonderful. Thank you. Anna, I have a question for you. How was writing, recording, and performing the song an essential aspect of integrating the literature of this project for you?
Yeah, I mean, it definitely was a way of incorporating elements of the musical improvisations that I had been doing and recording along the way. And that was really, you know, kind of, as I believe, Esther, you referred to, just kind of a safe way of experiencing certain parts and certain emotions. And the songwriting element of that really, actually the final piece I shared was really kind of a musical response that came out of me without a whole lot of planning and conscious thought. And so in a way, it kind of encapsulated that, you know, what the literature says about just the power of that self-compassion and the ability to recognize, especially responses that are born out of stressful or traumatic experiences as adaptive, but just needing, you know, a different role in order to help us survive when there is not a constant threat anymore.
Thank you.
Yes, Esther, I have a question for you. Would you be able to give a specific example of a music therapy method that could be employed in a narrative therapy model?
Great question. Yeah, so this is something that I continued to return to as I was combing through the literature, through narrative therapy and music therapy. And one idea that kind of came to me as a type of proposed method would actually be, which kind of makes sense, as a songwriting kind of method. So maybe taking time, so within the narrative therapy context, taking time for the clients, whether it's group therapy or individual therapy, taking time to really go through and write and highlight key moments or events, again, in due time when the client feels ready. Because again, trauma, it's tricky to navigate, and it's really important to build that trust. So I guess, yeah, again, going through that process, creating that space for writing, but then creating an opportunity for the client to then write a song within that structure. So again, maybe we would go through the writing together and maybe make lyrics out of that, you know, and then in turn create a musical structure. So what does this sound like to you? So even in terms of minor, major, or progressions or tempo, kind of going through that. So really taking time with the client and really creating that song, that musical response. But also with that, I really want to highlight too that you know, lyrics aren't totally necessary. I think it can be a really important, powerful tool, especially in the narrative context. But I really want to bring home the idea that sometimes these experiences, especially traumatic experiences, can really be better, I think, articulated and expressed by just aesthetic musical means that maybe language can't totally encompass. And that really lines up with the literature that I found.
Got a lot of head nods from your peers on that last statement.
Yeah, the expression and the bodily felt experience really important with trauma. Rebecca, I have a question for you. There was a lot of interest in your Fulbright grant in the comments. So I'm curious about where you are in the process of applying for the Fulbright grant.
Yeah, like I mentioned in my video, right now I'm kind of going through the details of what my research is going to be, especially because you don't go there until a year later. October 2021 is when I would go. So it requires a lot of talking to people in the field of psychology, in creative arts therapies in Israel, and what research they're doing and how to collaborate. So even if I have an idea for what I want to do in a general sense, like it requires me, you know, exploring what's out there already. And seeing how I can collaborate with those resources. So in that process, I'm still reaching out and seeing what's out there.
Thank you. Keep us informed with that, please. We'd love to hear about that, support you. Emily, I have a question for you. A question came in asking if you could describe the formula that you used for the mantra. And the second part to that is, do you imagine that what you did could also be psychoeducational, so then healthcare professionals can do this on their own at home?
Yeah, so the formula, or the idea I gave behind the mantra was a statement of self-compassion, followed by a statement of shared human suffering, a statement of self-kindness, and then your intention. So an example I gave was, I'm not perfect. Nobody else is perfect. It's okay to make mistakes sometimes, and I'll continue to try my best and be my best. And with psychoeducation, that was kind of a big idea of what I wanted to do with this, was to give these tools so that people can then use it on their own. Because a lot of research with the medical field is that there's just not a lot of time. So if you have someone coming weekly for an hour, it tends to fall off because the schedules are just so busy. So kind of giving these tools that even if you have 5 minutes, 20 minutes, you can use this on your own in the future.
That's a great point. All right, Laura, I have a question for you. It's kind of a two-part question. Can you tell us a little bit about the genesis of this project and how the video came into being, like a little bit about the process with your client?
Absolutely. Thank you. Great question. It entirely transformed due to the pandemic. And I was originally inspired by an artist, Bill T. Jones, and he created a piece called Still Here in 1994, and telling the story of people with terminal illness and embodying their movement and making a beautiful performance. So I wish to do the same for a very important reason. The human trafficking population, as I mentioned, is very underrepresented in literature, and it is underserved in practice. And the most salient post-trafficking need is mental health support, therapeutic support. And as we have all researched and worked and quoted Dr. Bessel van der Kolk, the best way to express trauma is our modalities through arts, through dance, through movement, music. So since we had to switch to telehealth, we still use the same model, but it was now the story of just one survivor. And the movement that is demonstrated by each dancer with one arm and then the other is a movement that she created. So that is her gesture portrait, her movement motif. In a safer world, she would be in this performance with us. So that's a little bit about the genesis. Have I gone off topic? Did I answer the second question?
You did. You talked about how you created this with your client.
Very beautiful. We have time for one more question that again would go out to everyone on the panel. There was a lot of talk throughout the day, and especially Lauren, when you started us off today, of collaboration. And so this is a great question for you all as you're having a chance to do this together and see each other's work and research and scholarship. How do you imagine collaboration as being a part of your work moving forward as a creative arts therapist? And this is for all of you if you want to jump in.
I'll say, I think it will be a huge part of my work. I just believe that all of our strengths coming together just creates more of a holistic treatment and theology for how we should be interacting and engaging with our clients. I just think all of our modalities and other professions have so much to offer, and really bringing all of that into our awareness and application just makes everything so much stronger.
I would love to wholeheartedly agree, Lauren, and I believe that the best treatment for trauma is an integrated approach, and so all the tools that we all possess, I think, would absolutely create a holistic healing toolkit. So I would love to collaborate with all of you.
Awesome. Thank you, everybody, for your beautiful work, your moving work, and your important work. So I think since we're talking about this, let's all just take a nice big deep breath. Everybody on the panel, everybody's watching. Let it settle out, however you want to settle it out. Shake it out, wiggle it off. Thank you so much for your work, everybody. We are going to take another short break, and we'll see you soon.
You remember when we used to live in Philadelphia, and we went walking one evening through the Italian market to find a cup of coffee, and all the cafes were already shut. But we saw a cat in a window, sitting on a pedestal, draped in velveteen, as if it were on display in a museum. And I said, when I get older, if I get older, I wanna live by the ocean. Will you come visit me there? We'll have a cup of tea in the open air, and we'll remember when we used to live in Philadelphia. Back when we were still in school, but older than all the other kids. The evening was divine, and so we kept on walking south to the Mexican cafes that were still open, and I got a cup of coffee, and we kept on walking, and I said, maybe they're right, maybe we're done, maybe the worst is yet to come. I made some plans, and now they're gone. It was just some sand I wrote my name on, and the rain has washed it all away in a flood, in a flood. There's a memory of another day in my blood. holding on. Picture of fire, hold up the arc. Come sit beside me, we'll play your favorite song. 'Cause to make a joyful noise in the face of a flood, is the legacy our ancestors made in our blood. In our blood, when the rain has washed it all away. In our blood, in our blood, there's an ancient song we'll learn to sing. In our blood, in our You remember when we used to live in Philadelphia, and we went walking one evening through the Italian market to find a cup of coffee, and all the cafes were already shut. But we saw a cat in a window, sitting on a pedestal, draped in velveteen. we used to live in Philadelphia. Back when we were still in school, but older than all the other kids. The evening was divine, and so we kept on walking south to the Mexican cafes that were still open, and I got a cup of coffee and we kept on walking, and I said,
Hi, welcome back, everybody. If you're just tuning in, thank you for joining us for the 2020 Colloquium. of the Drexel Creative Arts and Therapy and Counseling program. We are getting ready for Module 4. This is Innovations in Creative Arts Therapy. So I know we started our warm-up today with Janika having us exploring our boxes. This module is about reaching outside of our comfort zone and reaching out to other areas of connection. So I want you to take a second and just kind of stretch your edges. Find the edges of your screen or find the edges of your room and really move through the space. Find what might be interesting and different for you, a different way to move, a different way to stretch as we're kind of getting ready to hear the next presenters. So find a creative way to come back to your seat as we're preparing to hear our next presenters. And I'd love for us again to embody some of this work that we're hearing about. So make sure you're moving through your body, you're stretching. We don't want to get Zoom neck. So we want to make sure we're moving our necks in different ways. We're focusing, stretching beyond the screen, finding new ways to be creative. So settle in, find your feet on the floor. If you're sitting, find a nice, comfortable position that you want to be in, ready to receive the next module, which is Innovative Approaches to Creative Arts Therapy. Enjoy.
Welcome to Module 4, or Innovative Practices in Creative Arts Therapies. If you're just joining us at the start of this module, you will soon view and listen to 6 graduating Creative Arts Therapy students present their culminating projects. You are viewing this live broadcast of the 2020 CAT Colloquium content on a private YouTube channel. You can listen and view these presentations in their pre-recorded sequences, and if you wish, may add your questions or comments in the chat box function. To share any questions or comments ahead of the small group discussion or Q&A segments ending each module, you must log into YouTube via a Google or Facebook account. There are live Q&A sessions with all presenting students and 2 moderators at the end of each module and throughout our multifaceted and immersive program. On the theme of innovation, I must say that clients and therapists inspire innovation through perceiving vital gaps and needs in therapy care approaches. Innovative practices are developed in real time very often and due to many immediacies of need. An innovative therapeutic method is typically not a continuation of the status quo, nor a straight pathway to quick therapeutic resolution or even a clear understanding of how something worked well or at all. For example, innovative therapies can advance and articulate sensitive collaborative strategies to draw out and reduce experiences of minority stress and marginalization within mental health treatment. Innovative practices can both queer and question the basic why and how of our therapeutic and interactive spaces. Such critique can build in vital context and tailor novel approaches for clients who all present diversity of needs and intersectional histories. These revitalizations also tend to honor essential truths of therapy. That is, the relevance of human struggle alongside our wellness. Adaptation and experimentation in the creative arts therapies are readily inherent due to the spectrum range of natural to otherwise sensory materials, symbolic and tangible embodiments, and sonic expressions and instrumentations used. Beyond the physical limits of materials, tools, and communication forms are how media actively create, remediate, and disseminate relationship and cultural contexts, past, present, and future. Many clients and their mental health circumstances can become disenfranchised, overlooked, and unseen by society due to historical oppression or erasure, and present critical distinctions within our many intercultural experiences and backgrounds possible. Innovative therapy methods can reorient our default modes of thinking and acting therapeutically by decentering hegemonic bias and assumptions with humility and greater perspective. The presenting students in this Module 4, or Innovative Practices in Creative Arts Therapies, directly speak to many supportive approaches to complicated grief and bereavement, to honoring altered bodies and sexuality and intimacy and rehabilitative medicine, and remediating homelessness and addiction recovery. Their methods take on new advocacy, resource and renovate foundational practices already used, and uncover the avoidance of crucial issues, simultaneously obvious and evaded.
Hello, I'm Rachel Mindis, and I'd like to thank you for joining me today to discuss ABLE, the Informed Practice Approach and Application for Dance Movement Therapy in the Medical Rehabilitation Setting. I would like to take this time to thank my parents and my sister for the unconditional support throughout this process, and to my fiance, thank you for your unwavering belief in me and continuous love. I would like to dedicate this project to my clients that have shaped my work and inspired me to be curious about this topic, as well as the employees at McGee Rehabilitation Hospital for allowing me to put my ideas into practice. To my supervisors, thank you for your impact on my education and clinical skills and for your constant encouragement. For as long as we can trace back, people have created art, music, and dance that depict one of the most innate human needs: connection. Take a moment to think about what enables you to connect with your environment, your loved ones, and your inner thoughts and feelings. At the very core of this ability, you are likely to find movement. Now imagine you wake up and this natural ability is severely disrupted, leaving you unable to express even the most basic of needs. This is a common outcome for survivors of traumatic brain injury, spinal cord injury, and stroke. I'd like to take a moment to discuss why DMT is beneficial in the medical rehabilitation setting. DMT is a strengths-based approach. We work to meet the clients where they are at based on their current physical needs. The process is about exploration and not a set of expectations. DMT uses a trauma-informed lens, working to understand, recognize, and respond appropriately to our clients' history and current needs. The following is a list of various possible outcomes that dance movement therapy can provide this population to aid in the recovery process. It is important to recognize that the body post-injury is a different body, and oftentimes a different mind. The focus here is on reintegration and to foster the mind-body connection, allowing the individual to engage all parts of themselves. The current literature explores how dance movement therapy can be used to support individuals in the medical setting working through diagnoses such as cancer, cystic fibrosis, oncology, and a variety of chronic conditions, as well as hospice and palliative care. There is research on the physical outcomes of dance classes for individuals with disabilities, as well as emerging research on the use of a biofeedback computer program that turns movement from rehabilitation exercises into abstract art. However, a gap remains. There is currently no research on creative expressive use of assistive devices or ambulatory equipment in DMT or related fields. There is no literature on DMT and ambiguous loss, something that I've noticed most of my clients have experienced. And there is no research methods for any integrative rehabilitation practices or approaches that integrate dance movement therapy with physical or occupational therapy. When I began my internship, I noticed that the equipment and adaptive tools were solely being used to improve tasks of daily living. This project explored how adaptive and assistive tools within the medical rehabilitation setting could be used to support an individual's exploration of creative movement. Individuals in this setting often do not have this opportunity due to limitations of presenting physical factors. I was excited to explore an untapped area of dance movement therapy practice and to start a conversation about how dance movement therapists can work both independently and collaboratively in this setting to provide opportunities for their clients to express themselves using pre-existing rehabilitation equipment and adaptive support. I would like to provide you a case example. Mr. A and the Vector Advantage. Mr. A, an Italian-American man in his mid-60s, was admitted to the rehabilitation hospital post-stroke. After several days at the hospital, Mr. A was referred to me by his physical therapist, as she had discovered through their conversations he enjoyed dancing in his youth. Mr. A used a wheelchair in which he propelled with his feet to mobilize independently. He presented with a rounded posture while seated and lacked a general stability and proprioception while standing as a residual effect of the stroke. In conversation, he disclosed how he used to be very good at the jitterbug and he even won a competition. As he spoke about the memories, he was transcended back to the moments on the dance floor. When I asked if he would be interested in trying to dance again, he looked at me as if it was the most ridiculous suggestion he had heard. In collaborating with his physical therapist, we planned a session that would implement DMT while using the Vector Advantage, a gait rehabilitation machine, as pictured in this example photographed on the left. Based on Mr. A's physical needs, the Vector was a wonderful opportunity, as it worked by providing dynamic body weight support and preventing falls. The session began with exercises to allow Mr. A time to acclimate to the technology and gain his balance. We began to move together, and as he became refamiliarized with the pattern, he was able to pick up the tempo. At first, Mr. A maintained an expression that was a mixture of focus and apprehension as he was learning to trust his body again. As he began to grow confident in himself and his body, he spun me around. The session generated excitement from the staff and other patients in the hospital who were passing by. The session highlights how cross-discipline collaboration can lead to positive outcomes. The combination of the physical therapist's knowledge of the equipment and my implementation of stylized movement as an intervention created a memorable experience for Mr. A. The intervention promoted self-expression and vitality while simultaneously working on proprioception, core support, posture, and stamina in the vertical dimension. The thoughtful planning to address both DMT and PT goals made the session a success. The physical challenges of rehabilitation were offset by the enjoyment he was able to experience by revisiting a style of dance that had meant so much to him in his youth. This is just one example of the wonderful type of interactions I was able to experience throughout this project. I would like to share with you some of my findings from this project. I found that pre-existing adaptive equipment and ambulatory equipment can successfully aid in the development of self-expression, provide valuable coping experiences, and have a positive influence on body image and physical competence. I found that cross-discipline collaboration is crucial to the exploration of adaptive techniques, and that a professional's personal outlook on disability influences treatment style and the care of their patients. Some personal takeaways include: a person's pre-admission history is an important consideration in the work. There is a continued need to further research in this area. All techniques used are based on the patient's individual needs and is not a one-size-fits-all approach. And that creating a positive experience for an individual that involves ambulatory equipment can increase their attitudes towards the use of equipment as a whole. I look forward to engaging with you during the live discussion portion of this experience. Please feel free to email me at the address below with any additional questions. It is my hope that this project will allow future dance movement therapists and rehabilitation staff members alike to gain new perspective on the movement possibilities within the medical rehabilitation setting, and that together we can bring creative movement and self-expression into the lives of the individuals we work with. Thank you.
Hi, my name is Gina Brockway. I'm a music therapy master's student at Drexel University, and today I'm going to be presenting on my culminating project, Music Therapy Grief Support for Young Adults. This project was advised by Scott Horowitz with the support and supervision of Molly Hicks. In this presentation, I'm going to start with the origins and rationale for the project. I'm going to go over some key takeaways from my literature review. I'll talk about the project plan as it was originally devised and then as it had to be altered due to COVID-19, and I'll finish with some reflections. So this project really developed out of my year-long internship at Penn Medicine Hospice Bereavement Department. It became apparent that there was a lack of programming specifically for young adults experiencing grief. And based on my supervisor Molly's substantial clinical experience and my smaller amount of experience with bereaved individuals, we really felt that young adults could benefit from programming with an emphasis on self-expression and creativity, and with an opportunity to connect with other young adults experiencing grief. And out of this came an opportunity to develop a music therapy group from scratch to address this need. In my literature review, I looked at the experience of grief in young adulthood, and it's worth noting that young adulthood may be defined and experienced differently in different cultures, but based on time limitations and practicality, I was only able to look at the experience in Western culture. So young adulthood is a transitional period of life where people are developing and navigating their identities. Developmental psychologist Erik Erikson defines the major conflict of this period as developing and maintaining intimate relationships with others. Without proper support, young adults who lose people during this period may end up holding back from making meaningful connections out of fear of experiencing more loss. Common losses during young adulthood, such as the loss of a sibling or a non-marital partner, are less likely to be recognized by society as significant, and therefore often become experienced as what Doga calls disenfranchised grief. Doga explains that people experiencing disenfranchised grief are not given the same rights afforded to other grievers, such as support and sympathy and reduced responsibilities in day-to-day life, all of which can lead to more negative outcomes in the grief experience. The dual process model is a theoretical model of coping that describes ways that people may come to terms with loss. It holds that when a person is grieving, they're continually oscillating back and forth between loss-oriented and restoration-oriented coping. The loss-oriented process involves experiencing the pain of the loss, remembering and yearning for the person, and adjusting to life without them. Restoration-oriented coping involves taking time off from the pain of grief, developing new roles and identities, and accepting and adjusting to the changed world. And I believe that music therapy is in a unique position to help grievers access both loss and restoration-oriented coping in a safe and contained way. In my literature review, I found very little research on the use of music therapy in bereavement, let alone music therapy with bereaved young adults. Of the studies that I was able to find, the most frequently used music therapy methods were improvisation, songwriting, singing, and receptive experiences. On this slide, I've listed out music therapy goals associated with each of these methods that could be relevant to bereavement. I'm not going to read them all, but some of the main points to take away are that music therapy can help with building and maintaining connections with the deceased, the self, and others. It can provide a way to access grief-related memories and emotions in a safe way, and it can aid in the process of meaning making. Now I'm going to pivot to the project. The initial outline of the project started with an introductory workshop to introduce the idea of music therapy support for young adults and assess interest and need for it. Following a community music therapy model, the next step was to have a brainstorming meeting to collaborate on the details and the content of the programming with those who would be using it. The goal of this was to give participants agency over the process and not to presume that we knew what would be the best way to help them. After this, the plan was to integrate the feedback we received from the workshop, the ideas from the community meeting, and the research from my literature review to create ongoing programming for grieving young adults in Philadelphia. 6 participants attended the 2-hour-long workshop, and it included a combination of music therapy and verbal processing experiences to explore the grief experience as a young adult. We also wanted to help participants find connection with each other and highlight ways that music and creativity can help during the coping process. And during the workshop, the group was really open to the musical and creative experiences, and they really seemed to find cohesion, even with the short 2-hour time span of the workshop. And I believe that this was really aided by the music and creative experiences. We administered anonymous pre and post surveys to participants, asking about mood, current experience of grief, reasons for attending, etc. And the feedback was overwhelmingly positive. Everyone noted that they were interested in future programming for young adults. And they noted that the most helpful aspects of the workshop were finding connection with others and engaging in creative experiences. It was also notable that changes in mood were an increase in hopefulness, an increase in feelings of stability, and a decrease in feelings of being overwhelmed. The next thing was the community brainstorm meeting in March. So a few young adults attended this, and some ideas that came out of it were to have a balance of structure and open-endedness, to have simultaneous music and art making, and to invite participants to share songs that were meaningful to their grief experience. Unfortunately, shortly after this, the COVID-19 pandemic hit, and we were not able to implement all of these ideas. After some reorganizing and making changes, we moved forward with the group on a virtual platform. Since the end of April, myself, Molly, and a fellow intern have been facilitating bi-weekly young adult grief support groups over Zoom. We wanted to structure the group in a way that incorporated the same goals and ideas as the in-person group, while also creating a safe and open environment over the virtual platform. So each group begins with a music therapy intervention, such as improvisational songwriting or a shared listening experience, and it follows with participants sharing music, dance, poetry, or visual art connected to their grief experience in some way. And this is a paraphrased quote from one of the virtual group participants, and I feel like it really sums up what music has done for participants in this group and what it can do in a more broad sense for grieving individuals. She said, "The music helps me to feel like I'm moving through my grief rather than being stagnant in it." What stood out to me most about this group was how giving participants the space to share something personal and meaningful in a safe and structured way really seemed to foster deep connections between group members and allowed their grief experiences to be validated by each other. And given the disenfranchisement that young adults are likely to feel in their grief, this felt really significant. It was also notable to me that it seemed the music experiences did help young adults access both loss and restoration-oriented coping styles. Sometimes the music helped people to go deeper in their processing of grief emotions, and sometimes it created a shared experience of joy. So ultimately, more research is needed to provide empirical evidence and develop best practices for the use of music therapy with bereaved young adults. That being said, this project really illuminated to me how helpful music therapy can be, not only to young adults, but really to people of any age range who are experiencing grief. Thank you so much.
Hello, my name is Emma Sadler, and this is the presentation of my culminating project, Dance Movement Therapy for Men Who Are Homeless and in Recovery, a program proposal. I would like to thank my culminating project advisor, Dr. Christina Devereaux, for all of her guidance. I would also like to extend appreciation to all of my professors and supervisors for their expertise and their knowledge. Lastly, please join me in acknowledging the land of Philadelphia as the traditional land of the Lenape people, past, present, and future. During my internship, I had the privilege of working with men who are homeless and in recovery at a program called Miracles in Progress. Through our DMT groups together, I observed the power of movement and nonverbal embodiment through a therapeutic and egalitarian lens. Through the empathetic nature of dance movement therapy, or DMT, participants felt validated and seen, which inspired me to want to continue the work there. The program proposal I created requests for the development of a dance movement therapy program at Miracles in Progress. The prospect of creating a program proposal excited me when considering the ways I can advocate for my work, my clients, and DMT. The literature review conducted addressed the epidemiology of homelessness, substance use in the brain, and existing addictions treatment. Causations and continuations of homelessness are exacerbated at both a systemic and individual level. This includes lack of low-cost housing, stigmatization from practitioners about mental health, addiction, and communicable diseases, poverty, and trauma. For over 60 years, Philadelphia has struggled with addiction, homelessness, and the need for access to mental health services. There's a multitude of research looking at how addiction affects the brain, learning capacity, and adaptability. The lack of key chemicals in the brain can increase the risk for seeking satisfaction from external sources such as substances. When the brain is underdeveloped, the body is unable to regulate fight or flight responses. Furthermore, I examined the role of therapy in addictions treatment. Research has shown how mindfulness, or the awareness of one's thoughts, feelings, and bodily sensations, addressed maladaptive coping, increased treatment retention, and stress reduction. Gaps in treatment include the fact that treatment is substantially more expensive for those who have co-occurring diagnoses. Additionally, the identification of family characteristics in treatment has been linked to better quality of care for non-white participants who are severely underrepresented in most research. The question the literature informed my process is, how can dance movement therapy intersect with these three paradigms as well as address the gaps? Miracles in Progress, or MIP, is a residential program for men who are homeless and in recovery, located in Philadelphia, Pennsylvania. The premise of MIP is that through treatment and psychosocial support, participants can grow out of the confines of addiction, like how flowers bud and grow despite adversity. The mind-body connection of psychosocial treatment could serve as a catalyst for therapeutic and behavioral change. The main questions that organizations want to know is, what makes DMT so unique from existing treatment? One particular contribution of dance movement therapy with substance use is the containment of defenses, which directly counters some known addictions treatment. Rather than forcing these defenses to be surrendered, DMT participants are asked to acknowledge these defenses, be aware of them, and contain them. A treatment goal for clients in DMT is to increase the sense of self while focusing on the affects that these defenses are protecting. Groups can enable corrective emotional experiences as it relates to primary family systems. The nonverbal processes allow for participants to be seen as they are, thus establishing healing processes in group DMT. Another concept within DMT is the somatic patterns of giving up or hyporesponse. Movement can regulate and initiate the muscles by inviting them to shift from static tension to a more dynamic use of power. These passive areas in the body are often related to avoidance, which is a common trauma response. The empowerment and activation of these muscles has the ability to increase social engagement, which in turn regulates unconscious defense mechanisms. DMT has been shown to promote and sustain resiliency, positive affect, and psychological flexibility for those with chronic pain. This is particularly key in the application of addictions treatment in order to rebuild the natural opioid system to increase emotional and physical resiliency. The following is a clinical example from my time at MIP facilitating groups. I'm going to describe a moment of trauma coming alive in the body. The client, G, used strong words and movement metaphors that I will be reenacting. A group of men were passing movement that they remembered from their childhood, and the other members would repeat the movement. Members were giving movements such as the wave or the robot. When it was G's turn, he began to imitate his mother, vividly beating him while rhythmically verbalizing, "This is dancing with my mother." He began to laugh nonchalantly, bringing his defenses up. In that moment, I knew I needed to validate his trauma, ground the group, and transform this traumatic reenactment. Therefore, I encouraged the group to repeat this movement. I then turned to G and asked, well, where are you now? G threw his hands up in the air and said, I'm free from that shit. The group followed, both verbally and physically. Taking G's cues, I turned attention to the group, prompting every member to embody the theme, where have you been and where are you now? This exemplifies how DMT can aid in processing the traumatic experiences through validating defenses and experiences in order to elicit growth and reflection. I also conducted extensive research and cross-analysis of comparable jobs with respect to budget, planning, and evaluation. The program proposal developed requests a total of $48,200 to hire a dance movement therapist at MIP. This cost includes supervision, continuing education, and necessary props. Participants will have a voice in shaping their treatment and will be asked to evaluate their progression towards treatment goals for recovery. Individual and group dance movement therapy sessions will be tailored to the participants' needs as formulated by the dance movement therapist. In order to continue to track the progress and evaluation of dance movement therapy, the therapist will write clinical notes as well as attend treatment team meetings to continue to assess the work of DMT at MIP. While large systems cannot be overturned in a night, small steps can be taken to create opportunity, accessibility, and community through DMT. Dance movement therapy has a unique lens of movement and how it may relate to the expression of emotions and memories. There is an opening for DMT to enter the conversation and enhance the treatment for addiction through more funding and research. By having the knowledge to create a program proposal within reasonable parameters, therapists can find new avenues to advocate for their work, thus advocating for their clients. Thank you for listening to my presentation, and I look forward to answering your questions shortly.
My name is Sarah Doan, and in fulfillment of my Master's in Art Therapy and Counseling degree, I am presenting my culminating project titled Art Therapy Informed by Victorian-Era Mourning Practices. The question I sought to answer through this project is how a person experiencing grief could benefit from art therapy that utilizes Victorian mourning practices in treatment. My reasons for choosing this topic are many, however it boils down to a personal interest in Victorian expressions of mourning and a need to explore my own grief after the loss of my father. The literature I will discuss first covers what those Victorian mourning practices are, as well as current ideas about working with grief in therapy. The most recognizable mourning practice from the Victorian era is the mourning garment. Dull, black fabrics, usually a fabric called crepe, were worn for a period of up to 2 years. Veils were worn by women, and crepe arm and hat bands were worn by men. Flowers, real and artificial, were also associated with mourning, and were often made into elaborate displays to be included in memorials. Different flowers and plants symbolize different values. The wheat in the background of this wax floral arrangement typically represents the harvesting of a person's spirit at their prime. Memorial cards were common ways to announce death, as well as to create a keepsake in remembrance of the deceased person. Colors were almost always black, often with gold or white lettering. Visible grief was considered a normal part of the grieving process. Mourning garments signaled to the outside world, acquaintances and strangers alike, that a person was experiencing grief, and to perhaps treat them gently. Grief was made visible through mourning photography, depicting grieving individuals in full mourning costume, and at times posed to show intense emotion. Grief was also made visible by the decor outside homes or businesses of deceased individuals with black and white wreaths and ribbons. Finally, relic objects were popular mourning keepsakes. A relic object was any object that belonged to the individual, frequently hair, clothing, or personal objects. While grieving individuals in contemporary society often retain keepsakes from lost loved ones, relic objects in the Victorian era were often manipulated into artworks or special mementos to display in the home. Empty children's shoes were commonly preserved and kept as a memento after a child passed away. Hair from the deceased was often made into elaborate works of art or incorporated into jewelry. It could also be incorporated into a photo keepsake. Relic objects could be particularly useful when engaging in art therapy for grief when discussing and exploring the idea of continuing bonds. Continuing bonds, a contemporary topic in therapy for grief, is the idea that maintaining attachments to the lost loved one can aid and assist in the grief process by easing the sense of loss and helping the grieving individual accept the death of their loved one. A relic object can assist in maintaining attachments to a deceased loved one and can behave as a transitional object for the bereaved person, helping to integrate the loss into their new reality without their loved one. Narrative therapy also comes into play, as grief becoming visible through clothing or artwork tells a story to those outside of the loss of the grief being experienced by the bereaved individual. Since my goal for this project was to explore whether or not utilizing Victorian-era mourning practices in current art therapy would aid in the grieving process, I decided to explore my own grief around losing my father to cancer during the course of the graduate program. I set out to create several artworks, each either utilizing a relic object or communicating a story through visible grief. The first artwork, titled The Wake, was a still life set up and photographed to explore the intense emotions experienced during and after my father's wake and funeral. Florals were used to symbolize the disparity between the life and death present in the room with his casket, where overripe oranges and orange skin symbolized my father's body, empty of the life I had grown to expect would come from it. The next artwork, titled The Duality of Grief, used imagery of denial and mourning to show the process of grieving while utilizing pressed rose petals from my father's funeral and 31 beads, each for a year I knew him, looming over the emotional experience. This artwork was started before Valentine's Day, where, while shopping for a card for my husband, I found one I would have purchased for my father. It says, "Love you more," and reminded me of a word game we used to play. The card was painted black and arranged with dried flowers from his funeral. The matte black paint makes the words nearly impossible to read, symbolizing the words are only a memory now. The next artwork, titled A Wish, was created with flowers from my father's funeral, a thrifted and broken terrarium, its shape akin to that of a home, a cardinal sculpted from clay and paper, and a lock of my father's hair. This work emerged from folklore about cardinals symbolizing lost loved ones returning to visit, and represents my deep desire for a message from my father from beyond the veil. Finally, I began creating this mourning garment made from a thrifted dress bodice and 6 yards of thin crepe fabric. The dress is overall shaped like a tear and is impossibly long. It can't be worn without great difficulty and parallels the burden of grief. The experience of creating these artworks was illuminating, comforting, and sometimes difficult. Through creating with relic objects, I was able to reflect on the experience of losing my father and was able to feel close to him through the act of making. Here are some other things to consider. I personally chose to examine Victorian mourning practices due to my own interest and because of its recognizability and relatability, but other cultural mourning practices could be utilized as well. Because so many cultural values and practices are always changing, personal value is more meaningful than a specific historical period. Next, an important consideration is to take care when using relic objects. While using my father's hair, I did not properly plan the space in which I was working to account for loose strands. This caused a moment of panic, as I did my best to collect each individual hair that had dropped from the rest of the lock. Planning ahead and setting up a space conducive to using material that is finite and irreplaceable could be helpful. I also discovered that a client may not be ready to manipulate relic objects. When creating the Duality of Grief artwork, I intended to cut a black shirt that had belonged to my father to stand in for a veil. When it came time to cut the shirt, I found I could not bring myself to do it. That is okay. I was not ready. It's part of the processing. Additionally, I want to note that my experience is a singular one. More study is needed, and good rapport with and knowledge of a client would be extremely important, as well as collaboration. Finally, my view is of a Western perspective. There are many different cultures around the world who process death and grief in different ways, and multicultural perspectives on death, grief, and mourning in art therapy are necessary. Thank you for viewing. Here are my references. I want to thank my culminating project advisor, Natalie Carlton, for all of her wisdom, insight, and time. And thank you for dealing with my checking, double-checking, and triple-checking. Additionally, I want to thank my husband, Daniel, for supporting me through grad school. His devotion and love lifted me up through this process, and my life is more complete with him in it. I also want to dedicate this culminating project to my dad, Alden Lincoln Doan III, whose 61 years on earth were spent serving others, raising his children, and loving his wife. We really miss him.
Hi everyone and welcome. My name is Maricela Hurtado and my work is titled It Takes a Village, using dance movement therapy and the 12-step recovery model to support sobriety and making amends. Thank you to my past and present supervisors, as well as my culminating project committee that had a hand in both my education and making this project possible. This project really began in my undergraduate internship at the Kirkbride Drug Rehabilitation Center. Here is where I really found my passion for working with the substance use population. While there, I noticed that oftentimes the family members and the support system around the person who's addicted were neglected. When doing research on what literature is available, I focused on how family members are affected by addiction, specifically the Hispanic family, and how dance movement therapy can promote healing. The term family references anyone who is in a supportive role to the person who's addicted. Some examples of this may be a friend, a spouse, a partner, a child, or even a parent. Within the literature, the family is often neglected, but they in fact are just as affected by addiction as the person who's addicted. Oftentimes, the literature stated that family members can feel a range of emotions, from guilt to anger, resentment, and can experience anxiety, depression, physical ailments, as well as traumatic symptoms that may lead to post-traumatic stress disorder. Overall, addiction causes an emotional toll on the family. This causes family members to lock into these different roles that may not be helpful, such as enabling the person who's addicted. In order for everyone to heal, the family must release these roles, or the risk of relapse is greater for the person who's addicted. I wanted to focus on the Hispanic family specifically because it's important to be culturally competent at all times. It is our ethical obligation as therapists and individuals to look at each person fully for who they are, which includes being culturally inclusive and takes into account how society may oppress or afford privileges to this individual. When looking at the literature and when looking at my own family, I notice an emphasis on the group and not the individual, which is referred to as familismo. This is important because oftentimes Hispanic families are very private, and they have difficulty being open with those outside of their family, especially health professionals, since many Hispanics do not have the same access to mental health services as their white counterparts. This may create a barrier in how open they are as well. Many Hispanic families also have gender roles, such as Marianismo and Machismo. Marianismo is the submissive, giving woman, and Machismo is the proud, strong, caretaking man. This may have an effect on addiction within the family as well. Overall, within the literature, it is important for the family to sustain physical, mental, and spiritual health by addressing their physical and emotional needs, which can include setting boundaries with the person who is addicted. Giving the family the tools to help with treatment will ultimately take the burden off of the family and allow everyone to heal. NAR-ANON groups and LearnToCope.org both provide resources, support, and meetings for family members of those who are addicted. More research, though, is still needed on the effects of addiction within the family and how addiction affects the Hispanic family. When looking at dance movement therapy literature, we know that trauma is stored in the body, as emotions originate in the body and trauma is stored in implicit memories. Movement is the only way to allow this trauma to be moved and leave the body. Dance movement therapy, or DMT, promotes body-based self-discovery, allows the individual and the family to separate themselves from each other to heal, allows for transformative creative expression, freedom, strength and self-esteem, allows for one to develop a new set of emotional resources, allows for one to utilize inner strengths, symbolic imagery, and creative expression to approach trauma without re-traumatizing the individual. Again, more research is needed around dance movement therapy and the effects. I have chosen to incorporate dance movement therapy concepts and movement explorations with the 12 steps of Narcotics Anonymous. I chose to do so because I felt that in order for the family members to heal, The person who is addicted must heal first. The 12 steps of NA are an important process in the sobriety of many addicts. Anyone who identifies as an addict from any mind-altering substance can join the Narcotics Anonymous program. The Narcotics Anonymous program is a nonprofit fellowship program that was formed in July of 1953. It is important to incorporate the 12 steps in a way that addresses the needs and beliefs of your client. I have chosen to utilize traditional NA language in order to respect the origins of this work. When working therapeutically, it may be beneficial to change the language. The word God is utilized often, which when working can be adapted to any belief. I have grouped together the NA 12 steps and have taken the names of the steps directly from the Big Book's language. I chose to incorporate dance movement therapy suggestions because DMT could perfectly complement the 12 steps and address the trauma that addicts often experience. Steps 1 to 3 are let go and let God. This means fully surrender, admit, accept, and relinquish control. The dance therapy concepts are utilizing the horizontal plane, bipolar shape flow with widening, spreading with indirect space, and to transition to the next steps, ascending with lightness. A possible prop that can be explored is the blue band. It is a circular, stretchy piece of fabric that allows one to feel their weight in it and to really connect with others who are also within the band. An image to explore is opening up to receive. Steps 4 to 7 are revealing the defects. This means taking a personal inventory, asking God to remove shortcomings, taking action, and admitting when we are wrong. The dance therapy concepts are to transition from the previous steps using enclosing, the vertical plane, descending, strength, and transitioning to the next steps include retreating. Some props to explore are the use of the body sock. This is a big piece of fabric that one can put their whole body in and can ultimately use to cover themselves up, to hide when they're feeling ashamed or guilty, and also to really take an internal inventory and reflect on oneself. An image to explore is going into a safe place. Steps 8 through 9 are achieving freedom from the wreckage of our past. This means making a list, becoming willing, making amends if possible and safe. For dance therapy concepts, it's utilizing the sagittal and horizontal plane, using spreading with channeling, directness, advancing. To transition to the next steps, utilizing gentleness and lightness. Some props to explore are scarves or balloons. The balloons can really help with that channeling and really connecting with others in a way that really expresses what you're trying to say. The scarves allow for that gentle, light nature, as well as exploring, spreading, and advancing. An image to explore is welcoming someone in for a firm hug. Steps 10 through 12 are God helps us as we help each other. So having awareness of defects in the present, increasing your awareness of a higher power, utilizing meditation and prayer, and helping others in the fellowship. Some dance therapy concepts are using the full kinesphere, so the horizontal, sagittal, vertical planes, so a balance of enclosing and spreading, a balance of ascending and descending, advancing and retreating, really trying to find a balance here so that there is no impulsivity which could lead to relapse. For steps 10 to 12, I have named the movement exploration band together. A prop suggestion would be to use the octoband. An octoband has a circle of fabric in the middle with 8 arms that everybody can hold onto on the outside. This octoband is a connecting tool. It really allows you to feel the movement from the other person on the other side of the octoband and really allows one to support each other and to really give and receive information. Images to explore are a train moving in and out of the station and circling around, and how you can find a way to support others. Thank you so much for tuning in. And if you have any questions, I will be around after at the panel to answer any questions that you may have, or you can always email me right here.
Hi, my name is Brittany Henderson, and I welcome you to my culminating project presentation. My project is entitled The Transfiguration of Desire, using dance movement therapy to address human sexuality and intimacy within the neurorehabilitation setting. I want to first begin honoring God, my parents, and the clients I've had the pleasure of working with over these 2 years. I want to acknowledge my culminating project advisor, Dr. Sherry Goodill, my 2 clinical practicum supervisors, Melissa Greer and Amber Ransom, and last and certainly not least, my internship supervisors, Tori Klein and Natasha Levitas. Let's start with the genesis of my story. In 2017, I took an internship at a large hospital in Dallas, working in the neuroscience intensive care unit and the progressive care unit. At the time, I was a dance major with extensive experience in the medical field. I remember during my interview, I was asked, "Why are you pursuing a medical internship as a dancer?" I'm not quite sure what my answer was, but I was hired on the spot and went on to develop a 5-week dance therapy project working with critically ill patients. I remember that one client. She was on a ventilator, nonverbal, and partially paralyzed, with only a couple of weeks of life to live. I remember during one of our sessions, something miraculous happened. She began to wiggle her toes, her hands began to move, and tears began streaming down her face. After that session, she told me, on a piece of paper, this was the first time I felt alive in this hospital. This statement instantaneously became my why and my reason for pursuing a career in dance movement therapy. Now, I want to further investigate how dance movement therapy may be used to address sexuality and intimacy within the neurorehabilitation setting. Individuals living with brain injury have been often forgotten in a discussion on romantic relationships, sexual intimacy, and expressions of desire. There is not enough research addressing the sexual needs of those living with brain injury and how this might affect quality of life. Dance movement therapy has given me a platform to advocate for many clients living with brain injury and physical disabilities, and has given me an opportunity to provide an embodied experience. Neurorehabilitation research has reflected a need for sexuality to not just be a discussion held by one entity in rehabilitation, but to take on an interdisciplinary approach. This statement alone has enabled me to look at the research being done in DMT. Baum 2018 talks about a sense of avoidance in sexuality, especially when it comes to therapeutic training and disability studies. This type of avoidance can negatively affect the therapeutic relationship. There are ethical concerns regarding the use of touch in DMT. Boundaries and ethics should take priority to ensure that we are not instilling any harm into our clients. Overall, the literature has seldomly acknowledged the sexual experiences of people of color and sexual minorities with brain injuries. With this literature gap in mind, my guiding question began to be, how can I psychoeducate the community about the biopsychosocial needs of individuals living with brain injury, while also simultaneously creating space for sexuality in dance movement therapy? I then decided to plan and facilitate a public forum. This became 2 different forums, one aimed at clients and one focusing on professionals working in the neurorehabilitation setting. The global pandemic shifted my focus and encouraged me to embrace the power of technology. Both clinical forums were canceled due to COVID-19. I was to return home, and as I returned home, I experienced much grief and confusion. However, I started to remember my initial why, and this gave me hope. I then began to plan 2 virtual forums. The first forum was client-focused. It was titled, "What Moves You? An Exploration of Connection and Intimacy in the Midst of Isolation." During this virtual forum, clients had an opportunity to talk about their experiences and how they've been coping with social isolation, especially during a time of social distancing. I was encouraged that a lot of clients experienced much joy during this time and had the opportunity to look into other entities. We discussed the different types of intimacy, what isolation might look like, while also engaging in an exploration of movement. Clients shared that this movement experience gave them a sense of vitality, and it also gave them a new perspective on how to look at isolation during social isolation. The last forum focused on healthcare professionals. The title of this forum was "Let's Talk About It: The Role of Human Sexuality in Neurorehabilitation." During this forum, healthcare professionals learned about the socio-emotional and sexual issues experienced by brain injury survivors, explored the role of dance movement therapy in empowering sexuality, unpacked discriminatory influences associated with sex and disability, and discussed the importance of being sexually competent as healthcare providers. This forum led to a transformative conversation and transparency. Healthcare professionals talked about their experiences discussing sexuality with their clients and also asked questions. This project has led to new discoveries. I have found insight to the ongoing dance movement therapy work that needs to be explored in sexuality as it relates to those living with traumatic brain injuries and acquired brain injuries. Conducting these forums virtually has transformed this project in a phenomenal way. Participants shared that the topic of sexuality should be at the forefront of neurorehabilitation and should no longer be treated as a taboo topic. The medium of technology during a global pandemic has created space for people to connect in creative ways. It has also fostered a sense of virtual intimacy. I have found dance movement therapy to be an effective tool in discussing sexuality. However, I believe that much work needs to be done in making dance movement therapy more inclusive for all abilities. I have found that ableism has impacted our clinical work as therapists, making intervention accommodation a second thought. There is more need for interventions that are culturally sensitive and interventions that can be modified to meet client needs. Overall, this project has really impacted the way that I see myself as a dance movement therapist and has enabled me to focus on cultural concerns related to dance movement therapy, sexuality, and brain injury. I will now open up for questions. Thank you so much for taking out the time to listen to my culminating project presentation. I hope that you and your families are staying healthy and safe during this time of pandemic.
Go.
Hi, welcome everyone. My name is Dawn Morningstar. I'm a faculty member in the Dance Movement Therapy and Counseling program, and I'm here with
Michelle Rattigan, and I'm faculty in the Art Therapy and Counseling program.
So we're here with our panelists from presentation. So we're going to ask them to introduce themselves and their presentation, and then we'll have questions for them. So I'm going to start with Rachel. Can you introduce yourself and your project, please?
Hello, everyone. My name is Rachel Mendez, and I did an application and approach looking into adaptive equipment and ambulatory tools for dance movement therapy in the medical rehabilitation setting.
Thank you. Brittany, can you go next?
Hi, everyone. My name is Brittany Henderson, and my project was entitled The Transfiguration of Desire, using dance movement therapy to address human sexuality and intimacy within the neurorehabilitation setting.
Excellent. Thank you. Emma?
Hi, everyone. My name is Emma Sadler, and my project was Dance Movement Therapy for Men Who Are Homeless and in Recovery, a program proposal.
Thanks. Sarah?
Hi, my name is Sarah, and my project was art therapy informed by Victorian era morning practices.
Thank you. Maricela?
Hi, everyone. My name is Maricela Hurtado, and my project was titled It Takes a Village, using dance movement therapy and the 12-step recovery model to support sobriety and making amends.
Thank you. And last but certainly not least, Gina.
Hi, everyone. My name is Gina, and my project was on music therapy grief support for young adults.
Excellent. Thank you all.
So we have a question that we'd like to ask all of you generally, so anyone can answer this. And this is that, you all develop these amazing, innovative methods and programs. And so anyone who is aspiring to do this work, or perhaps some of the students who are just getting started and thinking about what they would like to explore next year, might be really curious about any recommendations that you might have of how do you come up with these innovative ideas?
I can start.
We got to move out of our box. All right. Who would like to go?
I can go. So for me, obviously, since mine was so personal, it was really about where I was when it came time to think about what to do for this culminating project. And it had been on my mind since we heard what a culminating project was, because I knew my dad was sick. I knew that this might happen. And so really it was on my mind for a very long time as something that I needed to allow myself to do. And when I started the research, I found out that there was a place for it and there was space for it. So that I gave myself permission to go for it based on a need. So sometimes there might be a need that you have that will give you the freedom and allowance to do that for your project.
Awesome. Anyone else?
I can go. I know one thing that I'm always thinking of is from like a macro level of systems, how can the therapist and how can dance movement therapy really come into these systems to advocate for the well-being of our clients, and especially in societies and systems where they're severely underrepresented and not having access and equity to things. And so for me, I was just really trying to think of like the ethical implications of social justice and how therapists can come into these systems.
Excellent. Anyone else?
Yeah, I would love to answer. I think for me, it's okay. Like you might go in thinking that you have an idea, but your clients will really inspire you, and Sarah was talking about a need, and you'll very quickly discover what those gaps are and what those needs are for the populations that are closest to your heart. And I think from then, based with your own interests and desires and passions, these projects really come to fruition in such a beautiful way, as seen by all these wonderful presentations today.
And Brittany, you wanted to say something.
Yes, I was going to say, for me, it was kind of straying away from societal norms and allowing room for exploration of things that are not talked about. And sex is a topic that is not talked about. So at my internship, the value of sexuality is so pertinent in that population. So being able to just have the conversation about sexuality and understand that sexuality is an experience for everyone, not just able-bodied individuals. So for those trying to develop a project, looking outside of the box and looking at something that is not seen as normal.
Amazing. These are fantastic takeaways.
Mm-hmm. All right, so I have a specific question for Rachel. My question is, what other visions do you have for interdisciplinary collaboration with DMT, maybe specifically within the medical field, but in general as well?
I think there is tons of opportunities for integration with DMT across disciplines. In my internship, I was really focused on working with physical and occupational therapists as they were familiar with the equipment that I was trying to utilize to kind of break these ambulatory barriers, these ableistic views that sometimes dance movement therapy can come across as. But in my time there, I also had wonderful collaboration experiences with art and music therapy in another very amazing project. So I think the sky's the limit here. As long as the other therapists and modalities are willing to participate, I think for myself, I'm always willing to explore and really create things that are personal and individualized to the needs of my clients.
Excellent. Thank you. Gina, I have a question for you. It was commented that you had a great use of surveys, and people were curious as to what sort of questions were asked in the pre-workshop survey.
So it was a pre and a post-workshop survey. So some of the questions were like, what is your current mood? What is your current experience of grief? What do you hope to get out of the workshop? And then for the post survey, it was those same questions. What is your current mood? What is your current grief experience? And then things like, what was the most helpful thing that came out of the workshop for you? And like I noted this in my presentation, but what was interesting is that people noted more feelings of stability and hopefulness, and several people marked anxiety in the pre-survey, and in the post-survey, the anxiety was gone and it was replaced by like contentedness or feelings of stability.
Powerful.
Great. Emma, I have a question for you. So did you experience any of that stigma of men don't dance, that sort of idea that guys don't dance? And if you did, how did you navigate through that?
Yes, I did, from staff and from clients as well. And so I think the best thing that a therapist can do is just get someone in the room. The really great thing about movement therapy and just kind of process-based therapy is that there's no right or wrong way to be in group. And that's something that I always try to emphasize is, you don't need to be in group you don't need to be dancing in group to get something out of it. Even just being able to watch other participants move can be healing in and of itself, just the power of witnessing. So just trying to educate and allow people to be as they are.
Mm-hmm. Thank you.
Sarah, I have a question for you. Will you have an opportunity to expand on your research and also look into other cultural mourning practices?
So grief and mourning is something that I want to continue working on. That's sort of where I want to focus my practice with clients. So I absolutely will continue exploring that and ways to work with people experiencing grief using art therapy. I do believe absolutely there is a need for research into multicultural mourning practices and how clients from various backgrounds can connect with their therapist, connect with their culture in that specific instance of mourning and grief. I would absolutely like to collaborate with others on work relating to that. At this point, it's just, let's see where it goes. It's very interesting work. Obviously, it's something that relates to all of us. Everyone's going to have to experience this at some point. And how can we work through that together?
Yeah, it's really relevant at this time.
Yeah.
Absolutely. Yeah. Thank you. All right, Maricela, I have a question for you. How do you see this model expanding in the future? Where do you want to take it?
Yeah, thank you. In the future, I plan to really make this into something that dance therapists can utilize, maybe as a model for a way to integrate the 12 steps of NA on a body level. So I really want to look at more different cultures and how I can adapt this to fit and serve the needs of others, as well as, like I kind of mentioned a little bit in my project, the 12 steps utilize the word God a lot, and everyone may have their own different ideas of spirituality and their own beliefs. And so I really want to find different ways to adapt this to, again, meet the needs of those with different beliefs. I really wanted to stay true to the NA language for this, first initial phase of this project. But as I continue forward, just really making it more adaptable and more accessible to others on a movement level and just with the language used.
Thank you.
Brittany, I have a question for you. Did you find skin hunger to be a part of your work and research at all?
Thank you for that question. Yes, skin hunger was definitely a thing in this research. And also as I developed my sessions with my clients, dealing with a global pandemic and not being able to have access to physical touch was something that the clients really wanted. So I kind of developed a term called virtual intimacy that I used in my project. So we weren't in the same room, but through the screen, we were able to develop this sense of virtual intimacy. So we played around with our hands, where we did a lot of things with the screen to foster that virtual intimacy. So yes, virtual intimacy was something that was explored, and it kind of gave them a sense of sensation dealing with skin hunger.
Thank you for answering that.
Thank you.
Another general question for everyone, right?
Yes, and this is kind of a broad question, so feel free to answer this however you want. How has this exploration inspired your expanded use of the creative arts, either in your practice, or how do you see this in general?
Okay, I'll start. So I didn't realize how much people wanted to have the conversation about sexuality, especially when it comes to the neurorehabilitation realm. So I was actually asked to present my DMT work at a brain injury conference in the fall. So I'm really looking forward to that. So it's just really important that we continue the conversation and make this a topic that is not so taboo, but something that is normalized. So hopefully I continue to do workshops and continue to do the work in this field.
I hope so too. Anyone else want to tackle that idea, that concept? Where are you going to move forward with your innovative experiences and your exploration?
Yeah, for me, I really found that within addictions treatment, I noticed that a lot of therapists don't have a very good understanding of the 12 steps and the whole NA organization. And I think it's really important if you're working within this population to really have that understanding, because this community is really important and helps them when they are out of treatment. So this is really, what helps with relapse prevention and is really a support system. So I think finding a way to kind of combine that and also educate people on some of these concepts so that we can kind of merge treatment and this community aspect is super important.
Mm-hmm. Nice.
Well, for me, if I could jump in, my internship was a little bit unorthodox. It was really an internship in bereavement counseling as well as music therapy. And for me, this project really just reinforced how powerful music therapy can be when supporting people who are grieving and in bereavement. And in my literature review, I found that there really isn't a whole lot of literature on it. So, I would love to work with this population in the future and continue to advocate for music therapy being infused in bereavement counseling, because I think it can really help and support people.
Mm-hmm. Sounds like you and Sarah need to get together.
Yeah. That was the other thing I was thinking too, is just there's so many collaborative opportunities here. And when you're studying and working so intensely in your specific discipline, sometimes we wind up siloing ourselves, right? And compartmentalizing ourselves. And this is the opportunity to kind of like break those barriers and recognize how much crossover you did in your work and in your scholarship, and how this is just a tiny little seed for that. This is going to grow exponentially from here. And we are just so honored to have been your instructors and advisors and just watching you through this entire process. We are just totally blown away.
Excellent work, everybody.
Yeah.
Does anybody else want to add to that thought in terms of their work, where they're going to take it?
I'll chime in real quick. I think for me, it's also not just informing and having a conversation with the larger community, but really bringing it back just to our discipline itself and informing each other on things that we don't get to really experience or really dive into in our schooling, and just kind of overcoming all these preconceived notions about what our disciplines are and what they can do and who they can reach, and really just redefining that, and being able to continue, for me, expanding different creative techniques, because you have to be creative when you're meeting challenges, especially in the medical rehabilitation setting, where 100% of the individuals are in wheelchairs or they're in their beds, and there is a huge mental barrier of movement, especially after the resulting limitations on movement that come out of it. So just taking all of this knowledge, creating more ways to work, and bringing it back into our education for future people in our discipline.
Great. Thank you, everybody. We need to finish. This was a fantastic conversation. Big round of applause for everybody on the panel and for your hard work. So we're going to take a little break and we'll see you back in a few minutes.
Thank you.
Welcome back, everybody. We are about to start in about 2 minutes for our final module of the day, Sense and Being. So this module is about sensory integration, about using the senses in therapy. So we're going to take a second in this warm-up to sort of move from your bones. So thinking about your internal body system. How do your bones operate? How do your bones make your body move? And what does it feel like to move from the inside versus from what you see on the outside? So take a second and just, if you want to do this by kind of lowering your gaze, or you can close your eyes if you want, and just kind of see what your body wants to do without thinking too much about it, without worrying about what it looks like, just kind of sensing what your body needs right now. And we've been watching lots of videos today, so this is a good time to do a good check-in with your body, see what you're feeling. Is it warm? Are you cold? What's your skin feel like? Are you feeling clammy? Are you feeling dry? Are you feeling comfortable? Are you feeling nervous? Kind of what's happening on your sensory level, and how does that influence what's happening inside and your feeling? So as we're going to begin, I'm going to ask you to come sit in your chair, and we're going to pay attention really quickly to our senses. So take a minute and just listen in your environment and see what you hear. Might be birds, cars, or people. Really attuning to the auditory. And take a second and see if there are any scents or smells that come into the room. Maybe it's flowers or cooking. And pay attention to what your body feels like. What's your skin feel like right now? And finally, let's focus on what you're seeing, because we're going to see another group of presenters today. Pay attention to color, shape, line. So really attune your senses for this next set of presentations. And we're going to focus, and we're ready to go. Module 5, Sense and Being.
Welcome to module number 5, entitled Sense and Being. My name is Dr. Christina Devereaux, and I am an associate clinical professor in the Department of Creative Arts Therapies here at Drexel University, and the program director in the Dance Movement Therapy and Counseling Master's Program. Thank you for being here for this module of this program. If you're joining us at the start of this module or for the first time today, you will soon view and listen to 6 graduating Creative Arts Therapy, or CAT, student presentations based on their graduate culminating projects. You are viewing this CAT Colloquium content being broadcast live on a private YouTube channel. You can listen and view these presentations in their pre-recorded sequences, and you may wish to add questions or comments in the chat box function. To share any questions or comments ahead of the small group discussion ending each module, you must log in to YouTube via Google or a Facebook account. There are live Q&A sessions with all the presenting students of this module and 2 moderators at the end of each module throughout our program. This module, Sense and Being, is about the intersection of inward attention, aesthetics, attending to subtlety, and the role of the creative arts therapist. You will hear Kara Hertnecke questioning the dominant narrative of visual art, where she examines the qualities of multimodal and sensory engagement in art therapy. You will hear Ying-Jun Luo examine a consultant model for music therapy and pain management. Ashley Caldero examines the role of inward attention for her developing professional identity in the process of engaging in response art. Lydia DeLorio unpacks the literature of interpersonal neurobiology, specifically mirror neurons, interoception, and empathy, and how this research can support dance movement therapy practice and research. Next, Gopi Shah examines the therapeutic use of playing with light and shadow. The module will conclude with Phil Forrest, who describes a model used in a rehabilitation hospital, light painting photography. All of these presenters require us to examine the role that multisensory experiences through music, art, and bodily sensation plays in the greater conversation beyond dominant narratives in arts media, research, or ways of practicing. This module is an invitation to slow down, be, attend inwardly, and examine how music, art, and movement's sense and being intersects with science. So, to begin this module, I invite you as a listener to engage in a new way of listening to these presentations by also attending to the multisensory experiences around you. Listen to them in a new way. Sit on the floor. Turn off the lights. Stretch yourself. Experience your sensations while being fully present with these exceptional project presentations. I know you will enjoy them.
Building Multisensory Awareness in Arts Participation, a culminating project by Kara Elise Hurtnecki and advised by Dr. Natalie Carlton. In Western cultures, the word art is commonly paired with the word visual. My culminating project started with a simple question: why? Why is art synonymous with visual culture? Why does the connotation of the word art imply something to be seen and imply something that is sensorily different from other forms of expression, like music, drama, or dance? And how does culture and language perpetuate this sight-focused narrative? Before I knew how to answer these questions, I did know that my relationship with art was beyond visual. Yes, art is seen. But also, art is touched, heard, tasted, smelled, embodied, questioned, shared, destroyed, found, intuited, rejected, cherished. Art is experienced. My culminating project explores multisensory engagement in the creation and observation of art as a means to deconstruct the visual dominance that art portrays in Western culture. Through a series of self-directed arts-based experientials, I explore my own sensory dependencies and biases, and challenge them by focusing on highlighting other sensory modalities and integrating new systems of perception. The sensory modalities that I focus on include sight, sound, taste, smell, touch, proprioception, vestibular, and interoception. I argue that through the multisensory participation of creating and observing art, we're able to build awareness of ourselves, our relationships, and our environment. With this, I am simultaneously reconstructing the discord of aesthetics, exploring the sensory and cultural implications of materials, and looking to discover ways to engage in a more holistic and inclusive art therapy practice. In my review of the current professional literature, I studied a wide range of fields that focused on the biological, psychological, and sociocultural components and implications of multisensory engagement. My review discussed how sensory hierarchies have shaped perceptions of and created privileges within the artistic experience, particularly through Western ocular centrism, in which vision is privileged over other sensory modalities. The purpose of my literature review was not only to critique perceived dominance of the visual sense in Western cultural studies of art, but also to study the qualities of multimodal and synesthetic sensory engagement in various fields. Multisensory systems are reviewed in the fields of neuroscience, philosophy, history, anthropology, art education, art exhibition, and art therapy. Themes of studies within my literature review include multisensory integration in the brain, sensory hierarchy and visual dominance in Western art practices, multisensory embodiment and perception of creating art, multisensory mental imagery and synesthesia related to imagination, memory, and learning, concepts of creativity, flow, and improvisation, multisensory studies of empathy, materiality, and aesthetics as cultural and relational constructs, and lastly, inclusive art exhibition and sensory design. For the sake of my own literature review, I studied the surface of a wide range of disciplines. There is further opportunity to explore each of these topics in great depth and detail. In addition, there is opportunity to explore research that extends beyond the paradigms of Western arts culture and integrate points of view on the creation and observation of art from non-Western perspectives. In designing and implementing creative approaches to sensory discovery, I am able to bridge connections to the existence of my mind and body, my relationship and communication with others, and my interactions within my environment in a more meaningful way. Based on the format of this presentation, experientials that could be captured through visual documentation will be shown to explore the following themes identified from my culminating project. 1. Visual mark-making inspired by non-visual stimuli. 2. Building sensory language and relational experiences. 3. Documenting and reviewing through audio recording and sensory journaling. 4. Increasing tactile sensitivity through sculpture and form. 5. Sensory mirroring, particularly through visual and audio stimuli. 6. Manipulating traditional art media and tools to build sensory awareness. My goals for this project are ongoing. As I continue to build upon my multisensory awareness in the creation and observation of art, I aim to draw attention to sensory bias and increase my competence of materiality and sociocultural art paradigms. I also strive to work with other fields and creative arts therapies to develop holistic approaches to treatment, working with resistance to art making instead of against it, and put emphasis and value into the creative process of art making, not just the product. Ultimately, I argue that building multisensory awareness in the creation and observation of art creates opportunity to engage in one's creative expression through a more competent and inclusive approach, and can allow for more holistic stimulation to one's social and psychological health. Multisensory arts participation increases and diversifies the accessibility to arts education, arts exhibition, and art therapy. As my graduate school experience comes to a close, I want to express praise and gratitude to the following supports. First, thank you to all of those who participated in my culminating project directly. A very special thank you to Austin for the initial kick in the pants to apply for school. Your support throughout the last 2 years has been an integral part to my preservation, curiosity, and happiness. Thank you to my family, especially my sister and my dad, my original support beams and sources of inspiration. You are strong advocates of mental health care and have encouraged me to find my own voice in the field. A special thank you to my art therapy professors and supervisors, particularly Michelle Rattigan, John Lutz, and my advisor, Natalie Carlton. And lastly, Thank you to my dear cohort and soon-to-be colleagues. I truly value the honesty, creativity, and integrity of each person in my cohort and the respect and friendships that were formed through our curiosity and vulnerability with each other. It's been a true privilege to learn alongside each and every one of you.
Hello everybody, my name is Luo Yingjian. Welcome to my culminating project presentation. My title is Self-Efficacy and Pain Management, a music therapy consultant model. Here is some brief introduction about my project, and I will talk about some background literature which include pain, gait theory, music therapy and pain management, music listening, live music making, and music assisted relaxation. Also, I will talk about some recommendations for a consultant model, which also include music therapy, music assisted relaxation, and a plan for independent use of music assisted relaxation. My purpose of doing this project is I want to help people get a better understanding of pain and pain mechanism. Also explain why music therapy can help with pain management. Finally, I want to establish a consultant model for people to manage their pain at home. So let's talk about pain. What is pain? According to International Association for the Study of Pain, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. What pain does to us? The purpose of pain is that pain can motivate the individual to withdraw from damaging situations, to protect a damaged body part while it heals, and to avoid similar experiences in the future. There are two different types of pain, acute pain and chronic pain. Acute pain is a normal, predicted physiological response to an adverse chemical, thermal, or mechanical stimulus associated with surgery, trauma, and acute illness. The chronic pain is associated with chronic pathological process, is defined as pain that persists longer than the temporal course of a natural healing and is associated with a particular type of injury or disease process. Chronic pain can be a very serious problem because chronic pain negatively impacts multiple aspects of patients' health, including sleep, cognitive process, and brain function, mood and mental health, cardiovascular health, sexual function, and the overall quality of life. There is a very famous theory called gait theory, as well as the gait control theory of pain. It describes how non-painful sensations can override and reduce painful sensations. Here is a picture that explains the mechanism of gait theory. Pain signals can be interrupted in the substantia gelatinosa of the spinal cord, which acts as a gate. Music is able to override the painful sensation and help people reduce the pain. When we talk about music and pain, we need to talk about music therapy. What is music therapy? According to American Music Therapy Association, music therapy is a clinical and evidence-based use of music interventions to accomplish individualized goals. In music therapy, music is used within a therapeutic relationship to address physical, emotional, cognitive, and social needs of individuals. Music therapy is harmless for human body, also without any side effects. Like Bob Marley said, One good thing about music, when it hits you, you feel no pain. There are some different methods that can help with pain management. First, I want to talk about the music listening. Music listening can help with distraction and relaxation, brings positive impact on mood and arousal, help with heart rate, blood pressure, and breathing. Also increase endorphin release in order to reduce the pain. Also, I want to introduce live music making, which include songwriting, song singing, music instrument improvisation, and vocal music improvisation. Another music therapy method is music-assisted relaxation, which included guided music relaxation, guided music imagery, and self-generated imagery. Music therapists will give verbal guidance for both guided music relaxation and guided music imagery. Like I said in the beginning, I want to establish a consultant model of pain management for people who are not professionals. What is consultant model? Consultant, they provide expert advice in a particular area such as business, education, law, healthcare, engineering, science, or any of many other specialized fields. In this consultant model, I will focus on music therapy, music assisted relaxation training, and a plan for independent use of music assisted relaxation. There will be two parts in music therapy, which included music listening and live music making. In music listening part, the model will focus on preferred music and recommendations of different types of music. In live music making part, the model will focus on choice of music instruments, music experiences and instruments that are accessible to those with no previous training. Also, music therapists will provide a framework for meaning making in music. In music assisted relaxation training, there will be a relaxation instruction and how to select music, as well as scripting, spot relaxation, and access zone scanning. Access zone scanning is about focus on a particular part where pain comes from. For the last part, plan for independent use of music-assisted relaxation. The model will create a self-relaxation script and then transform it to an audio recording. Also provide a list of recommendation music and music selections, as well as a rationale of music therapy and music-assisted relaxation in pain management. In the end, I really want to thank Flossie, the director of music therapy program in Drexel University. She gave me a lot of support and help since I came to Drexel University, as well as my culminating project. I am really appreciated. Also, I want to thank my family. They support me without any condition. And I want to thank my music therapy program cohort, the whole faculty, and all my supervisors. Here are some references I used in my culminating project.
My name is Ashley Caldero. I am presenting my final project titled Creating Response Art and Its Role in Developing Professional Identity in fulfillment of my Master's in Art Therapy and Counseling degree. The inspiration for my project came from the frequency I was creating response art. I began to feel some resistance to this process, so I decided to push myself to find purpose in creating. I came up with the question, how does response art play a role in developing my professional identity? The idea of professional identity was also being talked about frequently in courses. What did this mean for a graduate student with an art therapy and counseling degree? Through my literature review, I began to investigate the history of response art and the different purposes art therapists have used it for. The main intentions behind creating response art included using response art in session with clients as a way of further pushing the process. It is also used as a tool for self-care and throughout numerous courses in graduate school, particularly supervision courses. I also researched the Eld-1-Day process introduced by Abby Miller, where one piece is reworked over a period of time, generally in a supervision class. I wind up engaging in a similar process at the conclusion of my project. My literature review also revealed that the two most commonly titles used for the degree are Masters in Art Therapy and Counseling and Masters in Art Therapy. Other titles integrate a range of fields, including marriage and family counseling. As seen on this slide, I have included images of a collection of my response art. All of these pieces fall into the same theme that I will discuss later in this presentation. My plan for this project was to create at least 2 pieces of response art weekly. My supervisor already required a weekly piece of art to use in individual supervision. The response art was either created in a journal of mine or on a circular cardboard coaster. I generally made response art while at my internship site, usually immediately after a session. After I created the majority of my response art and was halfway through my final quarter, I reflected on the pieces made and identified recurring themes. I then decided that my final project would be a synthesis of the previously created response art. This synthesis would act as a metaphor for my evolving professional identity throughout this time. The materials used for my response art were generally 2D materials, including oil pastels, marker, and watercolors. I began to adventure into 3D materials such as pipe cleaners used in the cactus piece on the top left of this slide. Unfortunately, due to COVID-19, I was no longer able to attend my internship and utilize the materials I had access to in the art studio. Once COVID-19 made it clear that I would not be returning to my internship site or in-person classes, my response art switched gears and became a reflection on this experience. Creating response art aided me in processing the loss of my internship, a graduation ceremony, and final quarter as a graduate student. The recurring themes in my response art included the following. Mandalas, or utilizing a circle as a container, water, growth, isolation, nurturing, anxiety or forward thinking, and reflection. I came up with these themes after reflecting on the imagery and emotions evoked within me when viewing the pieces. The bottom left image is a piece I made during the first week of April when it was clear I would not be returning to campus. The image on the bottom right is a piece made reflecting on my professional identity in the first week of my last quarter. This image falls into the themes of growth and reflection. My final piece was a synthesis of some of my response pieces. I engaged in a process that was inspired by my research around the Eld-1-Day process. I worked on this piece over the course of 3 sessions, all of which had at least 2 days in between. I titled this piece Growing Pains, which is a direct reflection of my experience in graduate school. I have grown drastically in both my personal and professional identities and merged them in some respect. This process was accompanied by rewarding but simultaneously difficult experiences. Creating the final piece allowed me to see that some pieces of response art existed simultaneously in multiple themes. I think this is a good reflection on how growth presents itself in many forms. My final project made me consider the importance of creating response art and how it propelled me forward in developing my professional identity. I implore graduate programs to continue utilizing response art in their education and incorporating a course about professional identity within the curriculum. I want to say thank you to my family, friends, and boyfriend Mark for their endless support throughout these past 2 years. I am incredibly thankful. Another thanks goes to my culminating project advisor, Michelle, and my supervisor, Mike. Thank you to all the art therapy faculty for your guidance and support. Hello, my name is Lydia Diorio, and today I will be presenting my culminating project titled Mirror Neurons, Interoception, and Empathy, How Interpersonal Neurobiology Can Support Dance Movement Therapy Practice and Research. Before I begin, I would like to thank my culminating project advisor, clinical supervisor, and teacher, Cynthia Jones, for her inquisitive mind and guidance throughout this project and through the duration of my graduate school career. My academic advisor, teacher, and program director, Dr. Christina Devereaux, for her support and compassion, and a collective thank you to the rest of my clinical and group supervisors for always challenging me to think more critically. I would also like to take the time to share some clarifying definitions. First, mirror neurons were discovered while studying the brain activity in monkeys in the 1990s. They are specific neurons that have been shown to activate while an individual is observing another engage in an intentional physical action. This activation is similar to if the observer were performing the action themselves. Interoception is a category of sensory processing responsible for interpreting information initiated by internal sensations such as heart rate, muscle tension, etc. The initial inspiration for this project came from reading about how experiences such as trauma can alter an individual's biological and neurological function. I had an idyllic wish to do a study focused on tracking changes in brain activity in individuals with altered function to see if dance movement therapy could produce lasting healing effects on the brain. Due to the inability to access necessary resources required to complete this type of project, I decided to refocus on finding a way to connect dance movement therapy to interpersonal neurobiology. One already established association between these two fields is the relationship between mirror neurons and empathy. The field of DMT has utilized this connection to develop the theory of kinesthetic empathy and the heavily utilized intervention of mirroring. As I began reviewing the literature, I noticed that there were discrepancies between researchers on the validity and accuracy of the connection between mirror neurons and empathy. The studies that have been conducted to support and prove the existence of this relationship present neuroimaging results that show mirror neurons are activated even when exposure to the intentional action is restricted to only hearing the action be completed or not observing a completed action. It is inferred that this activation means that mirror neurons are responsible for action understanding and imitation, which leads researchers to link these results to the characteristics of empathy and emotional understanding. However, the current criticism regarding mirror neuron research argues that due to the lack of specificity of neuroimaging technology and the lack of studies done on humans, there is no concrete empirical evidence to suggest that mirror neurons are connected to action understanding and empathy, or whether or not the mirror neuron system even exists in humans. These discrepancies led me to hypothesize that the frame of reference for mirror neuron research is too small, and that if there is any true connection between mirror neurons and empathy, then we would have to broaden our scope. Maybe it is possible that mirror neurons are part of a larger system responsible for emotional and empathetic understanding. This inquiry led me to the process of interoception. Throughout my research, I discovered that the biggest similarity and connection between these two processes is where they function within the brain. Both involve the limbic system, which is where our primary emotions such as anger, sadness, and joy live. Within the limbic system is the insula, which is the main reason these processes are connected. The insula is said to be responsible for receiving sensory information and transmitting related emotional content. There is also evidence to suggest that the insula also activates when receiving information from mirror neurons. It is this interaction between the interoceptive and mirror neuron system through the insula that is crucial and foundational for empathy and compassion.
Of course, there are limitations and gaps within the literature. The first being the dichotomy between information and inference. While our understanding of the brain has grown tremendously and empirical evidence and research continues to increase, there is still so much about the way the brain functions that is unclear. The same goes for research within the field of dance movement therapy. While we base our theory and practice off of credible information, much of what we do is still only supported through inference. The second is that we have to take into consideration how culture affects interpretation and definition of emotion. Emotional definitions are socially constructed. Therefore, we have to consider that all research concerning emotions must be looked at through a cultural lens. When it comes to scientific empirical evidence, there is a lack of specificity within the results due to the technological inability to conduct research on conscious, moving human beings. The necessary technology would require brain surgery, and consent can only be given if the individual already requires surgery. Lastly, there is a lack in collaborative research between dance movement therapy and interpersonal neurobiology. Since this information is at the beginning stages of development, I decided to complete a journal article manuscript for the American Journal of Psychotherapy. The purpose of this article is twofold. First, to provide additional information to further support and legitimize the connection between mirror neurons and empathy, which in turn provides credibility to the field of DMT and the theory of kinesthetic empathy and corresponding mirroring intervention. Second, it is my hope that this article initiates the process of integrating DMT into mainstream psychotherapy. Submitting my journal article manuscript to a peer-reviewed journal not dedicated to dance movement therapy is intentional, with the desire to enhance understanding, awareness, and applicability of dance movement therapy and advocate for its inclusion in the therapeutic milieu. Thank you very much for taking the time to learn about my culminating project. I am happy to discuss any related questions that may come up, and I look forward to future conversations.
Transforming Therapeutic Space with Light and Shadow Play by Gopi Shah, advised by Natalie Carlton. I began with the question, how do spatial elements and material use facilitate play and improvisation when using light and shadow? To help explore this, I looked at the Reggio Emilia approach to early childhood education, art therapy, and art-based frameworks to find the common methods, goals, and principles to help inform the therapeutic use of light and shadow. Light and shadow play is an established learning project in Reggio Emilia. Reggio Emilia is an early childhood education approach that describes light and shadow play as the natural or artificial use of light as a material to support active exploration and discovery for children. Core concepts of Reggio Emilia, such as valuing the environment and self-directed learning, can be integrated into art therapy frameworks when using light and shadow play. Reggio Emilia suggests the classroom environment should be considered the third teacher, in the sense that children learn from what is around them. For example, the architecture of the building, or even the arrangement and storage of objects in the classroom. For my culminating project, I documented this explorative demonstration of light and shadow play techniques. I began with exploring the use of a light table that was made from a picture frame and parchment paper. In using the light table, I observed the relationship developing between the light under the glass and the objects on top of the glass. I noticed a form of co-creation between the light and myself that was illustrating a story in the space. These moment-to-moment interactions with the materials allowed the story to transform as new information was being collected in the process. The interactions between the objects and the light source initiated the art-making process, representing concepts found in the use of installation art in art therapy, along with sand play. The art-making process became a form of improvisation or a therapeutic performance through moment-to-moment interactions between artist, material, and environment. The object placement was used as a method of mark-making. The dimensions of the frame and the moving marks contained within it created its own microcosm in the space. I discovered the reoccurring concept of creating a space within a space that was reflected in the use of installation art. Understanding the art therapy room as a unique space that exists within the context of a greater environment can invite the option of creating a retreat. It can also create a more manageable scale to help better understand the complexities of the greater environment in a way that feels both immersive and safe. My process moved from the light table to a series of stacked shadow boxes made from cardboard and parchment paper. These shadow boxes and the placement of objects in them represents a version of the concept of space within a space. Like the light table, the frame of each shadow box created parameters for unique and complex worlds to be shaped within them. I used materials that were already available to me and found myself constantly challenging my ideas of what would be considered a material to be used in art therapy. A reframing of everyday found objects and recycled materials was required in order to understand how they could be used in new ways and given new meaning. This allowed for focus on spatial consideration of object placement in this three-dimensional way of mark-making, where the space becomes the surface. Lastly, I experimented with a homemade projector to help expand my surface to the walls of the room. The projection was small in size, however, it allowed me to understand the materials and their potential for an immersive experience, as I was witnessing a transformation in my surroundings where these blank walls were now given color, texture, and movement. Turning the main lights off and relying on a few light sources immediately created a shift in the room, challenging any preconceived limits I had on the potential of this space. I found impermanence to be a theme in the process of mark-making in my space. Questions came up as to why there was a felt sense of comfort in the aesthetic of impermanence and why others may not feel the same way. Because of this, further exploration into the aesthetic of impermanence and its value outside of Western culture is required. Some safety precautions and considerations that are involved when using light and shadow play include establishing boundaries and discussing personal space, sensitivity to light, feelings that might come up related to being in the dark, and implementing grounding techniques to transition from the lights being off and the lights being on. This concludes my presentation on transforming therapeutic space with light and shadow play. Thank you to my parents, my brother, and the rest of my family for their support and encouragement. Thank you to my professors and my culminating project advisor, Natalie Carlton, for her guidance and insight that helped me develop my ideas. And lastly, I would like to thank my cohort. I feel grateful to have learned among individuals who have challenged me and inspired me. I'm grateful for the constant kindness and support that I've received from each of you, so thank you.
Light Painting within a Physical Rehabilitation Setting, Culminating Project by Philip Forrest. Light painting is a photographic technique which brings together movement and time, not unlike using a pencil, pen, or paintbrush. But it is not bound by the two-dimensional surface of paper or canvas, so it shifts into the realm of a more abstract art form, recording kinetic movement in 3 dimensions as well as over a period of time. Light painting is typically done with one of 2 types of light source, reflected or incident, but both types can be captured in the same scene as well. Reflected light painting is when the camera is focused on a surface such as a wall and the light is moved across the surface like painting with a brush. Incident light painting is when the light shines directly at the camera. This presentation will cover this type of light painting. A few materials are needed for light painting: a still, digital, or film camera and lens with user-adjustable shutter speed, aperture, and ISO settings, a tripod or other sturdy camera support, small light sources such as an LED pen light or pupil constriction lights, and miscellaneous materials such as tape, lightweight dowel rods, and string can be used for setting up as well as moving lights in creative ways. Participants engaging in light painting within a physical rehabilitation hospital are referred to as patients, as this is a medical setting. These patients have all survived an event leading to one or more of the following life-changing conditions: spinal cord injury, stroke or cerebrovascular accident, or traumatic brain injury. Some patients admitted to a physical rehabilitation hospital are there for other types of specialized support. These include patients who have an existing spinal cord injury or traumatic brain injury and are receiving wound care, as well as patients who have had an extended time admitted to an inpatient ward and require physical reconditioning after major surgical procedures, such as organ transplant, open heart surgery, or major tumor resection. A word on ableism. Ableism has been defined as a network of beliefs, processes, and practices that produces a particular kind of self and body, the corporeal standard, that is projected as the perfect species typical and therefore essential and fully human. Disability, then, is cast as a diminished state of being human. Ableism is pervasive nearly everywhere, as well as being a societal construct which creates an other of persons with disabilities. It can be seen as a physical construct everywhere, in buildings, in vehicles, in personal computing and communication devices, and in creative tools. Art materials used within medical settings are often of the traditional type: drawing, painting, collage, and to some extent sculpture using modeling clay. These materials have an inherent threshold of ability in order to use them. Patients in a physical rehabilitation hospital are often working to adjust to new levels of ability after their event. The new level of ability may bring with it lower levels of strength, stamina, control, and range of motion, which may make using traditional media more difficult. As with other art media, light painting can be tailored specifically to each patient, but one of its main strengths is that the patient embodies the media itself, and differences in strength, stamina, control, spasticity, and range of motion are not seen in the final image. It has other strengths as well, externalizing or separating the patient from their condition, allowing space in the darkness for less self-consciousness, and equalizing the media. That is, the patient's work is just as subjectively good as another person's light painting. Art therapist Edith Kramer described the third hand as a part of the art therapist which needs to be learned and cultivated. In the physical rehabilitation setting, the art therapist needs to be proficient and comfortable not only with the creative media, but also with the hands-on fitting and adjusting of adaptive and assistive devices and technology, and how to tailor light painting to each patient. In the following slide, the light painting process is demonstrated. 2 cameras were used in this experiential, one to capture video and one to capture still images. 2 pupil constriction pen lights were used handheld and moved for a period of just over a minute. The video seen on the left will show the motion of the lights. The images on the right show the duration of the 10-second exposure and the movement of the lights recorded by the still camera. Here we see light painting as it is being done. The video on the left shows the lights being moved by the participant, either by hand or held in adaptive devices. On the right, we see the images captured during each exposure. These images were 10-second exposures. The art therapist must be aware that between exposures there is a buffer in digital cameras. The buffer in this case was a 2-second buffer. Therefore, each exposure on the screen looks like a 12-second recording, although each exposure is actually only 10 seconds. Patients in a physical rehabilitation hospital have experienced events which may have been very traumatic. Clinicians should be mindful of patients' potential trauma history and approach this directive through a trauma-informed lens. Light painting is a creative activity that can be adapted to patient therapy as part of a co-treatment session alongside occupational therapists, physical therapists, or speech therapists. Flexibility and range of motion can be translated into creative mark making, proprioception can be turned into a visual image, and spatial awareness and memory may be shown through pattern repetition. Light painting is also an excellent opportunity for clinicians of all available creative arts therapies to facilitate in an expressive experience which can synthesize art, dance, music, and storytelling. Light painting, as well as phototherapy in general, are not commonly used in the creative arts therapies, possibly due to perceived investment in equipment and photographic expertise. As a result, there's very little literature specifically regarding light painting and its therapeutic use. However, a few clinicians have used light painting techniques in art therapy, notably Veronica De Benedetti, Juka Lane, and Christina Vasquez. While there is little literature supporting the use of light painting in art therapy, as a creative process, it could be worked into therapy sessions such as family therapy, couples therapy, and mental health outpatient, adolescent, and emerging adult therapy. I would like to thank Dr. Natalie Carlton, my culminating project advisor, the Drexel University Creative Arts Therapies faculty, my clinical supervisors, my internship colleagues, my art therapy cohort, and the entire 2019-2020 CAT cohort, my friends Dave and Linda Lackey, who have been an inspiration for me for many years, my family, who have always supported and encouraged me no matter how far we are from each other, Beth Ann Fraser, my partner, my love, and now my colleague, and finally, Jovi, Zila, and Leva. Again, thanks to everyone for your support and encouragement these last 2 years.
Hi, everyone. Welcome to our last Q&A for the 2020 Creative Arts Therapies Colloquium. This has been an amazing day, and I'm so excited with this last panel of graduates. And my name is Michelle Rattigan. I am faculty in the Art Therapy and Counseling program.
And I'm Dawn Morningstar, faculty in the Dance Movement Therapy and Counseling program.
And so what we're going to do is we're going to ask each graduate to say who they are and the title of our project, and then we'll get into some questions and answers. So Kara, can you go first, please?
Hi, everybody. My name is Kara Hurtnecki, and my project was called Building Multisensory Awareness in Arts Participation.
Excellent. Lydia.
Hi, my name is Lydia Diorio, and I presented Mirror Neurons, Interoception, and Empathy, How Interpersonal Neurobiology Can Influence Dance Movement Therapy Practice and Research.
Okay. Ying Jen.
Hi, my name is Ying Jen. My title is Self-Efficacy and Pain Management Music Therapy Consultant Model.
Ashley.
Hi, my name is Ashley. My project is titled Creating Response Art and Its Role in Developing Professional Identity.
Gopi.
Hi, my name is Gopi Shah, and my title of my project is Transforming Therapeutic Space with Light and Shadow Play.
And last but not least, Phil.
Hello, everyone. I'm Philip Forrest. My presentation is Light Painting in a Physical Rehabilitation Setting.
Excellent.
Thank you. Okay, so I have a general question for anyone, and you're welcome to answer this however you want, in whatever order you want. So how did the creative arts therapies play a role in psychoeducation of self and other awareness? You can unmute yourselves. That might be easier. We can really hear you better that way.
I can speak a little bit about that. When you say self and other, I think about the word relational or relationship. And the arts, any kind of form of art, is a different way to communicate. So there's aspects of verbal and nonverbal communication happening. And I think that's important in terms of psychoeducation, because there's so much focus in Western therapies on verbal communication and verbal processing. So in a way, the creative arts therapies brings a different sort of nonverbal dialogue, if you will, to this process.
Mm-hmm.
Anyone else have a thought about that?
Go ahead, Gopi.
I also think the elements of sensory exploration and even the idea of embodying what you're creating, or the concepts of what you're creating, can be applied to all the modalities. But from like a basic core sense, it's what is communicated through aspects of creative arts therapy.
Mm-hmm. Okay, wonderful. We're going to jump into some specific questions. The first one came in for Kara. Did you find literature specifically relating to the developmental importance of multisensory awareness?
Yes. So with my review of the literature, I kind of cast a pretty wide net as far as different disciplines that I included in this understanding of what it means to be multisensory. And as far as development goes, there's a lot of art therapy literature out there right now that focuses on art therapy with individuals with sensory, deficits or sensory processing concerns. And so there is some intersection with art therapy and those developmental concerns as far as like diagnosis is concerned, or how they relate to other fields like occupational therapy or physical therapy. I don't have a specific source that I can express here, but I, open that dialogue to anyone that wants to continue it afterward. So there's definitely literature out there related to that.
Excellent. Thank you.
This one's for Yingen. Who do you imagine is the target audience for this consultation?
I'm thinking it can be a lot of different people, like the nurse and also the individuals need the pain management, and also some music therapists just graduate something like that.
Great.
Because it's a very general introduction, and it can help with some specific area to help pain management.
Excellent. You were getting a lot of feedback on your project, and so people were curious about that. So thank you for answering that question. Ashley, we have a question for you. How do you see yourself using response art post-graduation as a professional for yourself as well as with your clients?
Yeah, thank you for that question. I definitely continue to see myself using response art. It made such a difference in my last year of graduate school. It really helped me grow and really reflect on the experiences I was having clinically. So it's something I'm going to continue to use as I move into the workforce, whether I do that within supervision or just on my own or both. I think it's really important. And I think I want to urge clients to, if they have time in between sessions, to make response art if they can. If those feelings are coming up again and if they really feel the need to, I think it's a really valuable experience.
Okay.
Thanks. Lydia, I have a question. So the title of your project is Mirror Neurons, Interception, and Empathy, How Interpersonal Neurobiology Can Support Dance Movement Therapy in Practice. What if we flip that on its head and ask, how can dance movement therapy practice inform interpersonal neurobiology research? Do you have a thought about that?
Yeah, so I think that ultimately that's kind of what I hope for. I think that the connection is still, there's still a lot that we don't know about it. And so part of like the project, I had this like big grand idea, and then it was kind of difficult to narrow it down. So something that I talk about kind of in my article and in my paper is that I hope that what this can do is really like build this collaboration between these fields, and not just in research, but also like in educational or training institutions as well, as a way to kind of support, our field as well, because that's one thing that, we're kind of missing sometimes is that empirical evidence. And so having each other kind of guide the research for both fields is kind of my hope right now.
Thank you.
Exciting.
Yeah. Gopi, we have a question for you. What was your process like discovering what materials you could use and their applications? I personally was really moved by the difference between when you were using your fingers and when you were using a mediator like a tool. But the question here is asking, what was that discovery like for you and trying to figure out what to use?
So I did kind of limit myself to the materials that I had readily available to me. Maybe limit isn't the right word, because as I was exploring the materials, I was able to discover the multiple possibilities that they had and the artwork I was able to create with them. So a lot of me discovering the potential that they had came from inviting myself to just play with them and follow some of the stages of play, and first exploring with them, observing the qualities that they had, noticing how they react to the light, and then taking bits of information from those observations to continue the aspect of play and learning and continue to create with them.
Great. You had some people who were wanting to do your process now after witnessing that today.
Yes, do it. Everyone, do it.
And were those coffee grounds that you put on the light box?
They were actually chia seeds.
Oh, okay.
Very,
yeah, I would have never have guessed that. I was thinking coffee, but that might be because I really need one right now.
Don't we all? Okay. Phil, this is for you. Since you mentioned there is less self-consciousness in the darkness, are there other populations you see this working with?
There is a very small amount of literature out there about this. There are several clinicians who are using this technique and similar light painting techniques with populations having to do with body image. Also, there is one clinician who is using this technique in substance abuse treatment. But mainly my process here focused on the physical rehabilitation setting, just because I felt that it could potentially be used with pretty much anybody who has any thought about basically any thought or doubt about themselves in a physical sort of way.
Thank you. And I think we have one final question. Do you want to ask that one?
So, we had so many different modules today. You all wound up in the module known as Sense and Being. But I also see that, it didn't really matter what module you were in per se, because there's so much cross collaboration. Like I see a lot of what was in this module is also very innovative as well. So we're wondering, how would you like to continue utilizing these methods and explorations from this project in your future work and scholarship?
And anyone can answer this question.
Yes, this is a general question.
This is open to the group.
I can contribute. So something that I saw in my research and also in my art experientials that I performed is that at least in my Western perspective, my Western worldview, there is a lack of vocabulary and language associated with certain senses. And I brought up that word in my presentation, ocular-centric, which basically means that vision is at the height of the sensory hierarchy in the artistic experience within like a Western paradigm specifically. So I feel like besides exploring my own sensory bias and dependencies, I'm interested in especially exploring how this relates to resistance to certain therapeutic methods, particularly art therapy, and working with that instead of against it. So really trying to explore through these different sensory lenses, what people's experiences are, and building a verbal language too, to be able to communicate about these through dialogue. So I think there is importance in the value of the nonverbal sensory being, and then the articulation of the sensory experiences. So my goal, I guess, is to continuing to understand my own dependencies and biases and challenging those and bringing them into the therapeutic space by approaching others to explore things with curiosity with their own dependencies, and see maybe how they could think about materials or process in a different way. So bringing that as sort of like a creative challenge almost.
Thank you.
Yes.
We have time maybe for one or two more quick answers. Go ahead, Lydia.
So something that I talk about is just really having the goal of pushing kind of DMT into the mainstream of psychotherapy. And I think that these kind of collaborations are really important for that, specifically when we're going to talk about language, finding ways to explain what we do and how we do it and why it works, and trying to find a way to build our empirical evidence to do that. Because I found something for me, one of the things that's most difficult is really kind of just explaining what I do and finding ways to show others, either within the field or not in the field, the validity and relevance and efficacy of what we do. So my hope is that continuing on with this topic, particularly of interpersonal neurobiology, finding like a very concrete way of making that connection and explaining that, and hopefully being able to expand the research to different populations as well, so that we can kind of see, how trauma affects the way that these systems, biological systems change, and is there a way to track change and healing once we implement, our practice.
Very well said.
Excellent.
Yeah. Any other final thoughts from our panel before we close this session?
They
Well
did
done.
it. They did it. So I do want to invite everyone to our closing ceremony, which will be in not that long. We're going to take a little short break and we're going to come back. If you can zoom in, this is for faculty, staff, and supervisors, professors, and all the students to zoom back in this Zoom meeting. We'll log out of this and then log back on, I guess. For a movement experience that we'll do together, we have a special musical guest. Would you like to come over, special musical guest, who will be joining us for our closing in a little bit. So please log back on to do that. We'll do an experience together. So congratulations, everyone in this group. Round of applause for you. Excellent work. And we'll see you all soon.
Can't wait to celebrate you.
Yay.
and go.
All right. Time to wrap up the day. Arun, do you have me on?
Sherry, you are live. You can go.
I am live. Here we go. Time to wrap up the day. Dr. Carlton asked if I would be able to reflect on the day and make some closing remarks. This exciting and unforgettable day. So I've been jotting things down all day, and I have to tell you, I am going to run out of superlatives. First of all, another deep bow and piling on gratitude to the leaders of this event today, Drs. Carlton and Ramakrishnan, and all of the people who work behind the scenes and on the screens to make this so amazing. To our student presenters and graduates, so professional. From the first and breathtaking presentation by Arisa Chan, through all of the modules, presentations, art, music, dance breaks, Q&A, right up to the last groundbreaking multimedia tech integration by Phil Forrest, you all have been riveting, inspiring. Many of you have brought into the center issues, populations, and aspects of human experience that are too often unseen or pushed to the margins. We have been moved, challenged, opened, and brought close to truths about our work. You have taken us deep, and you have brought levity, which is what the arts can do. The range of your work, topics, formats, approaches to inquiry, just stunning. Taken together, you move us forward and you instill hope. And you were popular. We've estimated that possibly as many as 200 people joined the YouTube channel today, and some for all of the day. And the exchanges on the streaming chat showed that you are each part of a strong global community of colleagues. You are also now about to enter another community, alumni of Drexel, alumni of the department. Please stay in touch. Please join our LinkedIn group. Please come to the CNHP ceremony tomorrow at 11 a.m. Eastern, when the Dean's Awards will be conferred. The world needs you. Please keep in and keep developing your amazing work. And now to give us an embodied goodbye together, I'm going to turn it back to Dawn, who will lead us in really closing.
All right, everyone. Well, I agree with everything Sherry said. It's been an incredible day. So I'm going to invite you, if you would like, you can stand up with me. We're going to do a little bit of movement and embodiment together. If you want to stay seated, you can do this seated as well. And Scott's going to play for us. So we're going to do a little movement together, and then we're going to have a little dance party, okay? So I want us to think about what inspired our work today and what inspired you to get into this field. So take a movement. We're going to reach up for inspiration. Reflect back on why you wanted to join this profession and study graduate school. Take a second and really pull that in for yourself. Find that inspiration and pull it in to the commitment to come and join graduate school. What inspired you to come to Drexel, to dig into this work, to deepen your knowledge into some stuff that you already know? What inspired you to come to Drexel, push yourself, really commit to this work? One more time. What inspired you? What in the arts, what in your life to come and join this profession? really bring into that commitment of why you're doing this work? How did you share it with other people, with your clients, with your friends, both as a group and individually? So where are you spreading these information and this passion that you have for this work, widely and specifically? What clients have you touched? What classmates and faculty, supervisors, and then individuals that you connected with? Really feel that, embody that wideness and the specificity of what we're doing in this work. And the last thing I'd like you to reflect on in a body way is your social and cultural location. All of this knowledge, all that you bring from your history, your culture, your self-knowledge, all that you've learned, and how can you bring that forth into the journey that you're taking to become a professional? So pull that back from your history, from your ancestors, and bring it forth. How are you going to bring that forth to the world? And just embody that. Beautiful. And I'd like to take this time, as we're talking about inspiration, commitment, sharing widely, and specifically reflecting and bringing forward, I would love to ask all of the art therapy and counseling students to come forward to the screen. Just art therapy folks, come on in and let's see your faces. And let's take a moment to honor those folks. Hi.
Faculty too, or leave this to the students?
This is just students right now, Nat. Thanks for asking. All the art therapy students, yay! Excellent art therapy students. And can you retreat? Let's have all of the dance movement therapy and counseling students come forward so we can each have a moment with you. Come share with us. Yay. Yes, I love it. You can make a dance, you can clap. And let's have you all retreat back. And let's have all the music therapy and counseling students come forth. Yay! And we can honor them, celebrate however you want. Excellent. And come on back. Now I would like all the faculty and staff to come in. So you can see your faculty and staff. Come in here, Scott. Come in here, Ms. Rattigan. And come back out. And the last group would be obviously all of the people graduating, the graduating class. All the art therapy, music, and dance therapy people, come forward so we can see you all and celebrate your loveliness, your passion for this work. And now you can just enjoy and celebrate together. Play with each other in the screen if you want. Find someone to dance with. Oh, you want to dance with me? I'll dance with you. want to share my heartfelt congratulations to everybody in this group for the wonderful work that you've done so far and the wonderful work that you're going to bring to the world. Hearts to everybody. Yay. So go forth and serve beautifully. Faculty, is there anything else anyone wants to say before we say adieu?
I'm out of breath.
Before Michelle passes out because she's out of breath.
Congratulations, everyone.
Heartfelt congratulations. There's work to be done, and you're ready.
Congratulations. The presentations were amazing. Excellent work. And all the energy and the work behind it, even more so. So thank you for sharing it.
So proud of all of you and can't wait to see what comes next for each of you and all this work you carry forward. And you are so ready to be leaders in our fields and push us into the future in all the ways that we need to. Thank you all. I can't wait to see where you go.
Michelle, did you want to say anything?
Where am I? Here I am. Please stay in touch. We are colleagues now, and we would love to collaborate with you. So we will not forget you. Please do not forget us. Much love and gratitude for every single one of you. Thank you so much.
And don't forget, you all can be supervisors in the not too distant future.
Stop it. Stop it.
Can't wait.
All right. So you may take your time to dance off the screen or just take another minute to share in this moment, and you can leave when you are ready. Thank you for sharing with us today. Keep playing if you want.
Whose cat is that, Phil?
Right. I think that's everybody.
Whoa, we.
Okay, Michelle fell on the floor. I'm not kidding. She literally.
Have we stopped streaming?
We are still streaming. I wanna know when I can stop.
Well,
good.
I think this is a humble ending, if there ever was one.
Yes.
Thank you. Stop streaming.